Good morning, friends. May I request everyone to take the seat? Thank you. So, welcome you all to this conference on robotic technologies and joint replacement. We all know that the knee replacement is one of the most successful surgeries, and that has been validated by almost all the studies. And that's why we see more and more studies and technologies coming in this field. Now, artificial intelligence, robotics, all these things have changed the way we live. And orthopedics has not been left behind. And especially if you see the results of knee replacement, the results are so good that people think that is there any need for newer technologies? Is there still scope for improvement? Well, our clinical experience shows that despite doing surgically everything correct, still there is a subset of population who is perhaps not so happy. We exactly don't know what's the reason. Maybe because the knee which we are replacing, we are not able to replicate the natural kinematics and all that. Is that the reason? The alignment, the balance. So all these things are there. Now, with CT scan and all the imaging things, we have a wealth of data here. And that's why more and more efforts are being made to recreate the natural anatomy of the patient and the natural kinematics of the patient. So the buzzword has moved from a mechanical aligned knee to a naturally kinematic knee, personalized knee. Based on the various systems which we are using, these terms have come. So this is an effort to understand all these things. Now this conference is more about understanding the knee kinematics rather than the technology. So there are different systems, and all these systems, they are a tool to help you achieve your goal. So we'll be hearing a lot about the words like functional alignment, restricted kinematic alignment, and I'm telling you, these are the key things which are to be understood from this meeting rather than QVIS or CORI or MECO. I'm so happy that we have faculty with great experience in these technologies, and they have come from different places, and as we move forward we'll be introducing them to you. With this, I hand over the proceeding to Dr. Sanjay Londe. Dr. Sanjay Londe is from Mumbai, and he will start the proceedings.
Very good morning to everybody. Thank you, Dr. Shekhar sir, and thank you all the esteemed faculty to be here today. So we are here for a learning process. It's an evolving process about robotics, about artificial intelligence, and more of our day-to-day practice on how we do our surgeries. So I'll be kick-starting the proceedings with the evolution of robotics in joint replacement surgery. So joint replacement surgeries are widely regarded as one of the most gratifying surgeries with excellent clinical outcomes worldwide. TKR surgeries have been present from the 1970s. The modern day total knee replacement is carried out either by the conventional method, the computer assisted navigation as we know from the 90s, or the present day advancement like the robotic arm assisted surgeries. So in the last decade, many advancements have taken place to maximize the function and the endurance of the patients. And with this ever evolving technology, we are at the cusp of the revolutionary change in the modern day joint surgery. So if we look back at the history and evolution of total knee, we have been always evolving. In the late 19th century, we were talking about interposition arthroplasty, pig bladder, nylon sheaths, anterior bursa of the knee. These things don't even come to our mind now. Late 1930s, metallic interposition arthroplasty took over. Campbell and Smith proposed the metal femoral molds after successful results in hip. McKeever and McIntosh were the ones who proposed the hemi for the tibia. Ferguson was the one who attempted resection plasty for Cox. Waldius was the one in 50s who proposed the hinges. Gunston was the one who introduced the polycentric knee plasty in the 1970s. In 72, Coventry introduced the geometric knee plasty. But once the 70s took over, what we saw was there was three types of condylar prostheses which were developed. It was the era of the modern day TKR. Ranawat et al. Developed the duocondylar prostheses, Coventry developed the geometric, and Townley developed the anatomic. So 1990s was the era of the CAS. 1997 the CAS took place with an image-less system. It was introduced basically for better positioning of the implants, better accurate post-op alignment, and through a precise and reproducible bony resection and ligament balancing. So over the years, this surgery has been divided into three groups. In the present day, in 2000s, we have the active robotic system, the semi-active and the passive. So this is still evolving. This is a branch which is going to still keep on evolving. Probably after 5 years, 10 years down the line, we are going to have some new things also. The first robotic application was started in orthopedic surgery in 1992 with the Robotic system in US. It continued with the Casper system in Germany. These were extremely complex systems, far out expensive, high maintenance cost, and with evolving time, they were not so reproducible. But now the trend of robotic surgery looks more promising and affordable in our country. There are 5 to 6 companies which have come up with various models and different aims, different patient outcomes, precise implant positioning, accurate alignments, and for increased implant longevity, for better function of the patient basically. So when we talk about robotics versus traditional CAS, robotic cutting guide tools have reduced the navigation time. The traditional CAS in the beginning which was used had different fixed cutting blocks, so they had more time run. Most of the newer robotic systems are active, semi-active, are image or CT based, so better anatomic duplication of the patient's knee. See precise alignment status post-op with sub-millimeter accuracy. Now the active robotics has come out with partial and full cutting modes. You can do the whole knee, and then you can also have provisions to freeze inside the joint. Once you're doing the surgery, you want to change something, you can have real-time gap checks. Intra, post-operatively, you can again check what you have done. You are safer with the emergency stop and manual robo guide. A learning curve is always present, but I think, I hope, and we all hope today that the future looks bright. So I've just started using the evolution myself with the QS. So I'm not going to go into the details because all stalwarts are there to discuss about it. It's the beginning of a new era. In the 1950s we had a static plan, in the 1990s the computer navigation, and in the 2000s the robotic assisted arm surgery. So why robotic assisted arm surgery? Probably the answer lies of an unmet need with the conventional procedure. We don't know, we are still evolving, but we hope that the things that 20% of the subset of patients who are not happy with a total joint replacement surgery are able to get their answers by better ligament balancing, better gap checks, better alignment, better reproducibility of the function. So robotics is basically bridging the gap with an innovation, with a tool, so that we can be better surgeons and we can provide better results to our patients. So why robotics? So in robotics basically, in this system we are using a CT scan to build a 3D model of the patient's knee, and with that virtual model as a guide, we try to make an accurate bone cut and insert the knee components very precisely without doing the errors which we could have done with eyeballing. So is robotic knee replacement a specialized surgery or a personalized surgery? Yes. Like I feel personally, in my short span, no two knees are the same in a same patient also. So each person has a different face, the different shape of the bone, a different deformity, a different new challenge. So this robotic technology may help you to have a better understanding, pre-operative planning, so what you can plan in before the surgery, you can execute it or probably change it inside the OT with the help of such a tool. So how safe is it? This robotic system, the active one which I have been currently using, is quite safe. I felt it, I have observed it myself. It's got a very good bone movement monitoring. Even if a slightest of movement is there, with the anesthesia of the patient also, some problem is there, the machine stops. It tells you that something is not right, the patient is moving or you are not doing the right thing. So that movement is detected, that threshold value is crossed, and you can stop in a fraction of a second. So what are the advantages over the conventional surgery? Advantage is for the future. We have done the conventional surgery, the chances of errors have been there, we have seen our complications. We try to execute difficult deformity corrections, better implant selection, and better consistent outcomes. So there are a lot of currently available robotic systems. I think all the users are going to talk about it, all the faculty is going to talk about it. So this system is basically has a main console with a system monitor and optical tracking system. The robotic arm has an operating software, a main controller, robotic arm, a cutting tool and an irrigation, and a surgical planning software. So what are the basic features we are looking at when we are talking about robotic system, whether it is any system? It's a precise pre-surgical planning which you want to execute pre-op and intra-op, a sub-millimeter dimensional accuracy, optimal alignment, checking of the gaps, various cutting methods. You can decide at any point of the time of surgery with this system whether you need to do the femur or the tibia first, you want to stop, you want to do a full cutting or a partial cutting. It all depends upon you. You can do that. We'll see today on the surgery. You can change the plan during the surgery. That's the most important feature, and it has an easy and simple workflow after some time. So benefits: simplicity, flexibility, safety and accuracy. All the details we are going to see ahead. So basically the advantages, what we are looking at the future is better documentation of our surgeries, what we did wrong, why we did it wrong, how better we could have done it, what were our gaps, what were our alignment. All these things can be seen. Post-surgery outcomes can be documented and researched much better, and with the less amount of handling of the tissue, of the jigs and of the all the handling which is there. I think these active kind of robotic systems can help after some period of time to reduce your running time in the OT OR, and also it will lead to less amount of infection if you can do it quickly and in a more efficient and a more precise way. Thank you. I think it's a kickstart, and I'll be very thankful to all the speakers today to make up this time and come here. Thank you, Dr. Shekhar sir. So I have installed it about 1.5 months back. So I have been doing the joint surgery for good number of years, and to be very honest, the learning curve was just the first 2 cases. I think the first couple of cases I had to adjust to the new way of working, the new OT setup, the new way we have to handle the robotic console. But once you start doing it, once you really get into the thick of it, and once you are really dedicated towards it, you understand the planning before surgery, intraoperative, you check everything. I don't think so that you are going to do lot of cases. You have to wait till 50 cases or 100 cases to really get the good feel of it. I think the first 2-3 cases were the main learning curve for me.
So later on you became time neutral.
I'm quite happy and satisfied after that.
So what I would say that
Yes, sir.
as far as accuracy and that is concerned, the alignment, maintaining alignment and everything, that can be achieved within 4 or 5 cases. But it took me almost, I would say 50 to 60 cases to get time neutral.
Actually, we have
Time neutral, yes, agree.
Yes.
So to start with, what I understand is that we presume that it will give better accuracy, it will give better alignment. Do we really need that kind of accuracy? We still don't know. We are just presuming that so about 20 to 30% patients are not satisfied. Probably they'll be satisfied with this kind of a. Am I right to understand this?
Personal experience. I have had certain patients before COVID. I had operated conventionally, and some patients had some cardiac issues. So at one point I offered a robotic surgery because they are not readily canal. And it is not a surgeon perspective, but majority of the patients, they said that their recovery and the post-operative phase was much easier, because I think the conventional surgery nowadays is about 50-60% balance, gap balancing, 50-60% major dissection. Whereas at least in the image-based robotic, you're almost doing pre-operative planning and doing about 80 to 90% of major dissection and hardly any soft tissue needs. So probably there is some benefit in the early recovery and less pain in the post-operative. Well, that's what the patients are saying. Surgeon independent. So we need the soft tissue balancing is very much. Yeah, because
Sir, may I add something?
Yes.
It's not going to change the basic principles of TKR. It's like telephone was a success, then only mobile came. It doesn't mean that telephone was wrong. But we know what are the fallacies of that, and now we have something new. So it's going to add to our understanding of knee replacement. So it's basically help you to optimize and quantify everything rather than everything eyeballing. So the fight is how to get that satisfied 80% to 90%. We don't know the answer yet. We are trying to improve it, and future will tell us because once we understand in a better way, we'll execute in a better way.
And certain complex, I will show you in my lecture, certain complex.
Yeah. So in complex cases, will the level of constraint will be reduced by using robotic surgery? Suppose there's a complex case we are planning and severe varus deformity or planning, the level of constraint of the implant to be used, will it be decreased if we are using a robotic surgery? Or that will be again on table, pre-operatively it won't help much?
I think the level of constraint can be decreased definitely with robotics. See what happens if we use our conventional jigs, then there are some limitations. Okay, it will take fixed amount of cuts. Though systems have this thing that you can modify it, but the options are very limited. Whereas in robotics, the options are totally unlimited. Like in some cases where we see, just take an example that the patient is having valgus, and we know that in most of the valgus cases they also have hyperextension. Okay, so at the time of planning as well as balancing, we make sure that our distal cut is minimal. So it's not that I have to take 9 millimeter from the medial side. It can be even just 5.5 millimeter or 4.5 millimeter. Okay, so that I can reduce my extension gap. Okay, so all those options are there which can really help you in decreasing the constraint. So there is a possibility that if you use it, if you do it by a conventional method, you will end up using a spacer of say around 14 or 17, whereas if you plan it properly, you can manage it with just a spacer of 9. So that's also a decrease in the level of constraint. So similarly, I feel that if you have all the data beforehand, so what it means that you are doing resurfacing in the actual way where you are just trying to recreate the anatomy, and you are also having an understanding of the soft tissue laxity or tightness. So accordingly, you can either fill up the joint with more of metal or less if you want. So that's how it's.
Here comes the role of what alignment philosophy you believe in. So, with that kind of big varus, if you want to achieve a mechanical alignment, definitely you will either cut more or you will release more. But with these systems where you know how to execute it in a proper way, you can put tibia in 2-3 degree varus, you can even put femur in 1 to 2 degree varus, that will automatically open your medial joint space, so your releases automatically goes down, and hence the level of constraint will go down. So basically robotics is the way how you want to execute it. Planning platform is same like navigation, but execution is the biggest difference.
I think we can continue having this discussion. Let's move forward to the next one.
Thank you. Thank you. Thank you and good morning. Thank you, Dr. Shekhar, to have me here. And the 5 minutes of the initial introduction went to a heated discussion. So everywhere it's, should we really put so much of capital investment and buy the robots? Is it really worth? Or is it just another marketing gimmick which comes in the market, stays for a couple of years and then vanishes away? So let me take through my experience. I started this robot 2 years back, just after the first pandemic. So I saw this robot in Korea. So I was contemplating on which robots to buy. So I was not somebody who was jumping to buy one robot just for using it as a marketing tool and then do that. So I did my research for a couple of years, roamed places, and then decided, okay, let me zero it onto my robot. When I saw this robot, I felt I need to understand more. Then visited Korea and then couple of times. Then decided, okay, this is the robot which I'm going to settle for. So why image-based robots are important? In image-based robots, does an active robotic is safe? Is it that is it soft tissue friendly? Is it that an active robotic can be little bit stressful for the surgeon on the table? All those doubts I'm going to clear. So this is where I come from. And any successful knee replacement, symmetrical flexion extension gaps, up to you, whichever alignment philosophy you want to follow. good soft tissue balancing with accurate bony resections. Whichever technique you want to use, gap balancing or measured resections, up to you, and good component fixation. And the whole idea is proper implant position and allow the chosen alignment to follow. And the alignments can be either ways. You can be a mechanical guy, you can be a functional guy, you can be a kinematic guy, you can be inverse kinematic, you can be restricted kinematic. So the machine should allow you to do any of the things. So it should not restrict to one philosophy or alignment philosophy. The good thing about all the existing available robots is it allows to do all the alignment philosophies. So imagine you, suppose next 3-4 years the study does come across and say functional alignment is good. Imagine measuring 2 degree, 3 degree varus and tibia on conventional instruments. They are really not very, it should be difficult. And putting couple of degrees, as Dr. Mukesh was telling, to the varus distal femur, it's difficult to measure all those on conventional jigs. Suppose we get kinematic as the way to go forward. So imagine doing calipered measured kinematic. Not going to be that easy with conventional instruments. I think our robot should be answers for all of the things, whether you do kinematic where you do femur first and then decide the tibia varus, or you do inverse kinematic where you do the tibia cut first depending on your MPTA angle and then start out with the femur. So whichever alignment philosophy, the robot should help. And most of the available robots and even the good navigation systems can allow us to do most of this alignment philosophy. We really don't know whether mechanical is going to stay for a long time. Should somebody switch over to a functional alignment? Is that the kinematic alignment philosophy guys comes across with 15 years, 20 years survival study, then we may slowly move on to kinematic. But any robot, any capital investment you do now should be something which allows us to do every alignment philosophy for the future. So alignment does matter. So technology adoption is on the rise, and so whenever a institution decides to buy a robot, it's of a investment definitely to the hospital. So we need to see what is the capital investment, sit with the management, discuss what are the realistic goals of buying this robot, how much it is going to add value to the system, to the hospital and also to the patient. Is it just that it is just one-off investment and then just see we want to increase numbers, or is it that we want to buy the robot for genuinely we are interested in technology and taking it forward? These are the clear-cut discussion one has to make, sit with the management and then take it forward. So any robots, like why I chose a CT based or image based robot, I know definitely we'll have good discussions with imageless guys also, is it should help in all three planes. Whenever we put the implant in, it should be guiding you coronally, rotationally and surgical, all planes. So these are the types of robots: automatic, semi-automatic and passive. And this is how the evaluation navigation relate to the robotics. As again Dr. Mukesh was saying, mobile phones came because the telephone or landlines were always successful. So image based navigation was started first, but because of the difficult CT scan and difficult segmentation led to the innovation of imageless navigation system. Imageless navigation success, though there are enough data to prove that it has always improved the alignment, and one of the doctors said for 2-3 degrees alignment, is it really worth to invest a machine? So, but yes, all the studies which are done on navigation, either they are put on par with the conventional surgeries or better. There are no studies, hardly I don't remember any, or I've not read any studies where the navigation has shown to be detrimental than the conventional surgeries. So this success led to imageless robot. So imageless robot, we have Corey or Navio from Smith & Nephew, we have Wallis from Depew, then we have Rosa from Zima. And then the imageless robot, again success led to image-based robots, because now you have better CT scan, better segmentation, which leads to the image-based robot. So we have two image-based robots in the market now. One is QVIS, that is from Curexo, Korea, that's Merrill, which is in India, and then we have the Mako from the Stryker. So these are the differences between image and imageless robot. In an imageless robot, image robots, you have a CT scan, which helps to know the definition of axes in all three planes. You get a preoperative planning, and then there is boundary control. In the Mako system, the boundary control is basically on the haptic feedback, whereas in the QVIS, it's more to do with something called bone movement monitoring. One of the negative factors about the image-based robot is cost of the CT scan. Then we have imageless robot. There is no need for CT or MRI. Logistically easier for the imageless robots. It's my cons. It's not that with an experienced and all these cons may not be there. See what happens is when we map the knee, it's difficult to map the posterior half of the tibia and posterior half of the condyles, especially in very difficult varus or flexion deformity knees. But anyway, it takes the shape library. It already has an inbuilt shape library from which the shape is taken out, but the studies have shown that it is as close to the native anatomy. And there is increased acquisition time, but with an experienced guy using an imageless robot, this should not be an issue. For me, yes, intraoperative planning can be little bit time taking and cumbersome because we need to see multiple factors and then go ahead with the planning. Issues with the rotational alignment because we are not the markings of the epicondyles are not cross-checked, whereas in image-based robot, whatever epicondyles you do mark the registration points gets compared because you have a pre-plan in the CT. That gets compared with what you do on the peroperative. So these 2 points gets compared, so the errors can be highly minimized. So what can be the sulcus point for you in the CT scan which you have measured, and the sulcus point on what you do on the table, those 2 registration points gets compared. So by comparing the registration points, you're basically taking out the errors of human marking. And tibial rotation and slope, because since you have a CT scan, you can always switch on the unaffected side and see what is the better slope. The rotations can be well defined because you have the PCL center at the back and then the medial 1/3 of the tibial tubercle in the front. Malleolar marking is not required because this is again taken from the CT in an image-based robot. I'm not critical about the imageless system. It's just the differences. But for an experienced hands who have been doing regularly, image or imageless robot should not make any difference. So these are the current available robots in the country. So what I am using is the QS joint. Then we have Meko. The first 2 are the image-based robot. Rosa is from Zimmer, imageless, and Navio from, now it is Cori from Smith & Nephew. Now we have Depu Velis. And the next robot which is not available as of now in the country, but it's available in the US, is called Omnibot. It is from the Korean company. So this Omnibot is again an imageless system. The first 2 are the image-based system. So QS is a 6-axis articulated robot, if you see in the first slide, and then it's a CT based. It's based on optical tracking system. So basically we take the points, it's point picking. Some of the systems are surface mapping. I think Cori has surface mapping, and Mako, QVs and Rosa has point picking. Either way, it's measured resection, gap balancing up to you. It's an automatic robot. So there are 3 parts. Configuration, there's a console, the one which captures the knee anatomy, and then the machine. For the second one is a robotic arm which is used to mill the bone, and the third is the pre-plan or the software. So basically, if patient who decides to go for surgery goes through this process, CT scan done, CT scan, the surgeon, see now I came here, I'm going for a live surgery, I planned, it takes about 3-4 minutes for you to plan, the pre-plan. So the CT is done, loaded on the system, the planning is done by the surgeon 5-6 minutes before the surgery. The surgical saved plan is put it on the robotic pen drive. Surgeon goes like any other image or imageless navigation. He marks, opens the knee, puts the femoral trackers, tibial trackers, marks the knee, and markings gets compared with what you have marked on the CT marking in the pre-plan. Errors are shown of marking. If you are satisfied with your marking, you proceed with gap check. You can check the gap at 0, 30, 60, 90, 120 by stressing the knee and in neutral position. Then you can either choose 2 pathways, measured resection or gap balancing. If you want to do the measured resection and gap balancing are the ways to do it, but alignment philosophy is yours. You want to be functional, functional. You want to be mechanical, mechanical. You want to be kinematic, kinematic. You want to be inverse kinematic, inverse kinematic. You want to do restricted kinematic, up to you. The alignment philosophy is yours. Measured resection, gap balancing, up to you, whichever philosophy. Once the cuts are made, again you do the trial check and then proceed with the implantation. So this is the pre-plan video. So you have markings on the, once the CT is loaded, you mark, there are 4 things: coronal, sagittal, axial and 3D. So you mark the hip center, knee center, epicondyles, posterior condyles. See, the green line is the posterior, this is the transepicondylar axis. The maroon line is the posterior condylar axis. So basically you see the image in all the 3 directions. You see how the implants are fitting mediolaterally, anteroposteriorly. You see how the cut surfaces are. All these are seen before surgery. Before you go to the theatre, you go see all these things. Suppose you have a defective tibia where your medial defect is there, you can keep your tibial cut little bit more bigger, so that, and you play on the femur. So you can do either ways. If the tibial defects are less, you want to put the best metal in, and then cut less tibia. If you want to have more cut on tibia and then try to oversee the component, up to you. You see all the surfaces. On the tibia, again, you mark the hips, tibial center to the ankle center to take the mechanical axis. Then you measure give the rotation, you see the slope. After you do all these things, you are basically choosing a component which is as close as to the native bone in all three directions, ML distal, ML anterior, anteroposterior, and then you fix, basically you are shape matching the femur. If you are in between sizes, you can play with the sagittal offset. After you plan it, both your femur and tibia, you can, that is the plan last summary. This gets loaded onto the robotic software. The good thing about this is you don't have to stick to your pre-plan. Your plan can change, be flexible on the table. You can downsize your femur. You can change in whichever axis you want. Once you have done, then you go to the surgery. This is the benefits of CT scan, so image-based robot. All the three axes, transepicondylar, posterocondylar, AP relations to each other. Choose whichever you want to do. You want to choose PCA, up to you. You want to choose transepicondylar axis, up to you. There are advantages of PCA, there are disadvantages of PCA. In an ACL deficient knee, the medial femoral condyle, the posterior femoral condyle medially can get elongated, start digging on the tibia. So there can be false PCS also. Transepicondylar axis is good, but unfortunately they are difficult to mark. But here we have a system which compares the epicondylar axis, what you do on the CT versus what you mark on the tables. So those two gets compared. So you have minimal errors. Then the implant position, basically you're shape matching your femur on all three surfaces. Then you're checking the patellofemoral rotation before surgery. It minimizes instruments, minimizes in assistance in OR. Slope of tibia is better appreciated because you have a CT. You can go on the unaffected side and decide the slope. Virtual surgery before you go to the OR. Tibial rotation is well defined. Sagittal implant positioning, like either you can flex or extend the components of the femur. You don't have to do the hip rotations. You don't have to do the malleolar marking, especially tough, short, obese patients. Sometimes with the wrapped ankles, the malleolar marking might be tough. This is avoided. So comparison of the CD marking done in pre-plan to the surgical time marking gets compared. Sometimes missed talus or ankle lesions, especially when you have done a hip knee ankle X-ray. Most of the time when you see the X-ray, sometimes a small osteochondral lesion on the ankle might be missed, but here, because these are our findings after 1500 surgeries. At least 10 cases in 1500 surgeries which I would have easily missed on a plain radiograph. The missed talus lesions on the CT is seen because you're going to get the hip knee ankle CT scans. So these are the rotations. Again, if you see, the green line is the transepicondylar axis, the maroon is the PCA. It gets compared. Think that the line down is a tibial cut, imaginary. You can drop two lines from the green line. Just see whether those two lines are equal. It just helps us to know whether your rotations are correct. So this is the condylar symmetry. If you see on the right side, I am changing the implant size from bigger to smaller size. You can see how much the posterior gap opens up. If you feel that I want to go for a lesser size because it gives a better condylar symmetry, if you feel that will cut more posteriorly bone, you can flex the component so that it cumulatively increases the extension gap. So it also tells you to what amount of distal cut, how the implant is positioned posteriorly. Do you underhang? Do you overhang? Suppose for a 9 mm D femur, my implant is over projecting the bone. For a E implant, 7 mm, and still can I go up? So all this, how much distal cut to how much implant at the back can get appreciated. These are all before surgery. This is the validation of the CT points, which I am saying femur registration. So this is what I am marking on the table, and then this markings gets compared with what I have already marked on the CT scan. So this helps to know if there are any human errors of marking are taken out. So this is the femur registration. So once the femur registration is done, you see now basically the orange is something which I have marked on the CT, blue is here. See, my markings are a little bit different than what I have marked, especially the epicondylar points. You can remark it if you want or re-register it. So this is the surgery of the QS. It's just 1 minute video. If you have time, I can just show. So this is the surgery of the cleavage. So basically femoral tibial arrays, then you make your markings, see for the errors of marking. Once you are convinced, then you go ahead and see the soft tissue balancing, soft tissue, how the knee looks with the whatever of bones your pre-plan is, using that implants, using that distal cut in the pre-plan. It shows you how your knee looks both in flexion and extension. Then you connect the patient's body to the robot, make the cuts, and then before the implantation you do again that, see the trial, and then if required you do the releases. If you want to minimize the release, you go for the functional alignment. If you want to believe in kinematic, go to kinematic. That's up to you. System gives you the opportunity to do. So these are just the I think some of the speakers will take forward much more detail. I'll just skip this. So why? Because my topic is why CT scans? Why CT scans? So placing implants in flexion of 2 to 3 degrees alters both the flexion and extension gaps and leads to cumulative change in the gaps. So if I flex the suppose if I am in between sizes between D and E, D looks the better metal to go in, but by putting D, if I feel that I am cutting more posteriorly, I can always flex the component by a couple of degrees. This opens up more extension gap, reduces the posterior gap, but the amount of proximalization of the femur by cutting more distal cut can be avoided, because by flexing and extending you are not proximalizing the joint line. So this is the sagittal offset videos. How you plan on the table when you see now. When I'm trying to give the flexion component more, flexing the component more, my distal cut increases, my posterior cut decreases. These are all the intraoperative options. So you can change, you can internally extrude femur, you can flex and extend the component, you can view the varus on the tibia, varus on the distal femur. That's up to you. So these are the minimal instruments and minimal assistants. This is the minimal assistants or tissue restriction. This is the pre and post op, some of the X-rays. So our experience has been more than 1,500 joints now. So in all three alignments we are good. Implant is seen 360 degree. I don't subluxate my tibia because all the cuts are made in one static position. Hardly any bony recuts are made. Minimal soft tissue retraction, no saw, skive or smooth surface, whichever balancing pathway, titrated soft tissue as per requirement, whichever philosophy you follow. So this is our experience. If you see the duration of surgery and length of stay, the length of stay in the hospital has decreased. The duration of surgery, yes, 12 to 13 minutes more than the conventional surgery, but the duration of stay in the hospital has reduced. And these are the changes which we have made from pre-planned to per-operative modification. If you see, we have changed hardly 5% of the femoral sizes. Our recuts have decreased only in 3%. Tibia changes 60 to 40%. Like tibia, I cut, but I size the tibia in my cases. Rotation we have changed in 10%. Sagittal positioning in 5%. So infection rates are similar because I am a navigating surgeon, so I compare with the navigation surgery. So there has been a reduction in the rehab sessions because the cuts are made in one static position, and then now the recent one of the papers has come, robotic TKR versus the conventional. They have compared the CRP and IL-6 before and after surgery, and robotic TKR so definitely far better. So these are the alignment philosophy: 95% mechanical, 5% functional. These are the current studies, and these are the papers. These are the papers. And these are the points to consider. Surgery cost has increased by 3.5 because of the consumables in CT scan. Surgery time has increased by 12 to 13 minutes. Infection rate similar to non-robotic TKR. Consumable usage, robotic draped and infrared beads. Pre-planned time 4 to 5 minutes. Increase in OT personnel 1. Capital investment for the hospital. There's one navigation pin breakage, no fractures. And so robot does what you say, but you are the brain. Ultimately, you have to drive it. It is not a replacement to conventional surgeon. A good conventional surgeon can become a good robotic surgeon, according to me. A bad, nobody should train on the robot immediately. First, we have to do conventional surgeries. A good conventional surgery can become a good robotic surgeon. And long-term studies are awaited in our robots, and which we are coming out in a 2-year study now. And thank you so much.
Any questions?
See, my femurs have become much better than what I was doing in conventional navigation because I have the posterior condylar symmetry before I go to the surgery. See, it's like two ways. You manipulate the metal to get the soft tissue, or you manipulate the soft tissue to get the best metal in. You can decide. If you want to go for the most appropriate femur, sometimes you may end up cutting more bone, and if you feel that that is inappropriate, you can cut your tibias less. So for me, my femurs have become one less than what I was doing before. Like a D femur has become C femur, a E femur has become D femur. This gives good metal in. So I am reducing the metal volume, but not at the cost of removing more bone. I am playing more with the sagittal offset of either flexing or extending the component, going for the most appropriate metal in. This gives good rehab post surgery because by reducing a metal by one size also, a D to E, the amount of metal volume what it goes, the curvature reduces. This leads to better arc. So for me, it's with getting the shape matching the femur, which has helped me to get better arc of motion. And since all the cuts are made in one position, there is no tissue retraction in terms of subluxating. Imagine you have to subluxate the tibia and then make a cut in a very difficult varus or FFD knees. The amount of soft tissue release, you go around the corner and then subluxate. The amount of power required to subluxate. You only subluxate when all the cuts are made, the volume is created. When the volume is created, the pressure is less. So this helps in lesser soft tissue. But yes, all this has to be documented. Only one study has come. We are putting across our study. We are doing CRP and IL-6 2 days before, post 24 hours, 48 hours, 4 weeks and 6 weeks. We should come out and publish. And then the early trend shows that the IL-6 and see, again depends on, it's very difficult to shape these studies because the deformity has to be shaped. The obesity has to be, the BMI has to be shaped because all multiple factors. But as a clinician, to my eyes, I feel my robotic surgery patients far better in terms of pain medication usage and rehab sessions have decreased.
So one question is different.
No, no.
Asking is not from a technology point of view. My question is how many unsatisfied patients we are decreased by this?
She said the word unsatisfied depends on how the surgeon feels happy about his patient. So,
Dr. Jain, there are studies. I think he's asking in terms of translating whatever we are doing into patient satisfaction. There are studies, if you see, there is better patient satisfaction. There are studies in the literature now. Long term, they say it's almost the same, but initially, there's better patient satisfaction. Yes, it is there. Yeah.
long-term studies are definitely, but
They are there. On this very aspect, what you are asking, patient satisfaction, it is there. If you scan literature, yes, it is there.
the initial 2 weeks, 6 weeks, 1 month, 2 months, 3 months, definitely there is an edge of robotic over the conventional. The long term again has to see, is that the mechanical alignment is the way go forward, or is it that we have to switch over to functional? Nobody knows. Like many of the centers are still, robotic centers are doing functional, most of the centers are still with mechanical. So we don't know whether mechanical is going to really go away and then we are going to go to functional. But there is so much dilemmas in the global literature itself. But overall in the first 2 to 3 months, if you see the recovery part, I think much better than the conventional. And as a surgeon also, when you are implanting, you definitely feel good when you have done a robotic surgery versus a conventional. You see as a surgeon how the implant, how the knee moves in terms of how the laxity, mediolateral laxity, anteroposterior laxity, you feel good. It's basically, conventional is not incorrect or something I'm saying. It's just that even if you're a busy surgeon, you are made to sit and spend 5 minutes before you go to the surgery. So you are preparing at least in the mind 3 minutes before you go to the surgery, even if you're a busy guy, because the system makes you to spend 3 minutes. So that eyeballing is ruled out because you are knowing the component sizes before you go to the theater, and all your mind you know, okay, I want to play with these two sizes. The size what I've chosen is the best, but that if I have to manipulate, I can manipulate. So you get the best metal in by playing with the soft tissue, or you play with the metal and get the best soft tissue balancing. That options is yours.
I think just to answer your question, we have submitted our paper to EFORT Congress in Vienna, and we are presenting there. Early sort of first in the hospital as well as in the first 4 weeks, the number of analgesics the patients are taking in the robotic versus conventional, the analgesia requirement and morphine equivalent dose has definitely gone down, match to match. because we don't do all the patients robotic. Depending on their cost sort of affordability, we either offer a conventional or a robotic. So, and the cohort of patients is almost similar. But as you're absolutely right, at the end of 1 year, probably we should see how many patients have achieved a forgotten knee status, and whether the robotic patients have achieved forgotten knee status in a better way than the conventional patient. And I think high volume centers like Dr. Chandrasekhar probably can have a look at it, at the end of 1 year, whether the patients have achieved a forgotten knee status.
I think now
status we should see.
we should go on to the next talk. I'm getting warnings from the organizers.
I think
He's showing me
some
the watch.
change in the presentation. I think I'll request Dr. Sujay Bhattacharya initially to talk about the preoperative planning and workflow, followed by Dr. Nikhil Verma, the tips and tricks of registration. When they are loading for it, what the question you ask is very relevant. If somebody can definitely document at the end of 1 year how many patients are achieving the forgotten knee status, and if it is better in robotic, probably that answers the question. It is very early. Very early. But at the end of 1 year, correct. At the end of 1 year, which is a sizable time, and we can have a match-to-match comparison.
But there are studies. Scan the literature. Can we translate whatever we are doing into better patient satisfaction?
One of the speakers said that the robotic surgery started way back in 1992. With 30 years. Do we have any data now?
Not much. Because original robots they were very cumbersome.
So, when will you place, when did we start the newer technologies? 1 year, 2 years? How much period has gone now with the newer technology?
Not more than 5 to 7 years. If it's volumes we are talking, studies and volumes.
These will be so different. Even the results of different kind of robots will be different.
Oh yes, this is how science evolves, isn't so?
Correct. So we even do not know the different kind of robots, what kind of results they will.
No, Jan, that's how science evolves. No, you do something and study.
Technology will keep on improving. So you have to jump at one point. Now I-14 is there. You know that I-15 will come next year. So either you wait for I-15 or you take I-14.
Yeah.
In fact, surgeons like Dr. Ashish Singh can have a look at their patients actually, conventional versus robotic, and at the end of 1 year, at the end of 2 years, is there any difference?
We are doing studies, FJ, Forgotten Your Score, Knee Society Score, and the WOMAC Score. They are definitely better for the robotic patient. There is no doubt about it. There is less blood loss and more decision and planning.
See, one thing is there. We don't open the medullary canal, isn't so? Which is very, very important. One of the very, very important aspects in this whole scenario is opening up the medullary canal. Blood loss, inflammatory markers, everything matters. Chances of pulmonary embolism, all sort of things they matter. And we are doing one side robotic and one side non-robotic because we don't want to move the robot to the other side. So we are watching that also.
So it's a prospective randomized clinical control trial.
Right.
Surgeon sends patients.
Yeah, that's right.
Deformity.
I'm not putting it, no. See, we can always learn from our own experience, isn't so? For my own learning, isn't so? Whatever I am doing, yeah, that's right.
It's a prospective.
Those who are not paying for robot, we are offering them. Yes, please.
So good morning. Good morning to all. Sorry.
Just a minute. Let me introduce Dr. Sujay. Dr. Sujay is a orthopedic surgeon and he does robotic surgery at Sarvodaya Hospital, Faridabad.
Are we using robots for surgery here? Then our answer is yes, sir. can give you better of all the queries, what I have done. Already proven, and I am very confident now. Before I decided whether I can go ahead with these surgeries with this patient. I never abandoned any of my surgeries because it's a image based. So I get the things done the day before. Right now, the couple hours before also, I can decide whether I could complete the surgery with active robot or not. So things are very easy. So a couple of queries are there. What is the benefits of this robot? Simple things I can do, whether you have to decide first what exactly type of surgeons you are. You are a major dissection surgeons or a gap balancing surgeons. So you don't go and, you cannot hit here and there. You decide first. As per that, you balance the knees before your surgeries as per the CT scan. If you're a CS surgeon or PS surgeon, you cannot change. You decide yourself whether you do go for PS or CR. If a CS surgeon, so definitely you have to follow certain things. If the PS, also some little bit of changes are there. So once you've decided this, I'm a major resection surgeon, I'm a PS surgeon, or I'm a gap balancing surgeon or CS surgeon. As for that, you planned it and go ahead with the surgery. It's a beautiful process and very safe, even with a little bit of movement of the patients or even yourself also. That machine stop working. So I never come across any complications even in the soft tissues. Fortunately, unfortunately, I had 2 fractures of the femur because maybe in the initial stage because of the female patients, osteoporotic patients, and there was that time I was the first or second case putting the distal femur pins, the array, femoral array. We had some problem. Right now, after that, we changes the size of the pins. We are not using right now 4.5 mm pins. We are little bit of 2.5 mm pins to hold the femoral array. But what fractures we had come across only the femoral sides. So little bit I'm really thankful to Shekhar already explained little bit of this. Explain the pre-operative workflow. So same things will also tell Dr. Sanjay. So I'll restrict myself till before going to the surgery OT. So how we plan with this active robot is the city based. So it has already been discussed what is the advantage of the robotic TKR, and I still there is a technology always better, but you have to accept the technology. You cannot be in the first go be a robotic surgeon. You have to first be a good conventional surgeons. You should know each and everything about the TKA, then only you could be a robotic surgeon. Robotic surgeons, robot is very good in experienced hand and very bad in inexperienced hand. If you want to have the robot just to have your business more, then it will be a disaster, I'm telling you. Only things you should know every cut. If you cut the distal cut or more, you should know what will happen if you take 1 mm distal cut. You should know the consequences if you flex the knee, flex the femur. If you reduce the one to get the flexion gap, there are 100 ways you can do it. Robot have a precision, you can do everything. So you can have a 1 mm distal cut, 1 mm proximal femur cut, everything you can do with this robot. But you should know what will happen in that cut. If you are not very clear, you take that, then it will be a disaster. Then it will be a gap balance, then it will be open up this and that. And another thing is that what is the advantage of this doing a robotic TK? You are very sure you have done the right thing. But everything you can check over here. So gap balance can check. So you can take the flexions, the full extensions, the mid flexions. And if the compartments are equal in both the sides, because it is a quantitative data you can have. It is not a qualitative data. It is not your assumptions. Yes, I have done the right job because your colleague is there, your fellow surgeon is there, he is telling, no, sir, there is a little bit of medial gap is there, is opening on the medial side. But in robotic surgeons, everything is document-based, evidence-based. You can say it's 11, 10, 9 with all the gaps. You know,
Hello?
your colleagues cannot say, no, sir, there is because there is a documented evidence-based. So there is a beautiful things you can say. You are very confident. Post-op patient will because you know you have checked all the gaps. You know all the patient is balanced with the extension flexions and mid flexions. So there is absolutely no cause of instability because most of the unsatisfied patients, the questions are asked. The most of the patient, I think the instability, the most common cause, balancing. While we climb up the stairs, there is a little bit of I cannot hold on my knees while I go for the stairs up. It means the mid flexion instability. Mid flexion instability mostly occurs when there is a difference in the flexion extension gap. That mostly happens because we are mostly oriented on the 90-degree flexion and the extensions, but we don't bother much about the mid flexion. That is the most important thing. Mid flexion instability.
Hello?
That will give the
Check
patient
the
satisfaction while the patients go for the stairs up and down. So these are other things we can come across, we can check with this robot. So
Hello.
bad knee balance, it is already been.
Hello.
Things, bad
Oh.
knee balance, the patients, unhappy patients, these are the reasons. We want to close all the reasons behind
Food
it.
कोई पहना था क्या ना?
We want to offer.
Somebody will make.
So what does it do? So intraoperatively we component gaps with a fine adjustment with this OTS, optical tracking system we can adjust. So there are basically two steps. First step we get the CT scan done with the image based, and the second step is you know the flexion extensions gap. Another thing is that when you get the CT scan done, you know each and everything about the anatomy of the patient. Most common problem even if you go the conventional case is the imbalance, APML, anterior posterior mismatch. We are very confused sometimes. Conventional surgery, I've been doing it for more than 13 years, but recently for the last 1 year I've been doing the robotic surgery. But before that also I've been confused. Whether the size A or size B, size D or size E. So mostly the Indian female patients there is a mismatch, APML mismatch. But here, if you know your APML mismatch, you can plan yourself, will you go for this 1FL down or up. If you cut more in the posterior, if you got the more posterior lateral, then there is a more in the flexion gap, then you have to reduce the proximal tibial gap because you have to balance the extension side. In that case, you have to take more of the distal cut. So you plan before night because you know the patient is having this APML mismatch. But in conventional surgeries, you do not know exactly whether the patient is having APML mismatch. On the table, you are very busy surgeons. So suddenly you will come across, on the first go, you will decide, okay, I will go for this 1FL down. Then at that time you have to calculate yourself. You are going in the one down. You don't know what will happen. There is less posterior cut. With the less posterior cut, you have to take more of the proximal tibial cut to make the flexion gap. And if it is more of the proximal tibia, then you have to reduce the less distal cut. So that thing should be calculated on the table when you are taking the conventional surgeries. But with the robotic surgeries, image-based surgeries, you know the before surgeries. So this will be the problem. I have decided. So I'll go for that. You know everything is very clear. Then you can check in the OTS systems, you can check everything and go for as per your plan. So the first step is the robotic systems, you go to the CT scan as I explained, then upload in the GA planer. It takes only a couple of minutes, depends upon how many cases. Right now I am not doing it, even all the colleagues, even my technical support, he is not even a doctor, he can do it. So it is very easy. It is not at all needs your that much of qualification as these are. Even your guy who is supporting you, he can do it. And even my team, all members can go for the GA planner, they can go for the CT scan done. Because see, there will be reduces the chance of error. Everyone they get, because initially we used to check myself, but two guys check, then I check. So everybody will check that there is a chance of error will be less. So only I will be the only guy to go check the CT scan, I'll go for the surgeries, then maybe chance of error is there. So all your members can check it, is good, then you can reduce the chance of error. At one time you can you cannot go, you can just go into the OT and you will check.
Gloves change
the planning and you can go ahead with the surgeries. So after putting the J pillar, these are the components, the marking of the tibia. Just you have to, very easy to do it, it takes only a couple of minutes to do it for this. So this is the femoral condylar centers, this is the medial epicondyle, this is the lateral epicondyle, already discussed Chandrasekhar for this. Now, you have to decide you go for this gap balancing or this the major dissection. That you have to plan, as per that you have to plan the planning of the CT scan. So these are the points you have to make it out. Now, this is the femoral side. This is very important, the femoral side. So most of the times it is very difficult to make it out what exact size will fit the femur. Because in the QB systems, you can gap 1 mm down. If it is D, you can come to C, you cannot go to the E. So if it is in between, better to go for this up, because on the table you can come down. But if it is come down, and if you feel that it should go up, they cannot go up. So there is a system that should have some more things, because I think we already, this maker of this robot is a QRX company, so we have to talk to these guys. So it is better you can go 1 mm down or 1 mm up is better. But these systems right now having 1 mm down, so if it is in between, so it is better to take this up over. So you can see the 3 level. It is, you can see this is the foot end, this is the head end. This is the foot end, head end, this is AP, this is the posterior side, this is the medial, lateral, all sides you can see. So sometimes narrow femur is sometimes is very important in the Indian female, Asian females, because most of the Asian patients, I think, even in the conventional surgeries, You can come across many of the makers have this narrow femur. Narrow femur is sometimes is very good. But this system sometimes is narrow femur because what happens, there is a medial lateral, there is a wide, because anterior posterior these are very narrow, and there is a narrow flange. This sometimes what happens, it is exactly fits on the medial lateral, but it is the overhanging on the medial lateral proximally. So sometimes this happens. So the makers whosoever is a narrow femur, it is better because many of the times it is overhang. In that case, you have to come down to the lower sides. So it is difficult sometimes to make it out on the CT scan. So in that case, it's better to go 1 mm down because on the table you can check and you can come down 1 level down. So this is another beautiful thing. You can check. See, this is the overhang. You can make it out if it is the overhang or not. You should not overhang either in the medial side or lateral side. But it is not exactly in all cases like what I am showing you right now. Because many of the cases sometimes it will be a doubt. It is overhanging either in the medial side or lateral side. But in any case, we don't want overhanging on the medial side. It will be of overhanging on the lateral side.
बोलता हूँ तब दबाइए.
And I am telling you, you will see the precisions. It says overhang, it overhangs. It's really good, these systems. These are perfection. I'm telling you.
Finally,
Many cases we have seen it. What it exactly
Final,
says, it exactly duplicates in the OT tables. So we get it. Now, in the table we decide whether we'll accept it or not. Seeing I'm a seer surgeon, so for me it's good because I'm not taking the boss cut. So for me it is little bit of good. I can little bit of manipulate my femur. But who was a PS guy, little bit of difficult because if you want to really manipulate the femur, then you have to manipulate the whole box cut. I think that will be little bit difficult in that circumstances. So this is a femoral incision, say the RMS, root mean scar, or what I mean to say that, because what exactly you have to replicate on the table. So you can find it out how much error is there. Either root mean square or is less than 1 is always good. Then you are more nearer to the what you have marked in the city. So this is the things you are marking over here. Same things you will replicate on the table, and you will get the initial root mean square error and the final root mean square error. If the root mean square error is less than 1, it means you are more nearer to your planning. If you are more nearer to the planning, then your balancing and your everything will be the more nearer, and you are like much less time. It will be very easy to balance the gap. So everything will replicate. These are tibial axis. These are different points. Tibia is not the big issues. Only tibia will find out the bone error. What error exactly, how much bone loss is there. And you have to prepare the. You have to plan it whether you want to get into this cut the bone loss. I think that most of us we don't want because we can rebuild the bone loss either with the screws or anything you like it, or you can do it as your choice. So tibia is important because you can go up and down, doesn't make any difference. But issue is that the bone loss. If there is a bone loss, then you have to prepare to put a screws. Whatever you want to build it up, you can go ahead with that. So in that case, the tibia slope, in by our seer surgeons, I keep little bit of most of the natural slope, but at least 6 to 8.
पहले मार्किंग जब करते हैं थोड़ा पीछे रहो. ये जो स्क्रीन है ये और वो आना है, दो आना है. स्क्रीन और स्क्रीन. ये कैमरा कब यूज करना मैं बताता हूँ. ये रहेगा, ये कांस्टेंट रहेगा, उसके अंदर ये आएगा. सो जब मैं मार्किंग कर रहा हूँ तो ये और ये आना चाहिए. ये अंदर बिट. कैन यू डू इट एंड शो मी नाउ?
Same thing, the registration, it will also
picture
match on the table. So your RMSE will give you the exactly size. Now the root base score. Now end of the day you get this. This is the things you will get. You can get everything over here. So this is the distal medial 7.2, 7.3, posterior medial 11.6. See, if you build that.
Stop karo.
So I have taken the PCA posterior coronal axis 3 degree. So your choice, what type of surgeons you are. No, you are a gap balancing technique, or you are not going with the kinematic alignment. In kinematic alignment, you want to make equal. The posterior distal medial, distal lateral exactly equal. In that case, you have to rotate. You have to rotate the femur. Now, is where you want. I feel
अभी उल्टा करो पहले.
Follow the best
पहले जैसे करो.
of the TKA.
अभी पहले जैसा था ऐसा करो. मैं जब बोलता हूँ चेंज करना.
If you are a kinematic surgeon, you will go ahead. This is your choice. Because I am a gap balancing surgeon. I feel that the conventional whatsoever we are following since long, I will follow that, but I will follow the execution should be perfect what I exactly planned it. So I want exactly, I don't want to put my femur in the rotations, I don't want to put my femur in varus. If at all I want to put my femur, I will better to put in the valgus, that's only 2 degrees, not beyond that. If I want to tibia, I will put the 2 degree varus, I don't want to put my tibia in valgus.
बेटा किसी को बोलो सर को
So this is the things we will
टूरने
get
के
it now
टाइम
in
45
reference
मिनट्स
to
होते हैं, सर बोल रही कि
on the
पहले खत्म.
now this is the thing. This is the mismatch. This is the most
क्या?
common issues we'll come across
क्या?
even in the conventional surgery.
हाँ, क्योंकि वो टूरने के टाइम पड़ता जाएगा.
Robotic surgery, best things is that you know beforehand you have a ACL mismatch where AP is maybe more or is vice versa, ML may be more than AP. So you have to plan accordingly. You have to
Helmet
plan. You
account,
have
okay.
to exactly
Helmet.
you should know in the brain
Helmet
what
account,
exact
okay.
problem will come across. Then you can plan everything. If you rotate the femur, more flexions, you know that there will be less amount of flexion gap and more in the extensions gap. Everything you should know. It is very clear. So these are the permitted values. So I have no argument because the kinematic guy will say no. We can put the femur in the varus and we can put the tibia in the valgus. So I have got no objection in that because that depends on the alignment, what alignment exactly you want. Because I want a gamble in this surgery, this is my permitted range of movements of my implants. I don't want to go beyond that. Whatever I will balance, I will restrict myself in this. So in that gap balancing technique, I will balance only the lateral half of this knee. So when I replicate my CT scan, so see the beautiful thing, when I replicate my CT scan, CT planning on the robo, so this is the thing. See, I keep the acceleration 3 degree, the varus valgus 0, flexion extension 0, acceleration 0, valgus 0, slope 7 degree because I'm a seer surgeon. So this is the extension now, this is the things, now I have to balance. So this is the gap. This is the gap with the extension gap 3.6 and 3.7. So I will plan to go for this balancing on the lateral half. I will not balance on the medial half. But medial half I will go for the release.
Spinal है पाजी.
I balance it like this.
Spinal
How
है.
I balance? I take the reduced
Spinal है ना?
axis rotations. Rotations is the 1 degree rotations. I put the femur in the 2 degree valgus. Flexion 1 degree. Tibia varus 2 degree. Slope 7 degree. Okay. So right now is given 7 because it seems the patient is say this is the 5 degree, 4 degree flexion extension and limb varus valgus 5 degree, and I feel that the soft tissue because robo doesn't consider the soft tissue. That is your skill.
बेटा
That is your
जब मैं
skill.
पहले बोलता हूँ
Your
सारा
skill
ओटी एक
will
बार
be
दिखा सकते हैं.
revised,
हेलो.
little bit improve with the robo, but you cannot get extra skill with the robo. So if you have
इनिशियली उनको पोजीशन दिखाने के लिए सारा ओटी का एक सेकंड वीडियो दिखा सकते हैं आप. इसको घुमा सकते हैं ना. सिर्फ ये तीनों कैसा अलाइंड है वो दिखाने के लिए, पीछे से नहीं होगा तोड़ देंगे. मीन्स आई वांट देम टू शो this where the robot comes from, where this comes from.
This is the final cut. This is the bone cut.
सिर्फ पोजीशन, हाँ सेटअप कैसा किया, हाँ कर दो. जब मैं बोलता हूँ उसे मूव करो तो इधर से मूव करके इधर दिखा के
I think this is quite comfortable. 2 mm up and 2 mm down doesn't make a difference. It's always fixed with this 9 mm poly. So you can see this is a limb 5 degree. It depends on 1 degree varus. If it is 3 degree varus, it's acceptable. So this is the things you will get it now. Now you are very confident enough. You have get exactly match. This is the beauty of this robo. I think that is you are very confident. You have done the right job because you have get a very good balance. Gap, flexion, extension gap, and even the everything. The whatever you have taken, it is under the considerations of the what I've been practicing for the long time. Another thing is that everything you can check. Every cut you have taken in this robo, you can check. You can make it out whether you have taken the 4 mm cut, whether it is 4 mm. You can check it and you can reproduce it. So we give the patients like this. These are all these things. So documented. We documented everything. So whether you have balanced the gap, that is you can do only the image-based robo, I suppose. Thank you.
Thank you, Dr. Sujay. Thank you. Thank you, Dr. Sujay. I think they are ready with the live surgery. We'll have discussion during the live surgery or maybe later on, but they are waiting for us to give a green signal. So may we request Dr. Sujay to come here, Dr. Muhammad Hasil, Dr. Nikhil Verma to take over as for moderation. Okay. They are ready.
Hello, good morning.
Good morning, Dr. Chandrasekhar. We can hear you. Dr. Sujay will take over from me now.
Okay. So this is a right knee replacement we are doing, and pre-op is a varus knee, and this is how the OT setup is. So on the right side, when I'm doing, the robot comes on the right side. So this is the right side of the patient, the robotic.
अभी इधर दिखाइए. Now this is me standing on the right side of the patient, and then there is a navigation camera on the other side. उधर दिखाओ बेटा. That is the navigation. So basically the navigation camera is on the opposite side, robot is on the same side of surgery, and now for the time we have opened the knee, abhi idhar dikhai. So now we have done a midline incision. We have put two pins, one for the femur, one for the tibia. Tibial pin is put outside the wound, about 10 to 12 centimeter below, and if you see the directions of the pins are not perpendicular, just we tilt it caudally so that we get more working space for the robot here. And on the femur, again in the metaphyseal region on the medial side, this has two advantages. One, it lies within the wound, then it is metaphyseal. Third is, it also acts like a tissue retractor for me, so I don't have to retract the medial structures. First few cases I was putting in the superior part with two separate stab incisions. That also can be made, but this is also okay. Now over the last 200 cases we have switched over to the metaphyseal femur pin. So now I'll start with the marking of the femur. The CT is already planned and given and loaded on the robot. Now now I'll mark the points on the femur. Then I compare my markings with the CT marking and see for the error. Then I mark on the tibia, compare the error. After the markings are complete, then I see the knee using the values what I have given. I have given some values: distal medial, distal lateral, posteromedial, posterolateral. I think I have chosen a size E femur. So using those markings, it will give me a chart, balance chart. How does the knee looks in extension and flexion at 0, 30, 60, 90, 120. Then we will decide whether we have to do a mechanical or a functional. Either I do mechanical or functional. My experience with kinematic is not there, so I don't do kinematic knees. So now let's go ahead with marking on the femur.
Dr. Chandrasekhar,
Yeah?
good morning. Dr. Sujay is here.
Yeah.
Can you ask you a question, please?
Yeah.
Let me know how do you plan these your femoral pins, whether it is a bicortical or unicortical, and the width of this pin.
This width of the pin is 4.5 diameter.
Okay.
And then the second cortex is touched. We don't pierce the second cortex. The first cortex go through, second cortex touch, and then just transfix to the bone. Don't pierce the second cortex. Whereas in the femur, it goes 3/4 into the metaphyseal area. We never go outside the 3/4. We get bigger, longer purchase in the metaphyseal area, but sometimes osteoporotic bone you need to be careful. So if the bone is very osteoporotic, we dig more. So we have more femoral metal pins in the bone so that it doesn't shake or it doesn't vibrate while we are cutting.
Dr. Chandrasekhar, I hope that you want any problem putting the pin like this, because anteroposterior you are putting the I think medial lateral.
Yeah.
You are putting the medial lateral, and thing is that in that case also you have no problem with the calibrations with the robo, I suppose.
No.
Thank you.
Initially we started with the diaphyseal pins. Now over the last 200 cases we have shifted for the pin to be in the metaphysis. Two advantage: one is the pins falls within the wound, no more extra stab incision. Second is it also acts like a soft tissue retractor to me on the medial side. So let me go ahead and start marking with the femur now. So some points. Yes, please. So these are the registration points. Yes, please. Picture in picture. Give me that picture, please. Yeah, one more picture. Usko, yes, please. Yes, please.
He is matching all
Yes,
the
please.
points what he has taken already.
Yes, please. And yes, please. So now I am seeing my registration points. So if you see, the blue is mine, green is what is marked on CT. This is the medial epicondyle for you. This is the lateral epicondyle. If you are in the same axis, it's okay. Either anterior or posterior, doesn't make a difference. Difference is when blue is up and green is down, or green is up and blue is down. That means your registration points are not so great. So these are in the same axis. If you see both the medial side and the lateral side, they are almost in the same axis. You don't need to overlap them, but same axis gives the same rotational component. So for these 2 points are important for me because I'm aligning my knee on the transepicondylar axis. The other points maybe in the same sphere is okay. You don't have to, the same plane. You don't have to literally kiss each other, but these 2 points are important. Okay. So now I go for more points on the distal femur. So these are the registration points. Just go ahead. Now I start marking more points. This is the distal medial first. Yes, please. Yes, please. One minute. Yes.
Initial RMSE, it
Yes.
should be less than 10. Is good.
Yes.
Is a 5.0. Initial RMSE,
Yes.
root mean square error.
Yes.
Is a 5. It should be less than 10.
Yes. Yes. Yes.
You should not match what your
Yes.
CT is saying. Then why
Yes.
CT? If you are not
Yes.
matching.
Yes.
That is the root mean square error.
Yes.
If it is beyond within 10, is good.
Yes.
Acceptable. Exactly
Yes.
you cannot match.
So now I have
We
marked
can do it
distal
because-
medial. I have marked trochlear
You have to
point.
take
I have
multiple times in
marked
that
the
case.
distal
Less than 10
lateral.
is acceptable.
Now I am going and marking the intercondylar area. Yes. Yes.
See, that is
Yes.
a root mean square error, means
Yes.
what you have planned
Yes.
and what with the executions. That will be, but it doesn't affect much.
Yes.
But more you are accurate, is it less
Yes.
than 1 is very good. If it is more than
Yes.
1 also, sometimes it's very difficult knees, very
Yes.
deformed knees.
Yes.
It should be more than 1. It shouldn't be red color.
Yes. Yes. So basically now I have marked distal medial, distal lateral, intercondylar
But you
area.
don't-
Now I
osteopathy
am
don't
marking the
accept-
medial
don't-
side of the
don't
knee. Yes, please.
Don't recognize
Yes, please.
the osteopathy
Yes,
in the CT
please.
planning. Yeah. That's
Yes,
why
please.
unanimous you are doing, no? That's why you're considering the root mean square error.
Yes, please. Yes, please.
More closer.
Yes, please. Yes, please. Now I am marking the anterior surface. Yes. Yes.
Sometimes
Yes. 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 So all my femur marking. Yes. Collect better. So all my femur markings are done. Now you see the root mean square error down. Can you
Yeah.
see it's 0.65.
This
Anything
0.65.
less than 1 is good. So basically my CT markings of the knee versus the surgeon markings, the error is less than 1. 0.5 is luxury, less than 1 is highly acceptable, more than 1 you can remark it. So now since I have done the femur, now I go touch the verification points. Verification points are those points when you move the knee from flexion to extension or extension to flexion. You just test these verification points and the robot will automatically know the knee or the femur in that spatial configuration. Yes, please. Yes, please. Yeah. Yes, please. So now I go ahead with the tibia marking. Next. So femur is done. Now I go with the tibia. Yes. 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 So tibia again I see the registration in terms of medial and lateral. They just have to be in the plane surface. Same surface. You don't have to touch each other. Suppose if the depth of penetration is more, then you can vary little bit in the varus valgus. But that again, once the cuts are made, you can have a verification probe to see. But it has to be in the same surface. So I do only see these points because, as I've already mentioned, I make the tibial cut by the robot or the milling. Sizing I do myself. That's why I'm not bothered about the tuberosity points. But anyway, but for academic completion, you have to see all the points once. So now go ahead with more marking on the tibia. Yes. Next. So now you mark the medial tibia. Yes. 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 So interspinous is over. Now lateral tibia. Yes. 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 Now medial tibia. Yes, please. Yes, please. Yes, please. Yes, please. Yes, please. Yes, please. Now tuberosity. Yes. 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 Now anterior surface of the tibia. Yes. 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 Okay. Yes. 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 So all. Yes. So all the markings on the tibia is done. Again, if you see the down error, is 0.43 if you see there. So 0.43 is good. So we go ahead and do the registration points. This is the verification points. Yes, one on the medial side, one on the lateral, yes, and one on the anterior. 1 second. Yes, please. So now, as you know, I have not I have not removed any osteophytes. Now, if you want to remove all the osteophytes which are accessible to be removed, can be removed. You can remove it later also, because since I am going to do measured resection, I am going to balance my lateral numbers, and and also I am going to do mechanical alignment. So I am going to keep my medial side tight either ways from the starting point. So these osteophytes can be accounted on the later stage also. Now I move the knee and show you the graph. So this is my flexion gap check now. So now I am gap checking now. So if you see on the lateral side, in the extension, using the numbers, I have given distal medial 9.1. If you see the screen को बड़ा करो बेटा. Increase the screen. That screen को बड़ा करिए उसको. So now if you see the top corner, I am externally rotated 2.5 for the PCA. My varus of the distal femur is 0 degree. इसको बड़ा कर दीजिए. इसको बड़ा कर, इसको screen को. So I am checking the knee in extension now.
Dr. Chandrasekhar, please bring that screen fast.
Yeah.
This is very important.
इसको छोटा कर दीजिए. बेटा, इसको छोटा करिए. So now if you see the screen on the top side, externally rotated 2.5 to my transepicondylar axis. Varus is, I am taking the distal femur varus up. If you see the top corner, mechanical axis, that's why I am taking 0 degree. I have kept the component at 2 degree flexion. E is the femoral component which is chosen. Distal medial cut is 9.1 if you see the box, and the distal lateral is 7.5, and tibia proximal lateral is 6.4, minus 1.9 means to the defect I am cutting less on the medial side. Using these numbers, it is giving 9 if you see the blinking, 8 and 9, and the 3 on the medial side. So if I go ahead and cut, the established gaps will be 18 on the lateral side, 13 on the medial side. So this is, and if you see down, the limb is 2 degree or 1 or 2 degree flexion extension, varus of 7. Now I am giving the valgus stress and seeing. So the limb is correctable from 11 or 12 degrees to it is correctable to 4 or 5 degrees. With the valgus stress, almost the flexion extension deformity is going. Capture this now. So now if you see, I have established down, if you see the blue lines, 8 and 4, 8 is extension lateral, 4 is extension medial. Usually what I do for this 8 and 4, I add 2 millimeter, one for the burr, 0.5 on each side, femur and tibia, and one for the cartilage, 0.5 on femur and the tibia. So 8 is basically 10 for me, 4 is basically 6 for me. Now I see the knee at 30 degree. So it's a varus, I am giving a valgus stress, almost neutrally correctable. Now I am seeing the knee at 60 degree. Again, if you see the screen 18 and 20, I am giving the valgus stress. See, if you see, I am giving the valgus stress, it's 19 and 15. Now I am giving at 90 degree, again as valgus stress, so it's 17 and 15. So now I capture, I know this is basically a varus knee through and through, and the amount of deformity after, so once I cut, the deformity is opening on the medial side better. So what I do is now I check the knee at 90 degree. Check please. So these are the gaps now. At the 90 degree with the stress test, on the lateral side if you see, the blue one on the lateral down, it is 8 and 8. 8 and 8 is 18 and 18. Add 2 to it, it's about 20 and 20. 2 I add it on all the corners, extension medial, extension lateral, and flexion lateral. This 2 is added, one for the burr, one for the cartilage. That is 0.5 on the femur, 0.5 on the tibia for the burr and the cartilage. So if I go ahead with this cut, the established gap on the extension lateral and flexion lateral is 20-20. And on the medial side, it will be about 16 and 14. But these medial side numbers don't bother now. I have not removed any osteophyte. So once all the cuts are made, the medial first I'll remove the osteophyte, check the gap, then titrate the soft tissue depending on the need. I am going for a measured resection technique. In the measured resection, balancing the lateral numbers and the medial tightness, I have kept it tight. 14 and 12 is tight. I am not trying to equalize this number. Suppose if you are a functional alignment guy, what you can do is just
Go to the femur part. Femoral rotate. Go to the rotating origin. Yes. Go to varus. See, now I am trying to give 2-degree varus on the distal femur. See how the points changes. Just concentrate on the extension medial and extension lateral. It's 4 and 8. Give 2-degree varus. One more. Yes, one more. See, now it became 7 and 4. Can you see? So, but you can give distal femur 2-degree. Now go to tibia. Tibia implant. Tibia rotate. Varus, rotating origin. Now give tibia 2-degree varus. See, now by giving 2-degree varus, you are opening the medial space. So basically I have tightened the lateral space and opened up the medial space. With this I can increase my tibial cut 1 or 2 degrees. Functionally I am at 4-degree alignment. So this is functional alignment. Distal femur 2 degrees, tibia until 3 degrees you can go, acceptable 5 degrees. By doing this, you are trying to reduce the soft tissue release on the medial side, and with that you can get away with the surgery with only osteophytes. But even in this also, you always try to keep the medial side tight, because if you try to keep the medial side loose or equal, the moment you remove the osteophytes, you might be in a soup where on a varus knee or on the medial side legs. So always, even in functional alignment, keep your medial side little bit tight even with varus, because give some tightness for the osteophytes when you remove when it gets released. So this is just to show I have given the tibia to 2-degree varus, I have given distal femur to 2-degree varus. This is basically to show how the numbers change. Now I am established gap on the lateral is 15 and 16. I can go ahead and cut tibia 1 or 2 mm more. So that will establish a 18 mm gap. But now if I want to reduce my soft tissue release, I can do functional alignment. But I'll keep it simple. I'll go for mechanical alignment. I'll remove all the varus. This was only to demonstrate, and then I do the mechanical, I do the soft tissue titration as per the need. So now you give valgus for 2-degree. I am giving valgus because I am reversing it now. Better 2-degree valgus then. Now I am reversing and getting back to neutral now. Okay, finish. Now go to femur implant. Femur rotate. Rotating origin. Then give valgus 2 degrees. So basically I am not giving valgus, I am trying to make it neutral now. So now if you see the numbers on the lateral side now, after this is, now check, valgus de diya 2 degree, finish, now check karo beta. Capture. So this is my flexion, medial flexion lateral, now it's extension medial, extension lateral, check. So basically yes, check pa. So with all the 3 stresses I have seen, give me the pen now. कोई artery देना बेटा. So if you see now, zoom out and then give this. I am balancing my extension lateral numbers. Show me this now. So I am balancing my extension lateral and इसको बड़ा करके दिखाना. So I am balancing my lateral numbers here. If you can see, this is extension lateral and extension flexion. The medial extension medial and flexion medial I have kept it tight, because once I remove the osteophytes, this will open up. The soft tissue release I will take care. If flexion medial is tight, I can nick the MCL anterior fibers. For X, or if the tibia can be downsized by 1, I can open up more flexion space in the medial side. For the extension medial, the osteophyte removal and the posterior medial corner release. So I am basically keeping this varus of 0 degree means I am mechanically at 0 degree. I am not giving 2 mm or 2 to 3 degree of distal femur varus. My tibia is also varus, so I am cutting perpendicular to the mechanical axis. So basically I am aligning this knee in a mechanical alignment, and the medial side tightness which is available here. See the medial side tightness here, I am doing releases myself. So am I good to go now forward?
Yes sir.
Yeah. Now go to the next slide, next. So there are 2 options. You can choose gap check when you do full surface. Beta iske upar dabao. Full surface. In full surface, in a measured resection concept, so all the femurs and tibial cuts are made and the robot goes to the side. Then you do the gap check, release the osteophytes remove the osteophytes on the medial side, release the soft tissue, titrate, and then go ahead and implantation. This is measured resection technique. In measured resection technique, I am doing mechanical alignment today. Next, go to the extension surface. In a case where there is a very difficult varus with a FFT of 15-20 degree, you feel you need to oversize the femoral component, then you can do, or in very tight knees, you do the distal femur, proximal tibia, put the knee into extension, remove all the osteophytes, balance your extension, then put the knee into flexion, then call the robot and do the 4-in-1 depending on whether you want to oversize the component, whether you want to undersize the, or whether you have to come one down femur, you can do. So you have two options, one is measured resection, one is modified gap. I am going for the measured resection. Go for up beta, full resurface. So I am choosing this full resurface now. Now once I am happy with the numbers, so what I did, CT scan is done, loaded on the robot. Then I marked the points on the CT in the pre-plan. Then I again came and marked here, compared those 2 points. Then I was happy with the point marking. Then I did the soft tissue balancing, choosing the measured resection, choosing the mechanical flow. Now I am going ahead and connecting the robot to the patient body and going with the cuts. Am I clear?
Yeah, exactly. Chandrasekhar, please carry on.
So now I am connecting the robot to the patient's body. 2 metaphyseal pins has to be put. If you are very averse with the metaphyseal pins, you can use a clamp. So, but I use a metaphyseal pins. So, one on the femur. These pins need not be parallel or perpendicular. Just they have to buy some good bone away from your box cut and your distal cut. And the femur, femur pin is I put. For the tibia, I put 1 finger on the tuberosity, 1 on the fibular head, go in the center, make a small stab, and then reach the soft tissue point here, and then reach the bony surface and purchase the bone. This also, since it's a triangular bone, I try to direct more posteriorly because I get more purchase. No need to parallel or match. These are just fixation points. Up to you to purchase the bone, no need to be any symmetrical way. So now I am connecting the robot to the patient's body. So with these 2 clamps, now the robot is going to come inside. Get the robot inside now. Come close. थोड़ा इसको घुमाइए, हैंडल घुमाइए, वायर्स केयरफुल रहिए. ओके, ओके. नाउ टेबल अप करिए. आपकी वायर्स केयरफुल रहना बेटा नीचे. टेबल अप.
Can you
Yeah,
zoom out and show the machine coming?
Yeah, can you बेटा ये दिखाना, रोबोट दिखाना. क्या no रोबोट भी दिखाना. ओए, इधर ये भी दिखाना, स्क्रीन भी दिखाना. स्क्रीन को छोटा करना पहले, वो स्क्रीन को छोटा करके रोबोट का बड़ा. हाँ, very good, exactly. This is okay now?
Yeah, perfect.
Show me the patient also ना. थोड़ा पीछे कर लो बेटा इसको. हाँ, patient के साथ दिखाना. हाँ. See now right side है. I am getting the patient robot close to the patient body. If you see the screen now, all are illuminated now. Okay, all are illuminated. If you see screen, this is the position before you lock the robot. See to that they are all illuminated. See now I am blocking the tibia. The tibia is blocked. Can you see? Tibia is blocked. When I am blocking the femur, femur is blocked. I can also block the robotic marker, robotic. So see to that they are all illuminated. They know to each other the spatial configuration. Now, इसको दिखाइए robot. Now I lock the robot. Base support on. Now I am. Can you see? Now I lock the robot. Off करो एक बार. Now see now I am putting the base support on, which means I am locking the robot. Yeah, base support on. Can you see the movement now? Did you see?
Yeah.
So now before again I tie the robot, I see all things RX, RY, all are illuminated. Workspace is illuminated. Top view, side view, everything. Now robot is static. The knee is going to be static. I am fixing the robot.
Nothing is red here.
No red. No
Everything
red.
is fine.
You want to show me red? This is
the motor.
Yeah. Okay. Now I tie the robot to the patient's body. Okay. Yes, please.
This is robotic array. This is the femoral. This is the tibia array.
Step चाहिए. Step चाहिए बेटे. Footstep. So इस तरफ है. So now I am going ahead with the next this thing. Lock position. Yeah, next. So now I am doing the restoration point. ओके चेक करो बेटा. कंफर्म. कैमरा थोड़ा ऊपर से उठा. ओके.
So,
कैमरा ಏನಾಯ್ತು? थोड़ा कैमरा को इस तरफ कर लीजिए. तो, नहीं इस तरफ थोड़ा कम. रोबोट देखना है. हाँ. यस. रोबोट मार्कर. जिस गॉस पीस करो.
I think it cleared the array, robotic array.
Huh? We'll read this. Thoda. Do it. Okay, close.
Yeah.
Okay, now we are moving towards the cuts now. As I've told you, if you see, the sequence of events of cuts are shown on the right side. See, if you see the screen there, distal, anterior-chamfer, anterior, posterior-chamfer, posterior, box cut. Choose the flow according to your this thing. If you want to balance from flexion to extension, posterior cut के अब tibia cut करके flexion to extension करिए. Or as I have told you, distal femur, tibia, then do. In tough knees, do distal femur, tibia, do anterior-chamfer, anterior, keep the posterior later, balance the knee, take out the robot, remove all the osteophytes, come back and then give the order for the robot. You want to go for a bigger femur or a less femur. So now it's a simple knee, so I have gone ahead with the measured resection flow. Now start. So now since I have moved the knee, if you see, these are the verification points. Verification points are those points, yes. Once you touch, there is automatic calibration by the robot because it will know. It has to be just point. Yes. Okay. Now start cutting. So
Dr.
now,
Chandrasekhar, can you zoom out the screen, please? They can better find it out how much they're cutting in the distal femur.
yeah, but I think this also required लगता है Dr. Sajay.
Okay.
हाँ. So now we have started cutting the distal femur.
So value is shown over here.
नहीं चाहिए. ऊपर करो उसको. नहीं पास में मत आओ, इधर रोबोट ब्लॉक हो जाएगा. यो. पीछे से ऊपर करो. हाँ, पीछे लेके जाइए. हाँ, छोड़ दीजिए. हाँ, छोड़िए. Start now. Yeah. So now the distal medial, as the path is shown, if you see, उसको एक बॉक्स अंदर रखिए. इसको आधा बनाइए. उसको दिखाइए, स्क्रीन को भी दिखाइए छोटा वाला करके. So now I am doing the distal medial cut. Can you increase the speed of the robot? Yeah. Make it speed. Make 50 speed. Increase the speed.
This is the distal medial. This is the posterior medial. Distal lateral, posterior lateral. This is the speed. This is the force. Psi G.
Oi. So now we are doing the distal medial cut. If you see, so distal medial cut is planned at 6.8 and distal lateral cut is planned at 5.2. Saline बढ़ाइए थोड़ा. So if you see the screen down, it is showing the speed of the robotic cut. It is also showing the force required. Saline दीजिए. So force required, if it's a very sclerotic bone, if the force required is more than 5 newtons, so automatically the robot stops. If you see the graph which is there on the other side, nibbler please. So two things you can observe. One is the bone movement at the cutting position monitoring, nibbler. So if the speed, nibbler. If the speed required is nibbler, if the speed required is more, you can increase the speed. If the bone is very sclerotic, sometimes it's difficult to cut or the required pressure is more. Then if it crosses more than 5 newtons, the robot as inbuilt, it stops by itself. and if it is the speed, if you want to increase, it can increase. At the same time, if you see, it has already made a yellow boundary. It stays within the yellow boundary. It never violates the boundary lines. That is the beauty of this robot. And if in case, whatever you have marked on the CT and what you capture the patient's knee anatomy here, since both gets compared, it forms a boundary by itself, and whatever you have marked or planned as per the pre-plan, it cuts 5 millimeter less than your boundary what you have planned. So you can be rest assured that it is ultra safe. It is never going to violate the bony boundaries at all. Nibbler. So it has an automatically boundary which has made, if you see on the screen. So it is not the haptic as per the other system, but this has a boundary control which is formed by the CT markings and the knee marking. Now, can you come this side? Oh, एक minute. Careful. Okay. Now ये इसको बड़ा कर दीजिए. इसको बड़ा करिए. इसको. हाँ, एक minute. Now anterior cut, anterior chamfer is done. Distal is done. Now I am doing the anterior cut. एक ओमन दीजिए या राइट एंगल दीजिए. डीप वाला राइट एंगल. हाँ, इधर से दिखाइए अभी बेटा, ये कैमरा से ये दिखाइए. नाउ आई एम गोइंग टू शो यू द can you see now?
Yeah, I think is I adjust the camera will be better.
हाँ, थोड़ा कैमरा एडजस्ट करो, ग्लेयर ज्यादा है.
Too much glare is
लाइट
there.
ऑफ कर दीजिए इसको.
You can switch off the lights.
Yeah, switch off the light. So now we are going and cutting the anterior cut. Yeah, now start. Yeah.
So this is the anterior cut.
Yeah, now start.
And it is already planned over here.
Yeah, start now. Retract to Becca. Okay. Now it's okay?
Now it's perfect.
Go ahead, ma. Recovery. Yeah. Go ahead.
You already sure that it will not notch because already checked in the CT scan.
And also even if there is a quarter, I have kept a 1/4 millimeter notching because I wanted to cut distally, posteriorly less, but I have kept the component at 2-degree flexion, should not be an issue.
Perfect.
Saline?
You have reduced the posterior lateral cut. You have reduced 1 mm down.
Because this was a mediolaterally, okay, slow. Yeah, let them see.
And at any time we can stop the robot in between if we are.
Yeah, you can put any array, put a finger, it will stop.
So if you can see the distal cut,
see this one. This is a threshold.
So now if you see the anterior cut is being made
little bit of
as per my planned resection, and the component it is at 2-degree flexion. So
it looks fine, perfect.
So now I'll remove with the nibbler. Give the nibbler, please. So my distal cuts are done, anterior chamfers are done, anterior cuts are done. So if you see now, if you see here, see, wait. See now, it's good.
Yeah, it's good, perfect.
So now I'll go ahead with the next cut, that is posteromedial and posterolateral.
Posteromedial.
Posteromedial and posterolateral chamfer.
Yeah.
Okay. Now go continue. Now you can reduce and you आप zoom करिए. अभी आप निकल जाइए, आप zoom इसको आप दिखाइए आप अभी. Yeah. Now. Is it clear now, Dr.
Yeah, very good. Thank you.
Yeah. So now, that's okay. Chalega, no problem. So now we are doing the posteromedial cut. Is it good, visible now? No problem.
Exactly. Yes.
Yeah. थोड़ा saline डालिए बेटा. हाँ. Now posteromedial cuts is done. Now if you see, all the lateral cuts are done from side to side and all the medial cuts are made from anterior posterior. Lateral cuts, if you see, they are all made side to side. See, now it is doing posterolateral chamfer. Posteromedial is finished, now it is doing the posterolateral chamfer. As you have already seen, the boundary is established and the robot stays within the boundary of what the established boundary is. And if there is a violation, the robot autopilot it stops, so you don't have to worry. Suppose if there is a violent coughing of the patient, then the robot stops. So If you see the graph which is monitoring there, that graph on the right side of the screen in the robotic, in the camera graph, you can definitely see there is probe, the position monitoring what it's doing. See now my assistant pulled a little bit more, it automatically stopped. Now it started again. Yeah.
Little bit of movement, it stops.
So it is completely sensitive. So
It is sensitive here. See the threshold shown over here.
now we are going and cutting the posteromedial cut.
So the bony islands already left on the sides.
Yeah. The bony islands are left as Dr. Sujaya is saying, and also you see all the anterior cuts are made from, all the medial cuts are made from front to back, anterior. All the lateral cuts are made side to side for the patellar tendon accountability. So now you see the screen, it stays within the boundary, the LA boundary. The boundary is created by the markings what we do before the surgery, that is pre-plan, and what we have marked on the table, the boundary is created. Until unless you are marking too heavy, where you are marking knees in a very bad way, the violation can occur. But even if that violation occurs, there will be definitely RMSE which will guide you, because you can't basically go wrong here, because the CT you mark by yourself. Until unless you want to really mark it completely wrong markings, then there can be a problem. But I don't think so. Knowing the anatomy well, what we mark on the CT points, we don't mark a medial as a lateral and lateral as a medial. So that cannot go wrong. And at the same time, whatever you mark on the CT gets compared here. So if your error is more, you can remark it. The sensitivity, what we are taking is less than 1. So this is the posterolateral. Again the boundary is created. Please do not worry, it will never cross the bony boundaries. The knee is in flexion. The vessels are quite back. The capsule is relaxed now. The vessels, the only area where the vessel can come close to it is the posterolateral boundary for the tibia. The femur cuts, even if you oversize by 1, nothing will happen. Don't worry, because there is enough space. You are cutting it 90 degree. And once the capsule at the back is relaxed and the vessels are pushed away, so nothing will happen. See now, the lugoles are formed. Can you see? So if you are a CR guy, what Dr. Sujaya was telling, you can skip and go to tibia, no need to do box cut. So I am doing PS now, because already the PCL is removed. So now all the cuts are made, lugoles are made. Now I am going for the box cut. Now box and trochlear cut will be finished. The video clarity is good?
Yeah, exactly. Thank you.
Yeah. So now box cut is being performed. आप दिखा रहे हो, वो दिखा रहे हैं, आप दिखाइए. आप दिखाओ बेटा, आप दिखा रहे अभी. So now the box cut is being made. Nibler. So if you see the cut surface, they look very refined because there is no saw sky. So in a burr-based robot, these are advantages because one, it has a boundary and depth control both. If it violates the boundary on the mediolateral, anteroposterior or superior inferior depth, the robot automatically stops, sensitive to violation of more than 1 millimeter. And now the box cut is made. Now beta आप बड़ा करो, wait करो बेटा, wait, pause, yeah, wait now, आप बड़ा किया, हाँ आप बड़ा करो. Now you see the trochlear cut. Is it visible now?
Yeah, exactly. It's visible.
Yeah, go ahead with the trochlear cut. Yeah.
The last cut of the femur.
Yeah. Can you see?
2 degrees.
Is it visible?
Yes, visible.
Yeah. Now the trochlear cut is done. Now this is the time. If you want to remove the bone in the femur, lights on करिए.
To surgical TA or anatomical TA?
Yeah, there is a question from Dr. Arora.
हाँ.
You have taken the rotations. It is as per the your PCA or TEA.
For TEA, I have kept it. For TEA, I have kept 2 degrees externally rotated. For PCA, I am at 3 degree. because this knee with the markings was giving only 1 degree rotation. So I did see the pre-op X-ray. I felt probably it may require little bit more rotation. So I have rotated 2 degrees to the transepicondylar axis. Basically, I am at 3 degrees to the posterocondylar axis. Because the PCA was only 1 degree in this case. So I have added 2 more degree.
You have taken anatomical or surgical? That is the question from Dr. Arora.
Surgical transepicondylar axis. For that, I have externally rotated 2 degrees. So I have taken the medial sulcus point in the pre-plan. I have taken the lateral highest point on the lateral epicondyle. That forms the surgical transepicondylar. For the surgical transepicondylar axis, I have rotated 2 degrees more. So I am at 2 degrees externally rotated to the surgical transepicondylar axis. For the PCA, for this it was showing 1 degree external rotated for PCA. Now it becomes 3 degree because I have taken 2 degrees to the TEA, 3 degrees to the PCA. Okay? So now I am going ahead with the tibial cut. Yes? Now I am doing the tibial verification points. Yes? So now let me go ahead with the tibial cut. See, if the tibial cuts are made with 2 halves, medial and lateral half, and the medial just to the bone. Yeah. 1 second per. 1 second. 1 second. Recovery. Change the gap. I will reduce 1 mm tibial cut. Because, okay, go ahead, cut it because if there is a defect, I am okay to put 11 plastic. Go ahead, go ahead. Continue. Even at this stage, if you feel after all the femoral cuts are made, if you feel that you need to cut less, you can give the robot to reduce 1 mm. So basically we are targeting 20. We may hit 11 plastic or a 14 plastic because the soft tissue is lack. But if I cut less tibia, unfortunately I will expose the subchondral, I will not expose the cancellous portion bone. So I will be putting my implant on the cortical or the subchondral area which is not exposed completely cancellous bone. So integration of the tibia might not be good with the bone. So rather I will cut little bit judiciously more tibia and put a thicker plastic 11 or 14 rather than cutting less tibia and exposing only the subchondral bone, not the cancellous bone. So what I prefer is at least 80 to 85% of the tibial bone, pass kariye beta, 80 to 85% of the tibial bone should be cancellous, 5 to 10 or 15% of subchondral bone is okay, but it should not be more. 1 minute rukiye. Stop. Recovery pe jaiye. Okay, now give the lateral. Yeah. Okay, beta, go lateral. Now we are cutting the lateral bone.
Dr. Chandrasekhar, do you really need to retract the lateral tissues? We don't do it in general. It doesn't happen wrong with the patella.
Shrivastav साहब ने बहुत मोटा नहीं दे दिया आज. So थोड़ा retraction करना पड़ेगा.
So usually it doesn't require any retraction, but sometimes if in a fat patient,
short patient, and probably if you some retraction for safety
next
purpose.
time you will do it, nothing will happen.
And
I
if
promise
you want to save the fat pad, then in that case,
if you see Dr. Shekhar, I am not retracting the patella, I am just retracting the tendon.
yes.
I am not put the patellar retraction at all.
Dr. Chandrasekhar, in my experience, so we are doing very fatty patients also. In the initial couple of cases, we had some.
Not required. Yes, it's ultra
right now. You can do it.
Yeah, we can. Not an issue at all. It's just that I'm just retracting with the least amount of pressure, just to be like how the surgeons are. They want to be everything
because there is a tunneling inside the bone, and it will leave the bone island, the lateral most part of this.
You may not require. You may not. Even in this case, if you see, it is. You are not violating the bone at all. The retraction is just holding. I have not pulled it. I will only pull it if I feel that I have to pull it.
Yeah.
That is because before the robot starts cutting, put the retractor, because after you put it and try to pull it, it may end up cause bone movement monitoring, increased bone movement monitoring.
Yeah.
That's why what we do, put it. See, I never used it. I never retracted. See, I never retracted. I just was holding.
Yeah, that is better. We are demonstrating also. It looks good.
If in case if you want to see retract it, you can retract it. So now all the cuts are made. Now the robot job is done. The robot goes to the side now. Now I'll remove all the osteophytes and then show the gap and then proceed with the implantation. Okay?
You'll prepare the keel yourself?
Yeah, I am preparing the keel myself. The one reason because I try to leave 3 to 4 mm of bone posterolaterally, but most of my Korean surgeons, my colleagues there who are using QS, they are doing appropriate sizing of the tibia. And if you do the appropriate sizing of the tibia, you don't need to put, you can do the keel by yourself. Since this is my practice from day one, I did about 100 cases with keel also. But now, there's nothing that you shouldn't do. That is just that my mindset that I do the tibial sizing myself for a couple of reasons, because I feel the most appropriate tibia has to go in, and this one, okay, sorry. But you can do the sizing by the robot, no problem. Keel also. But in this case, as I have planned, the keel will be the sizing and the keel will be prepared by me. This is how I practice. But if I don't know the QV's users there who are sitting on the floor, like anybody is using the keel preparation.
Chandrasekhar, I tried once, but issue is that in that case I had a talk with the Curexa guys. They told you have to manipulate the tibia anteriorly, then you can better do it. Otherwise, in a small tibia, it is always chances of damaging the the condyles of the femur. So most of the Indians, the female patients are very small tibia. In that case, it is very difficult to do it. So because you have to anterior subluxate the tibia, then only you can do it.
So now these are the 2 pins which are still there, and if you keep these 2 pins, for some reason after doing all these cuts, you find the knee is tight both in flexion and extension, you can call the robot to do the tibia. If you feel your flexion is tight, you want to, from E you want to go to D, you can call the robot again. So if these 2 pins, if you keep, you can still call the robot. But looking at the gaps, my finger is going very easily on the lateral side, so gaps are already done. So I'm going to remove these pins. So basically now I can't call the robot again if I remove these pins. I want to remove the pins.
Sir, can we counter check our cuts that we have taken?
Yes, you can. I'll show you. You can check the anterior surface, how much rotation. You can check the distal surface, varus valgus. You can check the tibial cut, the flow, the slope, and the other things. Nibbler, please. Oman, nibbler. Yeah. So now I will remove the bony islands which are there, which are left by the robot itself. So that's the safety feature. So removing all the bony island. I have not made any soft tissue releases till now. So now I will make a small exposure release which is required because to subluxate the tibia. So now I put the knee into figure of 4 and now I make my exposure release. काटरी बढ़ाइए. I'll not go to the posterolateral medial corner. I'll just do the mid exposure. Omen, please. Yeah. Split omen. Split omen. Yeah. You will take. One more omen. इस तरफ आ जाइए. Now you come here. You come here. आप इस तरफ आ जाइए. Now you give me the saw.
Can you focus on the tibia to show that the bony island on the posterior and the lateral aspect?
Yes, please focus on the tibia, please. Yeah.
So there's always this ledge of bone on the
See,
posterior
can you see the ridge of bone here, which I am removing? Yeah. I'm just removing the island of bone. I am not. Yes, it's already removed. Nibbler. Saw, please.
That's why bar is very safe. It will not go beyond bone.
Saw? Yeah.
Lateral end.
Bend
because there is a support is there.
Blade with blade. I think it fell away. I think this one. Better. दूसरा blade है तो लेना. वो नीचे गिर गया. I think. उठा दे. Sizing.
Only.
Osteotome, please.
Only the osteophyte.
You have one more saw. Osteotome.
Now, Mukesh, you can basically
So,
you can set a
hammer.
boundary. Suppose it's size 1. your burr has taken the cut
Sorry?
according to size 1, then more of the bone will be left behind. If you see, so in this case I think it is size 2.
Nibbler?
No, it's
Solve
size
लिखा है जो
4.
बेटा दूसरा.
If you take the cut according to the software, then it will
Drill bit
always
देना
give a
बेटा.
ledge of bone on the posterior and the lateral aspect.
Drill
So
bit.
suppose you don't want a ledge of bone,
Drill bit.
then what you can do, you can convert it to size 3, because as it is, we will take keel ourselves. So you just want the surface cut. So if you take the size 3, then there will be very small amount of bone left on the
Meniscus removal now? Yeah. Give me the cut. Cocker. 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 पहले काकर दीजिए.
Yes.
Right angle लीजिए आप. Right angle. Soft tissue retract.
So you won't get that kind of bone which you want, because it's a burring
Lift
thing.
up.
So no, you don't have this option.
So now I am removing the medial meniscus. Now I am going to remove the lateral meniscus.
You put a wedge. They don't want you to put a graft.
Yeah, if you want to, the principles of bone defects is to be as per the what we do regularly. If in case the defect is smaller, you can put the screws and put a stem. But I think this is an acceptable defect, I think. Let's see. Osteotome, please. Straight osteotome. Just removing all the bone. Now give me a curved osteotome, sorry. Right angle पकड़ो बेटा. So I am removing all the osteophyte. Scoop दीजिए. Scoop. Yeah. Correct. So I am removing all the osteophytes now. Cocker. इसको खींचिए लेग को. Pull the tibia down.
Dr. Sujoy,
This
do
is
you
the
use
osteophyte.
femoral pin in the sagittal plane or in the coronal plane like this Dr. Chandrasekhar has done?
No, anteroposterior.
Anteroposterior. Okay.
Scoop, please.
It's a good idea, I suppose.
Good
Scoop
idea.
That's
दीजिए.
why I said keep on meeting your friends.
So now all the osteophytes are removed. So now let me check the gaps. Nibbler, please. Nibbler, please. Give me my laminar spreader with this thing, my instruments. So now give me this one. So now I'm going to check the gap with the spreaders. Can you zoom it and show to them? Can you show this number? Can you see, sir, now, Dr. Sujoy?
It looks like 20
on both the sides.
Yeah.
This is inflection at 90 degree. Now I will show the extension. Yeah, hold the leg. Extension medial was tight, but let me see. Spreader up. Now show this thing values. Can you show the values?
No.
You can't
Values?
see from there.
You can't see.
So there is 20
Okay,
on the
zoom.
extension lateral,
Yes.
and
Yeah.
about 18 or 19. So now I will decide what soft tissue I have to release on the medial side, or the extension medial. Now I will show you the trial. So this is how we decide when to do the soft tissue. Give me the trial femur, and give me size 3 tibia or 4 tibia with the 9 mm plastic.
The cuts are very precise. See, the one single tap will go inside.
So yeah, that's also the thing, because when you do with the conventional with the saw or scythe, sometimes
Hammer.
you'll have to force in, but here you don't have to force in.
Mostly the max femur, they need hammering. They are fit for the non-cemented.
So
Now gap check.
You can zoom out, I think. Zoom out.
Zoom
Can
out?
you zoom out the screen?
Zoom out. Zoom this out. Check, please. Check.
Can you zoom out, please?
check.
Chandrasekhar.
हाँ, now zoom this बड़ा करो इसको बेटा. स्क्रीन को बड़ा करिए. बड़ा. Could you see now?
Perfect, perfect. Yeah, yeah.
See now, as I have told you, check one. Yes, check. See now with the plastic, this is the things. If you see now, focus on me with the system. Give me an artery, anything which is scoop, anything artery which I can.
I think 2 mm through 3 mm is good enough. You can, if you're clinical, I think you have to decide clinically whether you'll
So
go
if
for
you see
1 mm.
now 13 and 12, this is okay.
Yeah.
These numbers are not bad. The medial flexion is already balanced. This I have to do the release, which I told you I have not done. I have just seen the trial. So posteromedial corner release will give away with this. This is an implant which is a keelless trial implant. What I am doing trial, but these numbers looks very healthy for me. 13, 12, and 12. This tightness I will release now, and that will take over because I have not done the posteromedial release. As I have told you, I am doing mechanical, so I need to do some releases here. So now let me size the tibia and do the release. I think these numbers will open up automatically. Am I clear?
Yeah, what type of poly will go for? You go for this 9 mm poly or go beyond that? Can you show the clinical picture, clinical stability of your knees?
Clinical stability, please. Show the knee. Show the knee.
Is it 9 mm poly, I suppose?
Yeah, it's dynamic. It's because it's. I have not put the original implant. This is just.
Yeah, it's 9 mm trial poly.
Yeah.
Perfect. It looks fine.
That's how it is. Ulta dikhaiye beta. Ulta, ulta.
Can you give some valgus varus trace?
Yeah, I will show. I'll show. I'm just adjusting the camera. Can you see the now tracking?
Yeah, exactly. You can see.
This is an unkeeled tibia. A keeled tibia will give better. Now, this is at 0. Can you see now? It's rock solid.
Yeah, yeah.
And
Perfect.
Rock solid, rock solid, rock solid, rock solid. Can you see now? Can you see?
Yeah, exactly. I think it's good enough with the 9 mm poly.
Yeah, 9. Let me see the trial and let me see the sizing of the tibia now. I have not sized it. And then after the cementing of tibia and femur, either 9 or 11. So we planned for 11. Probably I may go for 11. Just to be, it's a lax knee. But let me see on. This is a dynamic poly. So let me decide the real poly after the keel tibia. So I'll start preparing the tibia. If you guys have time, wait for me to cement. Otherwise, you can proceed. I will cement and come
Yeah,
out.
Chandrasekhar,
Yeah.
I think we'll go ahead with the rest of the program.
Yes.
Thank you.
It's a very nice demonstration.
Yes.
And one thing which I believe, and I think you also agree, that besides the number, it is the surgeon's field which is important.
Exactly.
And so, how do you feel after this, after the balancing?
Yeah, it looks very rock solid. If you see the patella,
Yeah.
I can't subluxate the patella out at all with all my 85 kg body. So it looks good. Number one. Number two, extension medial tightness. If once I do the release, I think that will open up because I have not done the sizing. For the wanting of the time, I wanted to do the trial and you guys to take over the floor. I will do the extra medial release and get the balancing done. It's just
that's a wonderful surgery.
Yeah.
Thank you.
Thank you
very much.
Thank you.
I'll catch you guys on the floor.
Thank you, Chandrasekhar. Thanks for demonstrating a beautiful case. Thank you very much.
Thank you.
Thank you, Chandrasekhar.
So, guys, before the tea break, we'll just have a small inaugural ceremony, 5 minutes. And may I invite our Executive Director, Dr. Rajgopal, and Dr. Anil Arora, who is the President of Delhi Orthopedic Association, to kindly chair this meeting. Can I request everyone to have a seat, please? Sir.
Then cooler.
Can you please, sir, light the lamp, the customary lamp lighting?
Sizing करना है tibia. Remove this pins also. Give me the tibia sizing, please.
Sir, please run.
Home ones, please.
Good morning to all the members here. And on behalf of Sant Parmanand Hospital, our chairman, members of our management committee and our staff, a wholehearted welcome to each one of you to have come today out here and grace this very, very nice conference that we've organized. And it is indeed an honor to have such a distinguished faculty for this program out here. And we are really delighted to have this conference here. And this is only the first of the many ones that we are planning to organize out here. It will be a continuous process, and I'm sure all the youngsters who've come here will learn a lot from the experienced professionals who've been doing these live surgeries. And a special word of thanks to our HOD, Dr. Shekhar Srivastav, who's taken a big responsibility in doing this, and to the doctors of our orthopedic department. Thank you all, and hope to see you soon. Thank you.
So I thank all the esteemed faculty who have come from different places to grace this meeting. And may I request Dr. Rajgopal to felicitate our faculty. Dr. Anil Arora, please. Dr. Sanjay Londe. I think he has gone for the tea. Dr. Rohan Parihar. Dr. Sujoy Bhattacharjee. Dr. Sanjay Londe is from, he has come from Mumbai. Dr. Mukesh Ladha, he has come from Nagpur. And Dr. Ashish Singh from Patna. Dr. Nikunj. Dr. Nikunj is from Ghaziabad. Now, as you all see that this is a 100-bed facility, and it was started by Dr. Shekhar Agarwal, who unfortunately is no more. And he wanted to have a state-of-art facility for orthopedics and the allied branches. But after his unfortunate demise, the current management team took this decision to start the hospital, and they had faith in us to start with orthopedics only, and we thank them for all the faith they have shown us. May I request Professor Anil Arora to felicitate our management team who have been really working hard to make this place a successful venture. Dr. Sagar Rajagopal, who is the Executive Director. Shri Sudhir Maheshwari ji, who is the Secretary of Trust. Shri Ashok Bansal ji, please sir. And Shri Ashok Soni ji. And before the tea break, can we have a few words from Dr. Anil Arora, sir?
Oh, thanks, Shekhar. Heartiest congratulations, Dr. Shekhar, his team, and management of Sant Parmanand Hospital. It's heartening to see first robotic conference happening in this part of country. See, science is moving from subjectivity to objectivity, no doubt about it. And I think in knee replacement, nothing better than robot to objectify what do you feel, what do you think, what do you want to achieve. So we are moving towards next era. Let us see how it goes. But heartiest congratulations, well organized. I see beautiful scientific programs, start from basics, and 2 live surgeries. We are blessed to have this kind of conference. Thank you very, very much.
Thank you, sir. We'll have a break for 15 minutes for coffee, and then we'll meet again for the next part. Thank you. So for this session, may I invite Dr. Chandrasekhar and Dr. Mukesh Lada to moderate the session. The first talk is by Dr. Nikhil Valsangar, and he'll give you just brief overview of all the robotic systems which are available. And after that, we'll discuss each and every system. Okay, Nikhil.
Hi, good afternoon everyone. I'm just going to give a brief overview of the different robotic systems. We have had an enthralling live surgery. Now we'll just come down to a little bit of theory. So introduction, why did we come up with robotics? Because the dissatisfaction rates of conventional TKR were up to 18% because of component malalignment or soft tissue imbalance, which led to poor function, lower implant survivorship and need for revision surgery. So the robotic assisted technology is a potential solution. So how do we classify these robotic systems? It can be based on degree of control provided to the operating surgeon. So we now have active, fully active or autonomous robots. These robots autonomously execute the pre-planned surgical procedure. There is no physical guidance needed from the surgeon. There are many check reins in place to protect the soft tissues. So the surgery which we did right now, QVIS, is a fully autonomous one. T-Solutions one is in the US. So most of the robots are semi-active. So in semi-active robots, there is intraoperative auditory, tactile or visual feedback to the surgeon, which prevents erroneous cutting. So Mako from Stryker, Corey from Smith & Nephew, Wellis from Depoy are all semi-active robots. And lastly, we come to passive robots, which provides guidance and position the instruments like cutting blocks on the femur and tibia. There is no haptic feedback and the cutting is done by the surgeon. So ROSA, Omnibotics, Pi Galileo are all passive systems. ROSA is available in India. So the robotic systems can also be classified according to the source of data used to create the surgical plan. So basically they are image-based or imageless. So the image-based are ones in which 3D computer model of the patient's bony anatomy is created from pre-op imaging data like CT scans, X-rays, MRIs. The 3D model of the patient's bony anatomy is then used for planning. So a little bit of advantage that we get to plan 1 day prior, know the sizes, the implants we are going to use. So there is an intra-op spatial matching procedure which we call as registration. QVIS, Mako, ROSA, T-Solutions one are all image-based robots. The ROSA robot can use 2D X-rays to convert it into 3D models. So this is something different. So the virtual 3D models created are not dependent on surgeon accuracy. There is sufficient time for pre-op planning and it decreases somewhat intra-op time in the planning. So, but it has additional costs of CT scan and MRIs and a significant radiation risk. So imageless robots are Corey, Wellis, Corey from Smith & Nephew, Wellis from Depoy. They predict the surface coordinates of the femur and tibia using accessible areas of the bone surface and various anatomical landmarks. They are highly dependent on operating surgeon's accuracy. There is no pre-op 3D planning, so we do not know which sizes and all we have to use 1 day prior, and we have to do everything in the OT. But it reduces cost and radiation exposure and is probably a little bit quicker. So according to the implant compatibility, we have robots which are open platform and closed platform. Open platforms offer compatibility with numerous implant types, but they lack the depth of more intricate design specificity and biomechanical data. So open software are T-Solutions one, which is in the US. QVIS outside of India is an open software. In India, it is with Max. So closed platforms, single implant choice. If the surgeon changes the implant also, then there might be a learning curve. So closed softwares are ROSA, Corey, Wellis, QVIS in India. So these are different robots. The surgeons will come and discuss about them who use these respective robots. I'm not going to talk about them. So in summary, when is it appropriate to use robotics in TKA? So data suggests all the time, always appropriate to use a device that can provide for better, more consistent radiographic alignment coupled with a knee that has balanced ligaments to benefit the patient. When not to use it, probably when the bone quality is extremely poor, to prevent pin placement fractures, and patients which have severe contracture or massive articular aberrations in which registration is difficult. So what direction are we expecting in the future? We have to move towards robust pre-planning, improved ability to adjust the plan dynamically to balance the soft tissue, and there is a tendency to shift towards fully active. That is to minimize surgeon dependency. So advances in the workflow of future systems to maximize productivity of the surgical team and minimize fatigue, more compact systems, implementation in the OR to be easy and intuitive, improvements will be made in human ergonomics, and systems which allow full surgeon control within a sterile field. The planning user interface has to be easy to understand and manipulate. The robotic cutting tool should be as quiet as possible because hearing loss is a problem with them. So role of AI, the robotic systems will collect extensive data, registration accuracy, joint dynamics, cut times and temperatures, bone quality, robotic arm positions. The currently AI is being used to mine this data to improve and refine algorithms for surgical pre-planning and joint balancing. So is this the beginning of a new era in joint replacement? Most likely yes. Thank you. Now we'll move to the experts who are using these different platforms and learn about each of them. Thank you.
Thank you, Nikhil. Now we'll have Mukesh, Dr. Mukesh Ladda, talking on Cori. So Cori is for the robot for from Smith & Nephew. So Mukesh, over to you.
Thanks, Dr. Chandrasekhar. Excellent demo. Much appreciate that. There is no fight among robotics. Whichever system you believe, use it. Basically, robotics gives optimized use of bone cuts, which you can balance with your soft tissues. The initial teaching with all of us was TKR is a soft tissue procedure. It's changed a little bit because we were taught सीधा cut हो गया, उसको ligament को release करके balance करो. So here it's saying that we are over releasing or we are under releasing. We were not aware of it. So whether that was leading to some dissatisfaction or poor outcome was a question. So here robotics helps you to optimize the bone cuts within the limits. You can't keep tibia in 10-degree varus and say that my ligament is balanced. So it has to be within limits. So maximum you can play about 6 degree in coronal plane, 10 degree in sagittal plane, and 10 degree in axial plane. So if you play within this range, you will achieve functional alignment of the knee. Kinematic, reverse kinematic. Kinematic in India is very difficult because if you go through the paper of Professor Howell, who is the father of this kinematic knee, he says no rotation, there is a third axis and you only cut the bone which the metal is replacing. So there you have that kind of arthritic knee where the damage is not that bad. In India, patient comes with severe varus, bone defect, hypertrophic bone formations and other things. So practically, only keeping tibia in 3-degree varus doesn't mean it's a kinematic knee. Kinematic has to play a bigger role on femur as well. So if you read the paper, so kinematic to me is practically very, very difficult to follow in India. Since last 4 years of my practice, what I following is functional knee alignment depending on patient's anatomy. If you ask me how I manage that, it's still a big question mark to me, first of all. But roughly what guidelines I have made in last 4 years. If patient is somewhere around 10 to 12 degree of pre-op varus, I prefer to keep the knee overall coronal alignment in around 2 to 4 degree of varus. And if anything beyond 15 to 20 degree, I keep the knee in 5 to 6 degree post-op varus. Combining both femur and tibia, not only on tibia.
On introduction of robotics and how do we go about things. Introduction of robotics and how does it work? in TKA? Is it the next level? So the question is, yes, it is the next level. So what we have been aiming in arthroplasty is always accuracy, confidence and reproducibility, and a flexibility. So we think, and we have all gathered because we all think that robot is the next level. So conventional total knee was a way of doing it. We are still doing it. Navigation was the first stage of advancement, and robotic hip and knee and unis are the next level of advancement. But as we have been told in the morning that you need to be a conventional doer and then shifting to navigation or robotics. So make new friends, but keep the old. Those are silver, these are gold. Remember these words. You need to be a conventional player first. So automation and booming technology, it's a boom everywhere. You see so many aircraft, so many new phones. Same way, now we are seeing so many new robots. So in the 1950s, we had a static plan. In the 1990s, we had a navigation execution. Then we had navigated free handheld tools. And in 2000s, we had the robotic assisted surgeries. So we need to understand the robotic systems. And to need to understand, we need to understand the body CAOS. So CAOS is defined as the use of computers or technology to assist in musculoskeletal care. So CAOS is the basically body, and computer augments our surgery because they have geometric precision, they have reproducibility, it has a perfect memory, and it lack of fatigue. So you have to understand COS. How do we use computers in our surgeries? Computer assisted surgery technically is not a robot. You're overruling every time. It does not require a dedicated technician. You're not like an Iron Man or super cop sitting in a room and the surgery is being done. This is one of the questions that the patient asks, but we have to make them understand. So we have been discussing these things, but we need to understand the robots are active, semi-active, passive. So active robotic tools are which you're sitting in the room and the computer is doing it, or the robots are doing it. So that happens in manufacturing companies where Apple phones or cars are being manufactured, and it is being monitored by a team of specialists. But we all are here, we are using semi-active technology, and the Mako Navio falls in this category. Secondly, it is important to know that when you're talking of the QVIS system, it is bird-based, fully automated, but still you can stop it. You can stop it, pause it, or you can just take it out of the way. Second important thing which we need to understand is intraoperative modality. So whether you are feeding, because you need to feed data. So that data might be in the form of X-rays, that might be image free, that is in the older, the other systems, and it might be X-rays or CT scan like we are doing in the Mako and the QVIS. So computer navigation are rigid tools. Understand this. You need something to interpret between the body and the system. So you have these arrays, and it helps the surgeons to be more precise, and you have a monitoring and you have data in front of you. So if I ask the audience here which two lines are parallel, probably we might not be able to judge it in a very good way, but the human eyes are very good in managing to see parallel lines on 90 degrees, not various 1 degree, 2 degrees, 3 degrees. It is impossible, and we say we are doing eye rolling or eyeballing. So Dr. Vivek Mahajan is here, and myself, we both are very proud that we worked. The first computer-assisted surgeries were done in 1997, which has been taught by Dr. Fellows, and we are proud to have worked with him. And at that time, the Navio was being developed. So we used to work with on the Blue Bells technology, and the Navio was actually purchased by Smith & Nephew by Blue Bells. So now they have changed the name to Cori. So you have to also understand what is the difference between navigation and the robotics. In navigation, you cut, then you verify. You have the data, but you're cutting yourself. In robotics, you have tools that is cutting the surface as well. So navigation and robotics, you need to have understanding. So is it a time or a long coffee break? I think so, yes, no, because we are doing the stuff. We have so many newer technologies. India's first fully automated joint surgery robot, that is, this is QS. And on the other hand, we have other systems. Mako is one of them. But what we need to understand after my talk and today's meeting, that all these are enforced controlled robots. That means you can control them and stop them. You are working in a haptic boundary or a boundary. And these are some systems. New kid on the block, ROSA has come up. Automated robotics, Robodoc also. Things will come up. Every day will be a new day. Now, second thing which we need to understand, how does it work? So, first of all, any platform you talk, you need to have a 3D registration. Now, when we talk of the image-free registration, when we talk of image-free registration on the bone and the computer. But that is not verified by the CT scan which is being done in the Mako system or the QV system. So that has to be within 0.5 mm of accuracy. So you can't go wrong. Like in navigation, we used to register, and there was a common saying, garbage in is garbage out. So image free is something like you don't do any imaging pre-op, but image based robotic workflow is that you need a CT scan, then you do appropriate planning, and of course you can change your planning intraoperatively. And as I told you, image free, you register on the table, and you might go wrong because garbage in, garbage out, but in experience and that is also good. And it all, so basically robot gives us in the Mako system visual feedback, haptic stiffness and audible feedback. We actually have a saw, so the saw works in a haptic field, and basically CT scan is done, it is planned, and it can, you execute what you want. So if you, same system, you have say computers on this in the front of your surgical field, and a person, a dedicated person is there who is also handling the computer. So how do we go about it? In any robotic systems, we need to have the X-ray, CT scan. The CT scans are segmented. That has to be overlooked by the surgeon himself. Plan. Then we do segmentation after the planning. That is pre-planned, and then you register the patient. It has to be in accuracy of 0.5 mm, and then replan it, dynamic planning on table, and there you are. So basically, you talk of any robotics, it is a software for precision. You have a pre-operative patient implant planning. It is robotic, arm assisted. In the QS, it is fully automated. You saw in the morning, superb demonstration, and the way it was cutting with a burr. There will be controversies whether saw is better or burr is better. Time will tell us. And this is how we do the pre-op planning. We see everything. Then we do implant positioning and planning. On the table, we have the tracking arrays, the radars, or what we call it generally. Then we register. So here you can't go garbage in, garbage out, because you have to register. It has to come in the blue dot, and the blue dot has to be in 0.5 mm accuracy. If it is not, you cannot proceed. So this is how we do the registration, as it was very well executed, surgery was executed in the morning, and we are doing it. Then we do dynamic planning in extension, 30 degrees of flexion and 90 degrees of flexion, and we see the data. So this is what we get on the table. So you will see 15, 19, 16, 19, and then we plan how much we want to do. Now here also you have the options of doing, you want to do simple mechanical planning like 3 degrees external rotation, and or I do gap balancing, functional planning. So we then cut the bone measurement. We have the rough guide. What are we cutting? How much we are cutting? If you want to have 1 degree, 2 degree varus or valgus in the femur, we take it and we plan it and we execute it with the robotic arm. So in the Mako system, you have the saw in your hand, and it is not fully automatic like the QVs, but you have the saw and it can't go wrong. And there you are. It cuts in a haptic boundary. You can extend the haptic boundary if you want, 5 mm, again 5 mm on table. And this is how we work. So we take the gaps pre-operatively, intraoperatively we manage, balance it, dynamic planning. But the whole question is, why have we discussed, what are we doing here today? Why are we talking on robotics? Because we all have some failures. Before I proceed to talk anything further regarding the literature, I was very happy to hear one of the lectures by Sir in Aurora Sir in, I think, Vapi. and he has explained very well daughter-in-law syndrome. So you need to counsel the patient, talk to the patient, Dill syndrome, talk to the lady, talk to the parents, talk to the children very well. So you'll have a happy patient. It's not about going to robotics or doing something, but have time, listen to his talk. It was a wonderful talk. So what do you have the benefits? Like you have so much insight while you're doing the surgery that you can't have notching, you cannot have malrotations, you can cut and verify the rotations. The bone dissections are actually perfect what we plan, and there are papers which show that what we plan is what we get. And recent literature, there has been problems in mechanic, kinematic, anatomical, functional alignment. So predictive gap balancing is coming. So in the next few slides, you'll understand a bit more what we get in the robotics. Now, usually when we are doing a conventional total knee replacement, we open it, we release it, then we put the spacers. We might cut more, we might release more in millimeters, which we can't understand. And it depends on the surgical technique, how much you're using your knife or cautery. So what we generally do here, we are indiscriminately releasing it. But when we, in traditional approaches, so basically in, now we are talking of functional alignment lately, and also predictive gap balancing, that we are releasing what we require. We are seeing the gaps, we are analyzing, we are releasing, decreasing the bone cuts and taking it from there. So functional alignment, that is what we are doing. All the robotic surgeons now are doing functional alignment. The reports till couple of papers say that yes, it is better. So predictive gap balancing is there, and functional alignment. If you combine these two data, the outcomes are definitely better. And obviously there has been a controversy between measure dissection and gap balancing. So this comes in between. It is a predictive gap balancing. And predictive gap balancing, you know how much you are cutting, you are giving varus or valgus to the tibia and the femur, and cutting less, they're doing more. So if I reconcile what I talked now, basically with traditional instruments we used to plan, we used to cut, then we used to assess, and then we used to balance. But now when we have the robotics in action, no matter what robotics you have, you are doing planning, assessing, you are balancing, and then cutting. So the whole algorithm has changed. So planning comes first, then we plan, as whatever I have told is just a small video, taking the data, dynamic, first was static planning, then we are doing the dynamic planning, and then accordingly doing the releases and taking minimal bone cuts, giving tibias, varus valgus, or whatever amount of rotation which we feel is right for this patient. So when we talk of functional alignment, it reduces the need of soft tissue release, maintains ligament function, we have data, and soft tissue releases are generally less when we talk of robotic assisted, and definitely less pain. So, and predictive gap balancing. So two new concepts apart from robotics which have come up is predictive gap balancing and functional alignment. And this is one of the most important slides which I would like to show. So what does all these things improve? Basically you have a medial pivot, it creates a good joint space, very accurate, you have less complications, absolutely 0% notching, you know what you are cutting and you are there. So what in my practice last from 2021 I have seen that most of the time we have shifted to CR implants, and I'm very sorry, but when I came to India, first thing in a meeting somebody was asking who are CR surgeons, who are PS surgeons, everybody, I mean I raised the hand in CR surgeons. Nobody was raising the hand. It was our first meeting in India after 5-6 years. So I thought, am I doing something wrong? So you have to have the algorithm. You're not a CR or a PS surgeon. It is on table when you come to know that you can shift from CR to CS, CS to PS, PS to TS, and TS to hinge. So this is the algorithm which you need to understand. Now the benefits are more benefits, more papers are coming up, and the clinical outcomes, the rates of discharge. Sir has also told, many people have told that patients are going home, lesser recovery, more accuracy. If you are doing a CR implant, you are just cutting, you're even not sacrificing the PCL and leaving the PCL notch there. So If you're cutting less, revisions if required, you'll have more bones. The knee revision indicators, if we are doing the Swedish joint race, they have shown with robotic joint replacement, the revision rates are lower. Satisfaction rates are more. In my personal practice, we mobilize the patient in 4 hours, discharge the patient day 1 stair climbing. Patients having less CRP, forgotten joint score is good, I mean less. The knee society score and the WOMAC score is less, and even the blood loss is less. We don't transfuse blood. So pain scores, etc., everything is less. Second question is timing and technology adaptation. Yes, that's a big question. So with 10 to 15 cases, you will be there actually. And big centers in worldwide and in India are using different technologies, any of the systems. So I think it's the way to go ahead. I have no doubt the future is somewhat here. So what when we do on robotic platform, we have less pain, we have lesser recovery time, and we have so many benefits, which I always say to my patients. So what I would like to ask you, why are we still using traditional conventional techniques despite some evidences? Do you want to have your knee replacement done with a 90% or 95% accuracy or 100% accuracy? So there comes the question. A big thank you. But what I would like to say, change is the law of nature. It is happening, already happening. Telesurgery is being done. So progress is inevitable. Technology is here to stay. Those who will change, I mean only the phones will change. We have our phones which is becoming smaller day by day. Those who will embrace the change will survive. Those who won't will retire. So you have to understand the technology, and with this you need to have you have smile at the patient after every knee or hip you do. Patients are mobilized. So a good surgeon respects soft tissues, minimal sufficient bone cuts. With this, I would like to proceed to the next slide, which is just 5 minutes, and quickly go through some things, because these are some cases which you need to see, because this is a very good platform where technology can be made useful. I will just take 5 minutes, but this is a very good, interesting presentation. Why interesting? Which you will come to know when I present this. So now, coming to intra-articular post-traumatic arthritis. In Patna, we get patients like this. You actually don't know what you have to do. We are very happy. We don't know what to take coordinates and all these things. So we have, these was done in some place, it was plated, the plate broke. So I need to explain you all where we can use technology and where technology fails. And you will have sequences of slides which will show you all the things. So I have everything. I have navigation, I have robotics, I have conventional, obviously conventional. So let's talk about this patient. A patient comes to me like this, young boy, you do 39 gentlemen, 10 to 30 degrees, and you are worried. You get the CT scan, see the lateral view. We can't do MRI. Even the CT scan showed so many artifacts that it's hard to take the tibial landmarks. How much do you cut? So anyways, this case was done with difficulty, and he required a total knee replacement, performed it. It was done manually, eyeballing, right? So this case was done manually with difficulty, you can understand. But we achieved something like this, patient happy, everybody happy. Now, let's talk something like this. So what happens to this case? So in this case, we use technology. So what happens when we are using technology? You need to register the bone. The bone registration has to be between, you cannot go between 0.5 or more. So we planned it, we sent it to America for segmentation. Our segmentation happens in America. So they refused it. So Americans refused it, it can't be done with the robot. So I said, fine, okay, we'll try. If not, then we'll do manual. So they sent something like this. I'm talking of all these things. So we have the CT scans, which shows broken everything, and implant was actually taken out. This was the plan sent by the Americans, and they denied that this can't be done with the robotic platform, right? So, but I asked them, send me the plan and we'll take it from there. Now, I put the pins and I tried to register it. Now the funny thing happened that registration occurred. So once the registration passed, so you have your coordinates in hand, and then you don't need any TBL jigs or something. So same case, last case, where I showed you that technology was not there at that time, but in this case technology was helpful. You understand my point? So registration was done, all the white dots turned blue, so I was happy to proceed. But unfortunately, when the operation was being done, you can see the postural medial fragment, which actually was unstable, had fibrous union. So after cutting it, I realized, so we had to stabilize with the plate. So this was done, and we got something like this. But this was done with the help of robotics. So no jigs, robot technology was helpful, like in last case. Now coming to the next case, in this type of case, robots are not helpful. Here, Cody would be helpful. You have to understand why, because that is image free. Now in Navio, that is Cody, in Mako and Cubis, if the things change intraoperatively, then you have to have the CT scan, and the CT scan has to be fixed. Now in this case, when we removed this, and it was varus of more than 30 degrees or something, so we had to do a dome osteotomy. So in this case, we registered, it was not moving. Then after registration, the femur was done with the robot, but the tibia was done. We did a dome osteotomy. So doing a dome osteotomy, the CT scan plan changes. You can't execute with the robotic. So half robotic, half manual. Getting my point? So here technology failed. You can't have moving fragment while doing anything. Here Cody would have been beneficial, or navigation would have been beneficial. So this is doing well, fine. Now we get something like this. These are some fresh fractures with OA. So in these types of cases, we are worried if we do a fixation, nothing will happen, they will happen. So here navigation comes beneficial. So best treatment plan in these are, you don't know what to do. So in these cases, what I do, you open it up, stabilize the fracture with pins, put your plate, put your navigation, image free. There is the role of either Cody or image free modality or navigation. So you put a plate, you do navigation, you put a CR implant, and you're out. You don't have the box cut, so supracondylar plate can be done. So these things, all these things are published. So lastly, in this case, here robot was simply useful, nothing, plate was removed, it was static, and everything went well. In all these cases, we have calculated a joint line, and this is also published in one of the international journals, and it is all right. In case of fused knee, where we managed to do with robotics. Now, this is the last case, and this is where everything will fail. So this is a fused knee, patient young, wanted to mobilize, and it is periarticular, has been this patella has fused with the femur, and you have a supracondylar fracture. So here nothing will work. Here you have to plan on a straight knee. Osteotomization of the patella was done, taken out, and then using your brain, using your image intensifier, extramedullary alignment was taken using this femoral head and things, and then it was released, and then after releasing, proximal tibia cut was taken, and the proximal PCA was taken parallel to the proximal tibia cut. So it was all planned, fixation done, then planning done, and then stabilized, extramedullary alignment taken, and finally something happened. So something happened. Anyways, this was the last slide. Yeah. So this ultimately, it was all based on your brain. It's conventional. We keep old friends. We achieve good flexion extension gaps, and ultimately something like this. And patient was having 90 degrees, of course, indeed with this quadriceps plasty. So this was the last case, and the main purpose of showing you this is that even having technology, you should understand technology. Even having technology, your technology might fail. You can have technical issues. So if you have technical issues, you have to jump back. So before I end, I would like to say, keep your old good friends with you, make new friends, and just be correct technical education, skill and understanding, and it's very important to understand the conventional total knee replacement. So all these are published in journals. So unlimited the limit of possibilities. Any questions?
We'll take the questions at the end, Dr. Ashish. Thank you so much. It's good that you showed where the navigation comes into picture, where the passive and active systems, where the CT-based robots, where CT-based robots won't be helpful. And basically one tagline, a good conventional surgeon is always going to be a good robotic surgeon. It is not an excuse at all. So now let's move on to Dr. Sanjay. He'll be talking on workflow and functioning of QV's robot.
I think my job has been made very easy by Dr. Sujay and Dr. Chandrasekhar. Dr. Sujay explained the pre-operative planning in the QBIS system, followed by a fantastic demonstration by the Dr. Chandrasekhar of the surgery. So I think without wasting time, we'll go with the intraoperative how I follow. Means again, I think you can have your own philosophy about as has been explained, functional alignment, HK 180 degrees or kinematic alignment. What we usually follow is this. I think, to my mind, there is no doubt that there is a benefit of robotic-assisted total knee arthroplasty, because it's like a pilot and autopilot. Yesterday, I came with Indigo. In Airbus 320, there is a pilot and there is an autopilot. If autopilot concurs with the pilot is very happy. But suppose in Mumbai, if there is raining too much and you cannot see the runway, then probably the pilot will keep the autopilot aside and he will land the plane himself. But if the autopilot concurs with the pilot, it is 100% guarantee that you are going to have a desired sort of alignment and desired gap balance. So there is absolutely no question that this is a assisted tool and which improves our accuracy of the implant. So I think Dr. Chandrasekhar has already shown and Dr. Sujay has shown the components of this system. It is accurate, it is bone preserving, and the use of milling tool reduces the impact on the patient's weak bone, and this thus cuts down the adverse side effects such as fractures. In fact, currently we have a ethics committee approval and we are looking at a study of thermal necrosis of the bone with a saw versus a burr with a irrigation, and at least the initial results show that the thermal necrosis of a burr with a irrigation, continuous irrigation, vis-a-vis saw, because saw you don't have a continuous irrigation, the thermal necrosis is much less with a burr with a irrigation. But the numbers are very less, so we'll definitely come out with that research and publish about the thermal necrosis of the bone by the two systems. So I think this is our first paper in Indian Journal of Orthopedics regarding the QBIS system. We've analyzed our first 30 cases, whatever we planned in the office and whatever implants we put during the surgery. As you can see, we were almost 100% right in the sizing of the femoral implant, and we were almost 96.67% right in tibial implant. In one of the case, actually we planned for 5 and we ended up putting 6 tibia. That was the first only deviation. So there is no question. Again, I am slightly biased. Fortunately, I have access to 2 systems. One is VELIS and one QVIS. And I personally feel that I think an image-based system is much better because it gives you an additional advantage of planning the surgery and planning the implants at your peace of mind, not during the hush-hush of the operation. This has been presented by us very proudly. We can say that the most futuristic conference in the world about the technology in arthroplasty, that ISTA, we presented on the online mode in the Hawaii, USA. We did not travel, but it was during the COVID time, so we presented online. So I think intraoperative workflow has been very nicely demonstrated by Dr. Chandrasekhar. So as a robotic surgeon, you need to be a good conventional surgeon. I am a PS surgeon. I use all the PS implants with due respect to probably I am a very low ability and low, not average, I am a very average surgeon. So I use a PS knee because I think the type of deformities which we get in our patients, I have my doubt whether the PCL is functioning or not, but that can be a matter of debate. So we expose the knee in a routine manner. The most important thing the conventional surgeon has to understand and adapt is immediately after 3 minutes of exposing the knee, immediately you take the nibbler and start removing the osteophytes. So in robotic surgery, please don't do that, because you need to match the patient's anatomy with the CT scan morphing of the model. So no osteophytes are removed. Very minimal medial soft tissue envelope is reflected. Not, I think, gone are the days of traditional Ranawat teaching where we used to go almost up to the posteromedial part. You know, we don't touch deep MCL. We just elevate a little bit of medial envelope. Then there will be the insertion of the tibial and femoral tracker pins. Nowadays, I think Dr. Chandrasekhar and Dr. Neeraj Alkar, they have popularized the insertion of the pins through the incision, so that it theoretically decreases the incidence of stress fracture, because that is one of the dreaded complication. Personally, I will show you, I prefer to put the pins in only 3 cortexes, just especially on the femur side. Just go up to the next cortex and stop it there, because you will feel the jerk there. So that theoretically reduces the chances of a stress fracture. What you don't want to do is actually put the pin transcortical. It should be in the center. But if the pin is transcortical, then I think if you see on the post-op image or X-ray, go a little slow on that particular patient, because transcortical pin is one of the sort of one of the risk factor for a stress fracture afterwards. So as I have told you, some surgeons, they prefer to put the pins through the incision, and the aim is to prevent the transcortical insertion of the pins. This is what it is on the saw bone, and we have seen beautifully on the surgical demonstrations also. Femur and tibia registration, 40 points each are marked in the femur and tibia. Registration point confirmation done by assessing the RMSE, root mean square value. Again here, see, as a surgeon we can go wrong, but the computer or the data or the data analysis or artificial intelligence will not go wrong. The crude RMSE should be less than 10 and the final RMSE should be less than 1. If it is that is there, root mean square error, that means the patient's anatomy is matching with the morphed model of the CT scan. So whatever cuts you are going to get, they will be in the sub-millimeter accuracy or less than 0.5 millimeter accuracy. The final RMSE should be less than 1. Dr. Chandrasekhar has nicely demonstrated all the points during the operation. So what usually I do at that point of time, once I expose the knee, once I put the pins, I assess the pre-cut gap balance. The pre-cut gap balance is checked in extension, 30-degree flexion, 60-degree flexion, and usually 90-degree of flexion. The medial and lateral gap values are captured, and it gives a fair idea about the post-gap balance. Now see this particular patient, it's in 2-degree varus at 91 degree of flexion. In the medial side is 2 and the lateral is 10. So I'm very happy with the 10. Medial is 7 before we have started cutting with the robot. So I know once I cut and once I remove little bit of medial osteophytes in a varus knee, I think I should be okay. And there is a very good paper by Michael Mont from Rothman Institute. He says that in a varus knee, the medial value, if it is 10, the lateral value of 11 and 12 is actually desirable, because the lateral side should be little lax, especially in flexion. There is a fantastic paper, and it's published in one of the very reputed journals. Vis-a-vis, in a valgus knee, the value on the lateral side can be 10, and on the medial side you can be lax by about a millimeter or 2. In fact, the other system, I think Dr. Mark Clatworthy is not there. They actually recommend keeping in the Willis system in 90 degree of flexion. They recommend keeping 2 millimeter loose in 90 degree of flexion to mimic the rollback of the femur. Means that is their recommendation of the Willis group. So this is the which you have not touched the robot. We have not started any operation. So we know exactly where we stand. Robot positioning and attachment, as Dr. Chandrasekhar has seen, the cubist joint robot is attached to the patient. This is done either by inserting one pin near the lateral epicondyle and one pin in the anterolateral aspect of the tibia. Nowadays we have the clamps. Of late we have started using the clamps, so you don't have to use the pins also to attach the robot to the patient. Then the cubist joint robot is moved in and attached to these pins. Now you can see I think Dr. Chandrasekhar has also demonstrated. This is most important. These things, these are subtle things, Rx and Ry. Rx is mainly flexion and extension, and Ry is abduction, adduction, and internal rotation. At no point you should be having a red field here. If it is red, then you adjust the flexion extension of the patient or adjust the adduction, abduction or internal external rotation of the patient. This should be always blue and green. It should never be red. If it is red, the robot will not proceed. And this is the top view, and this is the side view, and this is the top view of the robot. It should be in the circle, preferably on either side of the line and either side of the center here. Preferably, it is better to have this view and then ask your anesthetist to lift raise the table towards the ceiling so that these points become visible and they should be on either side of the center. Once you get this picture, nothing red here, Rx and RY is okay, no red sort of color, and these 2 points on either side, everything is ready for you to go. And then you cut either one of my colleague, we are a group of 6 surgeons in Mumbai who came together, and the hospital owner also chipped in, and we put the first robot in Mumbai, the QVIS, and it has worked really well. The owner has also purchased the other robot. So not only the technology is good, but personally my experience is it will increase your numbers also. But this is not science, but that is also important. So then you attach the robot. These are the cuts. I prefer to put the femur first. One of my colleague cuts the tibia first. So the sequence of events is distal cut, then anterior chamfer, anterior cut, posterior chamfer, posterior cut, lug holes, box cut, and trochlear cut. We owe a lot to Dr. Shekhar because I think we went to Bangalore, we practiced on saw bone, and that's why our learning curve was much shortened. In fact, we have sent that article to the publication also. In our hands, our learning curve was almost about 10 cases. And there is a very good surgical anxiety score also. I filled that form. I asked one of my colleagues, we always work together. We filled our anxiety also before going in for the surgery. And our surgical anxiety level was also less after first 18 cases. Obviously, for the first 18 cases, we were anxious. Both surgeon assistant and a scrub nurse. So 10 cases about for the time, and anxiety level about 18 cases. So this is which you have already seen. I think we will skip that. All of us are just standing there, fully automatic system, no burring, nothing. Tibial resection, the medial side, the burr comes from here, it is open, so there is no chance of soft tissue problem. Lateral side, I personally sort of make sure that I plan in such a way that there is some gap here, because especially in thin patients with short patients, the patellar tendon is always there. So we need to be very careful, and we need to put though Dr. Sujay Bhattacharya says that there is no need for a radius ulnar spike or something, I always put it because it is always better to be on safer side. You ask your assistant to just keep the radius ulnar spike so that it will, because the lateral side the burr is going to cut like this. So you put a radius ulnar spike so that it will prevent any iatrogenic injury of the patellar tendon. In fact, we published in your own journal, Journal of Clinical Orthopedics and Trauma of Delhi Orthopedic Association, the safety and efficacy of this particular system. Efficacy is already there, which we have seen, and safety was also established in the first 80 cases. In fact, they say that in an osteoporotic bone, robotic surgery and milling is query, whether we should do. I feel it is opposite. Actually, in a porotic bone, because it is cutting very smoothly and seamlessly, till today, touch wood, we never had any condyle fracture or anything. And that's very good, because especially rheumatoid patients or very elderly patients, vegetarian patients, their bones are very bad. You can, on table, you can just compress the bones, at least in our part of the country. I don't know about here. So that's it. So I again personally follow Dr. Chandrasekhar's philosophy, because we have been taught and we have learned from him. So I don't use the robot for the peel. I cut the tibia because it will give still that lever or that lever in my hand to rotate the tibia if I am going wrong. So I prepare the peel myself and I prepare the wings with myself. Then once you have done that, we will put all the osteophytes. Usually the robot will keep a sleeve of bone at the back of the femoral condyle and at the back of the tibia. You remove it with the nibbler as he has nicely demonstrated. I have not touched any soft tissue. You put the trial implant of the femur and tibia and then again check the balance. So I think this also we can skip. Then post-cut gap balancing is checked, and if the post-cut gap balance is checked in the real time, again from 0 degrees, 30 degrees, 60 degrees and 90 degrees, the trial implantation is carried out, and if it is tight on the medial side, then appropriate soft tissues are released on the medial side in the varus knee to achieve a rectangular gap. Again, 1 or 2 millimeter gap laxity is acceptable on the lateral side in flexion and in extension. If it is tight on the lateral side, then appropriate soft tissue release is done on the lateral side in the valgus knee. So basically what we want is some sort of a curve like this. This is 0 degree varus, 90 degree flexion. In 90 degree of flexion, 9. I would have even accepted 10 or 11 here in this particular thing. Again in extension, 10, 11, capture about 1 millimeter, I am happy with it, and 9 and 9. So I think I strongly encourage people to read that paper from Michael Mont. Very, very nice paper about the, not only in the robotic, but in the conventional knee also, how one can go about balancing the knee. So that's what we do. So these are certain cases. Actually, this is the case from dear Ashish Singh's territory, lady from Chhapra. She, for some reason, she wanted to come to Mumbai and get it done, you know. So these are the X-rays, weight-bearing X-ray and stress view. Post-operative, this is lateral X-ray. This is what we planned. Again, in the planning, because it is a C implant, it's the posterolateral, the thickness of the implant is about 8.2. So to achieve a rectangular gap, I usually keep the posteromedial cut about 1 or 1.5 centimeters more than the lateral side. So as I have told you, it is more of a 80% major dissection. Because when I am planning, I want in the varus knee the posteromedial cut to be more than the posterolateral cut. So I usually keep it about 1 to 1.5 centimeter more so that I will achieve a rectangular gap. Again, you can flex and extend the implant. I usually keep about 2 to 3 degrees of external rotation. I am a PS surgeon. I am not deviated from that. Usually keep a slope of about 5 to 6 degrees. So this is we have planned before the operation in the cozy AC room of our chamber. So this is what we get during the operation. Extension
वहाँ connected नहीं है ना?
You see, a fool with a tool is still a fool, you know, or garbage in, garbage out. But if you are operating and you see these values, it's a validation that you have done a fantastic, good job for that particular patient. So this is what during the operation, and this is the post-operative X-ray. Again, important thing about the imaging, you know, see the X-ray here. In fact, she the senior most physiotherapist in our part of the Mumbai, his wife, 82-year-old, and physiotherapist is about 90. And on the plain X-ray, you would never see these cysts. See the big cysts. Very, very difficult to ascertain on the plain X-rays. So once you do a preoperative scanning, you are aware that there is a cyst, and you are aware that which implants you want to keep and what are the surprises which you will have during the operation. So this is during the operation. You can see the cyst. Here we have slightly modified the anterior chamfer. I did not use the burr because when you use the burr, you are losing the bone. So I used the pegs, put 4-in-1 block, and use that 4-in-1 block to cut the anterior chamfer and use that bone to graft that particular cyst. Because we knew in advance what we are going to do, so this planning is much, much easier. So we grafted it, and this is the post-operative X-ray. Again, a guy from Jalgaon, somewhere near Madhya Pradesh, Maharashtra and Madhya Pradesh border. For some reason, about 30 years back, he had a fracture, which was managed with stem pin traction. Nature is great; it has healed, and the patient has carried on for last 30 years, you know, with this particular extraarticular deformity. This is his scanogram. I think with conventional surgery, I don't think this is manageable. You know, it's all eyeballing and it's all gut feeling and everything. And nowadays, I think gut feeling has no role. You know, so this is his clinical picture, about 5 centimeters short, and this is what we did. His alignment was straight. Here, as you can see, with respect to the hip, in the AP, in the frontal plane and the caudal plane, this is acceptable because actually, if you calculate on the robot, the implant was in almost 11 degrees of extension. But the patient on table, he had straight leg, and almost we could correct to about 3.5 centimeters of his limb length discrepancy. From 5 to 5.5 centimeters, we corrected almost 3.5 centimeters to this particular patient. Again, certain surgeons who were skeptical in Mumbai about the robotic, till a QVIS robot came to they went to their hospital as a loaner, and he only did the case along with me. Valgus knee, he was skeptical that I have to release IT band, posteromedial structure. We did not touch any of the tissue, proper preoperative planning, and see the result. No soft tissues released. Same case, another surgeon in the same hospital. You can see the stress riser, valgus knee, very bad knee. And this is the result. In the novice hand, it was their first case. I was assisting them, and that was their first case. So I think there is no doubt that the preoperative imaging and CT scan definitely helps us in planning exactly what implant to put, what size of implant to put, any unexpected occurrences like cyst and everything, and that will hopefully decrease the number of dissatisfied patients from 20% to about say 10% or 5%. So the technology is emerging, and let's see where it takes us. Thank you. And I thank Dr. Shrivastav to give us an opportunity to present our work here.
Thank you, Dr. Sanjay. It was a nice presentation. So now we will play the video of Dr. Mark Clevertavati, who is going to demonstrate his talk on Welly's platform. It's a recorded session.
ये वीडियो रिकॉर्डेड वीडियो
Hello everybody, my name is Mark Clevertavati, orthopedic knee surgeon from Auckland, New Zealand. I've been lucky to be involved in the development of the Welly's robotic assisted solution over the last 2 years. We were the first surgeons in the world to use this, and I'd love to share my experience with this great system with you today. The technique we're using is a patient-specific alignment navigated bounce totally arthroplasty. The concept is to aim for a bounded anatomical resurfacing of the knee to replicate the native anatomy of the knee. We then make small positional modifications to enable a stable total arthroplasty through a full range of motion. We avoid soft tissue releases so the TKA is implanted to function within its natural soft tissue envelope. The first thing that we do is dock the robot to the bed. We have gone to great effort to create a small robot with a small footprint to enable to use this easily and not to overcrowd your OR room. We then make a point in the tibia and the femur, so if there's any ray of movement, we can address that. Registration is very straightforward. Collection of the centre of the femoral head, very quick, efficient and accurate. Then the malleoli, the tip of the medial and the lateral malleoli. The collection of the tibial points is extremely important. The first point is to collect the centre of the tibia, so this is the insertion of the ACL. The second point is to collect the medial tibial plateau point, and this is determined by the arthritis of the knee. In this particular patient, the patient has a lateral compartment OA, so they have a normal medial compartment. So we place a pointer in the centre of the medial tibial plateau. We've got a normal articular cartilage. On the lateral side, we put the portion where the articular cartilage turns to bone. We measure that point, so we've lost 2 millimetres of articular cartilage. The final point is the AP collection, so you place the pointer in an AP position. For the femur, you collect the centre of the distal femur, the point where you normally put your intermittent rod if you use a conventional technique, wide sides line. We then collect both the distal femur and the posterior femur independently. I think this is a very important point, so what we're able to do is collect it a lot more accurately than other systems which collect the distal and posterior points together, and in my opinion often do not collect enough points. And then the posterior femur medially and laterally. The anterior aspect of the femur, very important for sizing of the femur. And then we check our points, and you'll see it's very accurate. We can make sure we've got a very accurate model from this in all positions. So we're happy we've got a very good registration of the knee. We then perform the pre-resection soft tissue assessment to get the accubalance graft. We then flex the knee to 90 degrees, then externally rotate the hip to tension the lateral aspect of the knee to get the lateral flexion gap. We then internally rotate the hip to tension the medial aspect of the knee to get the medial flexion gap. Place the knee in extension and then correct the deformity so that we get the accubalance graft both in flexion and extension. So for this we can use the control planning. So what it does is default to measured resection. So the tibia at 0, the femur at 0, and 3 degrees of external rotation. From that we get the balance curve. We can see this particular patient who has a valgus knee that it is loose medially in extension and is a bit loose medially in flexion. So the next step is to manipulate the screen to the kinematic alignment. So we do a virtual assessment of kinematic alignment. What kinematic alignment is a true anatomic measured resection. So for this patient, the tibia is in 3.5 degrees of varus. We've taken 9 millimeters of bone off the medial tibial plateau and 7 off the arthrotic lateral tibial plateau. The femur is in 3 degrees of valgus. There is no articular cartilage loss of the posterior lateral femoral condyle, so the default limit is 0 degrees posterior condyle axis, and the femur is flexed 3 degrees. So that enables us to look at the balance consequence of a kinematic alignment knee. To implant a 6 millimeter spacer, we need 10.5 millimeter gap, which we don't get, so the knee will be too tight. And most importantly, you'll see that this knee is loose medially in extension. We then do our pre-resection planning. So what we're aiming to do here is to have a balanced knee. So we've got an 11 millimeter gap. So we've cut the tibia at 1.5 of varus to balance the extension gap. So we've got an equal medial lateral extension gap. We like to have our MCL equally tensioned through a full range of motion. We've got 11 millimeters here. We like to have 1.5 to 2 millimeters of laxity lateral inflection. So to achieve this, we're cutting the tibia at 1.5 of varus, planning for 5-degree valgus cut to the femur with 3 degrees of external rotation, 3.5 degrees of flexion of the knee, and 0.5 posterior. So once we've completed the planning, we bring the robot into position to execute the tibial cut. We then use the spherification tool and show this extremely accurate cut with exactly what we planned. This is a critical part of the technique now, is to remove any posterior soft tissue, or if present in particular, any osteophytes. We then insert the sense tensor. The knee is flexed to 90 degrees using the bone hook, which enables it to be inserted easily. It's very important to put it in flexion, so you can make sure it's very well centered throughout the knee. The sense tensor has 2 link springs, which enables us to determine the soft tissue tension through a full range of motion. We then do our post-tibial resection assessment. So with the tensor in place, we range the knee up to 90 degrees. But unlike the pre-tibial assessment, we do not rotate the hip, as the sensor tends to adequately tension the knee in flexion. So it's just range pointed up to 90 degrees, but then we do then correct the deformity and extension. So at the valgus knee, we apply various force to give us the AccuBalance graft to plan an optimal femoral component resection. This then enables us to determine the AccuBalance graft before we resected the tibia and after resect the tibia or soft tissue tensioning. There are a number of competitor systems which plan the implantation of your total knee replacement before any resections are made. In my opinion, this is flawed, because as you'll see from this particular case, that the AccuBalance graft changes. So before any cuts are made, we plan for this position by cutting the tibia and removing the soft tissue, and then osteoblasts are present. There's a change in the graft. So you'll see here an extension. Knee is actually 2 millimeters tighter medially in extension, and there's a much bigger gap laterally in flexion. So what this technique enables you to do is cut tibia, remove any soft tissues, then tension the knee through a full range of motion to determine the optimal placement of your femoral component. We then use the femoral component planning scheme and the AccuBalance graft to determine the optimal placement of the femoral component. This knee was too tight to medial in extension, so we applied more varus to the femur to balance the extension gap. Our extension gap was then too tight, so we've taken more distal femur to get a 10.5 millimeter gap. We then rotate the femur to have a balanced flexion gap with slightly more laxity laterally in flexion. We then have a balanced extension gap and a balanced flexion gap, but our flexion gap is much bigger than our extension gap. So we then equalize these gaps by flexing the femoral component to have a balanced gap through a full range of motion. So to do this, we've flexed the femoral component 6.5 degrees, posterior to 1.5 millimeters, so we use the AccuBalance graft to have a balanced knee through a full range of motion. So here we see the Vellus robotic assisted solution in place, and with the saw, you just let the robot do the work. It'll take you to the right plane. If you try and force it, it'll stop. And it's important to complete the entire cut rather than moving across an ML direction. You'll see here we've basically addressed each femoral condyle separately, and that's the best technique to use. We then validate the cut and show that it's extremely accurate. We're now making the anterior cut. And again, you'll see we just let the saw do the work and move in one plane. We validate this cut and again show it it's extremely accurate. Posterior condyles. And finally, the posterior chamfers. And the anterior chamfer. We then take the robot and you'll see how we can move it to the head of the bed so it's out of the way, so it enables us to trial the implant, cement the implant and close the knee without any interference from the Vellus robotic assisted solution. We're now trialling our turn down, so you get an excellent fit of the implant on the bone. And then we check the stability using the balance curve to determine whether we've got an accurate implantation. And you'll see here, we've got a beautifully balanced knee as planned. Thank you very much for the opportunity to present this to you today.
So now we are ready for the live surgery second. We'll go quickly with the brief history of the second patient for the live surgery. And also I would like to invite Dr. Sanjay to join the table for moderation of the second surgery.
ये जो केस 2 है ना, केस 2, हाँ ये वाला।
दूसरा भी नहीं हुआ क्या? मेल मेल में मंगवा लेते हैं तो सर
10 GB के
10 GB
स्टार्ट कर दिया ऊपर। अच्छा स्टार्ट कर दिया, ठीक है। मैंने ऊपर स्टार्ट कर दिया।
So, so this is the case details for the second life surgery.
Hello.
She is 63 years old female, came to us with complaints of pain in both the knees, with difficulty in walking, sitting cross-legged and squatting. She is non-case of hypertension, hypothyroid, and having tenderness over the medial side of the joint line more than the lateral side, and her range of motion was 0 to 90 on the right side. We are going for the right side demonstration of the surgery. So these are the lateral view of the X-ray of the same patient, and these are the medial OA deformed, varus deformed knees, AP view of the same patient. So these are the pic of the in a standing position, and these are the range of motion. As such, there is no fixed flexion deformities, and this is the walking video of the same patient. Okay. So these are the preoperative planning that we made through the CT scan of the same patient. We are taking on the femoral side, the distal medial, we are taking 8.5 mm cut, and distal lateral side is the 6.1, and posteromedial is 7, posterolateral is the 5, and there is no flexion we kept, and little bit axial rotation is about 2.7 from the posterior condylar axis. And on the tibial side, we kept medial cut to be 2.8 and the lateral cut to be 5.3, and slope is around 5. So these are the CT bone models. That's how we have planned this patient with the CT scan pre-operatively. So this is how the femoral side looks on the bone models. And these are the centers that points we have collected in the preoperative planning. Thank you. Now we'll start the live surgery session. Hello sir, Dr. Shekhar sir. Are
Yes.
you audible?
Yes, yes, Nikhil.
Okay, okay.
Okay. So, according to the plan, the femoral size is B and the tibia size is 2, but then it's a dynamic thing, and while gap balancing, we'll see that if any changes need to be done. So, we'll start the registration. So, the medial epicondyle, yes. Go. Yeah. Go. Yes. 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 So the initial RMSE is 4.91, which is quite okay. It should be less than 10. Okay, start. You also have foot pedal, but here we are using a handheld device. Yes. Yes. Go. 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 Yes. इसको ठीक करो. Okay. So we have taken the medial parapatellar approach. Go. 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 Yeah. Yes. Yes. Go. Yes. 2, 3, 4, 5. 1, 2, 3, 4, 4, 5. Go. Go. Yeah. Yes. 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 Go. Yes. 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 Go. Go. So there are 40 points in the femur. To map it properly, yeah. Yes. Yes. Go. 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 2, 2, 3, 3, 4, 5, 6, 6, 6, 7, 7, 8, 9. Go.
So, what's the final RMSE?
It's 0.59.
Okay.
Go. Yes. Yeah. Now we go to the tibia. Collect. Yeah. Yes. Yes. Now, if there is cartilage, then you have to press it properly so that it sits on the bone. Yes. Go. Okay. Next. Then mapping of the tibial bone. Yes. Go. 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 Yes. Yes. Yeah. 1, 2, 3, 4,
So I think if your point is
5.
not correct, it will show as a red point. You can see
Yes.
that.
Yes. Go. Go. Yes. Yes. Yeah.
No, no, the way it is done. Sequence. 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 The
Go.
idea is to keep the points slightly away when you are mapping
Go.
so that you are getting the good morphed model of the
Go.
bone.
Go.
Yes.
Go. Go. Yes. Go. 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 Collect. 2, 3, 4, 5, 6. 1, 2, 3. Go. 2, 3, 3, 4, 5, 6, 7, 8, 9, 10. 10. So here the final RMSA is 0.67, which is again less than 1 which is desirable.
So what is the acceptable level for you for final
So
RMSE?
usually within 1.5 is okay, but we usually try to keep it below 1. Yes. Go. So now we'll do the gap balancing, which is the dynamic part of this process. So we'll see the gap in 90° of flexion. Okay. Oh.
4 and 6. No, just gently.
Okay, capture.
Can you make the measurement part zoom in?
Isko make this screen the bigger one.
So, Dr. Shrivastav, are you applying any stress while capturing these values, or you?
So I want to see the maximum opening on the lateral side.
Okay.
Okay.
So it is 6-4. Is
Yes.
that correct?
6-4 in extension.
Yeah. And 9-6 in flexion. Is that correct?
So at 90°, when applying, it is coming up to almost 7 or 8. Okay. Okay.
Yeah.
Again, capture 8. So flexion is 8.
Correct.
And extension is 6. Can you see the screen?
Yeah.
So what we'll do, we'll increase the extension gap, femoral implant,
Yes.
femoral shift.
There is a question from the floor. Dr. Arora wants to ask,
One arm.
the capturing is in with the stress or without stress?
The maximum is, no, capturing is without stress.
So no varus stress or valgus stress.
Yeah. Up.
So you are proximalizing the implant, femoral
Yes,
implant.
yes.
Is that correct?
Yes. One up. One up. Okay. So now you can see that our gaps are now quite balanced on the lateral aspect.
Can you zoom in on the gap balance screen, please?
इसको fit करो. Okay. Can you show me an artery? So can you see the screen now?
Yes.
Okay. So on the lateral aspect, it is 8 and 8.
Yeah. And flick.
Okay. Can you see here?
Yes.
So on the lateral aspect, it is 8 and 8. On the medial aspect, it is 6 and 6. I am quite okay with that because I know that once I remove the medial meniscus and there will be some opening and it will become almost equal.
So you are happy with it?
I am happy with it, but what I will do, I will take my tibial component more proximal. I want to make it 7 because, see, these numbers may just tell you that it is balanced or not balanced, okay? But you have to also take into consideration the tissue quality. Now, in this female, I see that the knee is quite lax. The tissues are quite lax. So, I'll keep it less than 8 so that I can put a spacer of, say, 9.
So to begin with, I think what we usually do is to assess the hyperextension or
Yes.
of the knee before we open the knee. And if it is hyperextended, then probably we cut less proximal tibia.
Yes, if the tissues were tight, then I would have been happy with this. But here the tissues are quite lax, so I'll proximalize my tibial component. Tibia पे जाओ. Go to tibia. Tibial implant. Tibial shift. One up. Okay. So one more. So my colleague Dr. Nikhil wants one more, one up. So we will keep it there.
Okay.
We are happy with the balance now. Because this 2 millimeter of difference on the medial and lateral aspect, we know that once we remove the meniscus and all, it will get balanced automatically.
Dr. Srivastav, can you keep the knee in full extension, and if it shows something like -3 hyperextension, then I think your plan is correct, you know.
Zoom out. यहाँ से नहीं यहाँ से नहीं, साइड से दिखाना पड़ेगा आपको.
No, it's okay. You just show the screen. Yeah, it is going into -2 degrees. So you are correct. You will achieve about 2 more millimeters.
Yeah. Okay.
7 o'clock position. Yes. Proximal is the tibia. Because yes.
Pins. So you can use clamps to fix the robo, but here we'll be using the pins. It's just a question of personal preference. So that's the second pin, and you have to be slightly careful while putting this pin. Dr. Chandrasekhar showed the objective way of putting this pin. You put one finger on your tibial tuberosity and the other on fibular head and go in between. So now we'll bring the robo in. Camera, can you यहाँ से दिखाओ रोबो आते हुए. Full surface cut, yes. And someone can also focus on the screen. नहीं कर सकते, अच्छा ठीक है. देख के दे. So the positioning of the robo has to be accurate. There are few markers which you have to see on the screen that its angulation and its position is perfect in position to the limb. So there is a, it's not that it has to be exactly in proper position. There is a range, and if it's within the range, then it's fine. You have to bring parallel to the joint line. Okay, ठीक है.
I think Dr. Shrivastav, the table can go up to the roof so that it will come. Yeah.
Okay, done. Lock.
So you are happy with the RX and ROI?
Yes. Can you show the screen there? अब इसको स्क्रीन को वहां कर लो. एक कैमरा उस स्क्रीन को दिखाओ.
So nothing should be in red. RX ROI. Otherwise the
अच्छा ठीक है, दिख रहा है. ठीक है. Okay.
No, I think.
Then you fix the robo with these clamps. Probe. Yes, check position. Okay,
So that's the registration of the robot with the marker.
कैमरे की पोजीशन ठीक कर दो. Yes. उसकी पोजीशन ठीक करो, ओटीएस की. ओटीएस को चेंज करो. सेंटर मिलाओ. हाँ. टी में मार्क करने. बस ठीक. इसको बेस क्लीन कर. Yes.
Yeah.
Then we validate the femoral points again.
So here your acceptable limit is less than 1 millimeter, Dr.
Yes.
Shrivastav?
Yes. Okay. Yes.
So when usually the femur is being cut, you cover the tibial areas so that water does not go on that. Now there is no role for a tibial area now. Yeah, that's what they had done.
Okay, start.
So Dr. Shrivastav, you use new burr for all the patients. We usually use it for about 3-4 patients, unless the patient is very well built and bilateral knee.
So same way everywhere. So the company advises to use a new burr every time.
Correct.
And I think it does add to the accuracy, and perhaps it's also better for the longevity of your machine.
Correct.
But then we know that in India nothing is disposable.
Correct. But bilateral knee, male good built patient, I think better to use a new burr.
There you have to use a new burr. But speaking from experience, I can say that usually this burr lasts for 4 to 5 cases in females.
Yeah, correct.
4 to 5 knees.
About total disposable and burr about 10 to 12,000.
So that finishes the distal cut.
While these steps are being done, ask your assistant not to touch the table or whatever, because that slightest of the movement, the burr will stop, the robot will stop. So they should be away from the table. Everyone should be away, yes.
So that usually happens. Sometimes in obese patients, sometimes they breathe very heavily, and then it becomes a challenge.
I think
Because
our
yeah, so in that scenario, we have to take help of our able anesthetist friends.
the one trick which we have found useful, Dr. Srivastav,
Yeah.
is when the obese patients or if there is too much of abdominal movement.
Yeah.
In fact, people from Shalby were visiting us, and the patient had too much of abdominal movement. I think one of the trick is the anesthetist should keep talking to the patient continuously. Then the abdominal movement comes down. I don't know what is the physiological reason for that, but if they keep on talking to the patient continuously for those 15 minutes, you're okay.
So do they charge extra for that?
No. one cup of tea after the operation.
Okay.
Yes. For some reason it becomes less.
Mop, clean mop. नहीं छोड़ता, रहने दे. So the surface which you get here by this burr, the milling tool, is quite smooth.
Yeah, that is correct.
And secondly, as I have seen that, especially once you do robotic, the implant fits very nicely.
In fact, unfortunately, our bones are not good, and uncemented total knee is not in fashion here.
Yeah.
But I think the fit of
That-
the femur
yes,
is very
yes.
good.
I think one indication for robotic knee will be uncemented TKR, because here you get accurate fit, absolutely accurate fit.
And I hope the Merrill people will bring the unicompartmental knee also, because that will be boon actually. You don't
Yeah.
have to touch any tissue. Just burr, trial the implants and put the actual implants.
So the posterior chamfer cut. So once when the burr is taking the cuts on the medial aspect, it usually goes from medial to lateral, as you can see. When it is taking cuts in the lateral aspect, the lateral condyle, then it goes from anterior to posterior. It is coming from medial aspect, but the burr is moving from anterior to posterior.
Yeah, that is a safety feature for the
Yes.
patellar tendon actually. But still, I think very aptly they have put the radius ulnar spike or something on the lateral side. Turn it.
So that completes the chamfer cut.
One of the best advantage what we observe, unknowingly sometimes we took a femoral component flexion and later on see an X-ray.
Correct.
You don't perceive robotic, you see ruled out.
Even scanograms and tibial cut, at least in my hand, sometimes we are not very happy in conventional tibial cut, you know. Either udhar thoda, especially sometimes 0-degree slope or reverse slope. There is no possibility of that in this. See, the moment it encountered the tissue, it stopped.
So sometimes what happens that if your tibial spine is very prominent, then it may impede this cut. So the trick is here to remove this tibial spine, but then you have to do it only after registration, not before that.
Dr. Shrivastav, as a rule, we always remove the posterior chamfer bone and tibial spine before this step.
Yeah.
As a rule, as a workflow, to prevent any stoppage of the burr, or should have a good unhindered access of the burr for posterior cut. Tibial spine. That's it. And the posterior chamfer bones. If you are cutting tibia first, then it's not needed. So again, this is I am not a salesperson for Merrill, but this is the only system which allows you lugs, and this is the only system which allows box, if you are a PS surgeon.
So
no, then you have to put the trial. In Velis, you get up to here, everything is by saw, then you put a trial, and like normally what we do, reciprocating saw and this particular bone comes in the way of the burr, so ask your assistant to remove that, that bone in the, so that the flow is smooth.
Pause.
Yeah.
Go.
Yeah, you stop the burr, remove it, and correct. You can keep this bone just in case if you want to graft somewhere.
Okay. Suction. So the femoral cut is over.
Yeah, that was very smooth.
Probe. Okay. Okay. So the tibial cut will be taken in two parts. First again will be the medial part, where the cut will go from medial to lateral, and the second part will be anterior to posterior.
At this point, Dr. Shrivastav, sometimes we use our suction as a retractor for the medial collateral ligament.
Okay. suction. So the patient curved a bit.
Yeah, that's why it immediately stopped. So
Yes.
it's one of the safety feature. Little bit of movement of limb, it stopped. Okay, okay. Mako system, you will not go beyond the haptic boundary. Velis, you can go beyond the haptic boundary. Velis, you have to be careful. See, some surgeons are courageous, some surgeons are timid, you know. Yes. Let us have first 200 cases, then we will progress. Yes.
हाँ देख लो. ठीक है? Okay, start. So the patient was nauseating and that's why she was moving a bit. But
So
now
that's why you
yes,
stopped, Dr.
yes.
Shrivastav. Yeah. Dr. Ladda, Shrivastav sir is cutting completely.
Okay.
So fantastic. Now you'll detach the robot. Now
Yes,
at
we
this
detached the robot.
You put the femoral pins through the incision or at the top?
At the top, not through the incision.
Okay.
So again, these are individual preferences.
Yeah, I also put it on the
Yeah.
top actually. Because there is a small possibility that they may come in the way of the robot actually.
Yeah.
If you put through the incision.
And sometimes you have to also increase your incision to accommodate those pins.
Yes.
इसको नहीं निकालना भी है ना. Okay.
So
Oman.
So now you will clear all the bone
Yes,
loose
the
pieces
remaining-
and everything.
yeah.
Put the trial implantation and again check the gap.
Yes.
No. No. खुद करना पड़ेगा. Yes.
Clean mop. एक नीचे clean sheet.
See, 25-degree flexion deformity, you'll have to see after anesthesia how much it is getting corrected. And anyway, before the operation, I think while planning, you will cut.
टूर्निकेट नहीं काम कर रहा है. No, आप deflate the tourniquet. I think it's not working. नहीं, BP बढ़ गया. Just keep it there. एक sheet, clean sheet.
The drain. It makes me happy.
Table के height down कर दो.
Yeah, I think that is, yeah. Put the implant flexion and then release and then cauterize. And obviously standard tranexamic acid. Yeah.
Wash.
Yeah. That is standard. Now 1 gram on induction, 1 gram afterwards, and 500 milligram next day morning. So Dr. Shrivastav, femur has been cut very nicely, no notch.
No notch.
Absolutely.
Yeah. It's absolutely fine. Oman. Okay. Nibbler.
So there are some osteophytes at the behind that you are going to remove. Is that correct?
Yes. There is some bone on the lateral aspect.
Yeah.
So we'll just nibble it out. Curved osteotome.
So once you remove these osteophytes, you are contemplating that the medial gap will also become equal.
Yes.
In flexion extension.
Okay. So.
So meniscus you will remove completely or again keep part of it attached as a marker?
Just at the middle part, so I keep just a thin rim of meniscus intact because medial meniscus, as you know, is firmly adherent to MCL.
MCL, correct.
And that is one ligament which you don't want to tinker with.
So you are removing the posteromedial and posterolateral sliver
yes.
of bone, you know.
till now we haven't done any medial releases.
Yes.
Cocker or towel clip. Okay. Let's see the gap now. Lift. This will always remain, है ना? Lift the femur. Okay. So I can feel some posterior osteophytes. Those have to be remained. Those have to be removed.
So usually the robotic burr will not reach these osteophytes. Almost 90 out of 100 times you will have to remove those. Sorry? No. No. There is no digital injury.
Osteotomy.
You can check the cuts, but not like Wellis or you put something on the surface. It is accurate. Na? See, once you put the trial implants, it will give the values.
Okay.
Dr.
Enabler.
Shekhar?
Yes.
Sir, audience wants to verify the cuts
Okay, we'll
over
do that.
the femur side and the tibial side.
Okay. Cut verification tool. Lift. Lift.
Sujay, you use this tool? I never use it. Okay. Okay. Because normally, correct. In checking it now.
So I usually rely on my trial implants.
Because once you put the femur, come on now, we are all good conventional surgeons. You will see that it is fitting snugly well. No, if it but how the cut goes, yeah, correct.
Yeah.
Yeah, he's using that. Yeah. Yeah, that's fine.
Sir,
So
can you please zoom in the screen?
On the screen.
On the screen.
So we are verifying the distal cut.
Yeah.
The planned cut was 8.1 and
About
this
0.5.
This is coming around 7.9.
Yeah, you're okay actually.
And
Less than a millimeter.
Yes. So less than a millimeter.
Perfect.
Okay. Similarly, if you want to see the tibial cut,
so you have planned 2-degree varus, you are getting 2-degree varus.
robot marker, नहीं tibia marker नहीं दिख रहा. Tibia marker is not visible.
So you are happy with it?
Yeah. Okay.
Yeah, perfect.
Trial implant. So So it goes in quite nicely.
So it went very easily. Yeah, you're happy.
Yes, it went quite easily, but it's not lax.
So fantastic. 90-degree flexion, 10-10. Is that correct?
Yes. Can you see there?
Yeah. Superb.
सामने सट जा. Tibia marker.
Super.
Okay, this is extension.
Yeah. 9-10.
Almost.
Or 10-10.
Yes.
Perfect. Very nice.
Okay. So we'll now prepare the tibia and complete it because we haven't done the tibial preparation.
Yeah.
But we are quite okay with that.
Yes. Captured values 10-10, 10-10.
Yeah.
Fantastic.
Dr. Sanjay.
Yes.
So what I would suggest that you can please proceed for lunch.
Yeah.
So that we can start the next session on time.
Are there any questions? Quick, couple of minutes.
The one more talk of the previous session has been left. So
Okay.
we'll complete that talk, sir. I think.
Okay, okay. You can complete that talk.
Okay, thank you, Dr. Shrivastav.
Thank you.
Fantastic.
Thank you. Thank you.
Very nice demonstration. One talk is remaining.
So I
इसको
have
निकाल
been-
लेते हैं.
before going for the lunch, one talk has been left of the previous session. So please, Dr. Mukesh, over to you.
Sorry to make you wait for another 10-15 minutes. So after the beautiful demonstration of QVIS, which is a fully automated robotic system, I am here with semi-active. So I don't have any disclosures, but definitely some patient may say why to pay you, because robotic is doing the surgery. So we all know robotic is there to optimize the bone cuts.
बस ठीक है, पेशेंट स्टेबल है ना?
Audience, may I have your attention, please?
Ashish sir, may I start? So I'll finish up this one. So we were all discussing about what alignment we prefer to keep or what not. So QVIS is a fully automatic system which is total burr based. We saw Wellis, which is totally saw based system, and this Cori we have both option of saw as well as you can burr it out. So it's a semi-active where the robotic burr is in your hand and you burr it out. So you just need simple X-rays and a scanogram. It's an imageless system. So it takes an real-time image when you go in the room, and when you open the knee, you take the images of the femur and the tibia. Whatever approach you prefer, midline, medial parapatellar, or you prefer subvastus or midvastus, everything works. So in minor deformities, subvastus approach really works well. The only problem with that, you have to change the pin insertion site. You can't put it through the quadriceps, so you have to come from the medial side. If you are using medial parapatellar approach, you can come from the anterior aspect. I have not yet tried this in such a bad valgus knee where you know the ligaments are so laxed or stretched out. So in such bad valgus knee, I am yet to try it, but in varus I have tried. So here where you have to do medial epicondylar osteotomy and shift the medial epicondyle proximally, I have done this conventionally, and the take home is my conventional knee has also improved significantly after my robotic TKR because my understanding has improved more. So whenever I have to do somewhere conventional, that has also significantly improved. So this is simple Cori machine, a smooth entry and smooth exit. You can shift it from one room to other room, and if you want, you can take it outside to other theaters as well. So it's a simple machine which is mounted on a trolley. You can easily move, doesn't take much space in your operation theater, ergonomically and surgeon and OT friendly machine. Only that much. This is the small OT setup which I work in. It's 20 by 20 where the trolleys are on the foot end. The patient is draped and prepped and the machine is on the opposite side of the operating limb, which is lying there at a distance of about 6 to 7 feet from the operating limb. This is all what it has. So you have this Cori gun. This is for pin inserter. This is to make it tight. These are pins. These are all trackers, and this is the, you may say, a hand instrument which is there to map the femur and the tibia. This is all the machine about. So it has a wide angle of the camera which goes widely. They are not narrow, so they cover more area. This is the total console, and that's the gun which a handle which you can hold, and that's the tip burr with the attachment over there, and that's the trackers. So this pin insertion I do anterior-posterior on the femur as well as on the tibia. It's a unicortical pin insertions. On one or two occasions, I think initial days of my Cori Navio in 2018 late, I had 2 periprosthetic fractures, 6 to 8 weeks post-op. So I realized any patient complaining of thigh pain more after your navigation or whatever robotics, little slow on rehab, because thigh pain may attribute to some early stress rises. So be gentle when you have that thigh pain patient after your surgery. Go slow on rehab. So tracker fixation, again, fix it very well. See that they match their hexagonal edges. It should not move, because even a micromillimeter of motion may change your planning and whatever you are executing it. And make your machine know which is femur and tibia. So you have to do the checkpoints, femur checkpoints and the tibial checkpoints, so that the machine knows this is femur and this is tibia. And then you need to collect the centers. So to collect the ankle center, while draping, I only use the, what we call it, cling drape as well as a small soft roll, so that you can easily palpate the bony ends very well. Then take the ACL footprint, then take the knee center, and then you take the hip center. For hip center, be very gentle, don't rotate it fast. Pelvis should not move. If you are having some error while moving it and it's not getting green, so beyond 1 degree it won't take. So it should always be below 1 degree. So if it's going beyond 1 or 2 degree, 1 degree more, ask your assistant to hold the pelvis so that it should not move the pelvis. And then when you open it, I remove the osteophytes, especially one which is below the MCL on the medial femoral condyle, which is kinking the MCL. So remove as much as osteophytes which are visible anteriorly, superiorly, medially and laterally, so that it's a real-time image. So when you map, you get the exact size of the components. So the release is just up to the mid-coronal plane of the tibia. Don't go beyond mid-coronal plane initially. Maybe just anterior to the MCL attachment, and you don't need to do much. So with that only you can see, you can easily sublux the tibia to certain extent, not complete subluxation. And this is the real femoral mapping. So that the tip is a round tip, so it doesn't poke into the bone. It's a round tip. You just need to go around whole femur, keep mapping it, and it automatically rotates where your tip of that hammer goes, and you can map the whole posterior, distal, anterior, epicondyle, everything. So do a good femoral mapping, which takes hardly about half a minute. So you map completely intraoperatively. For this reason, to have correct implant size, remove as much osteophytes as possible. There are chances it may give sometimes one size above component, but then on planning you may reduce it to one size lower, because the associated osteophytes on the posterior aspect. This is femoral axis deviation. That's what it should be, the surgical epicondylar, transepicondylar axis. This is PC and you go to 0. So keep it to 0 degree rotation to start with. And that's the tibial mapping. You just need to map, even if you don't map the whole tibia, they have certain blue points where you can map. So you just have to hold a half subluxation, not complete, and you can see the whole tibia is getting mapped up. And this is the real-time mapping which is done intraoperatively. And now before anything, you need to see the tension in the collaterals. So this orange line below is medial collateral ligament from 0 to 120 degree, and the L, which is purple, is lateral collateral ligament from 0 to 90. So before we take the cuts, we see how tight is the medial compartment right from 0 to 120 degree with certain valgus force, and how lax is the LCL compartment with certain varus force. Now that varus force or valgus force may differ from person to person, but when I am using it, since on my patient I know how much I am using the force, it becomes static for all the patients there. So here you see the MCL is quite tight, complete from 0 to 120, as well as LCL very lax. So this is the graph what you get first hand, which below the line is tightness and above the line is laxity. So both lateral side is quite lax and the medial side is quite tight. So I am stressed now. First thing what I do, I start planning in the extension. So here you see I start putting the tibia and few degree of varus, and my MCL is automatically getting lax. So that much of releases goes down. So still 2 mm tight, and here is 1.5 mm. I prefer to keep first, as you know, balance the extension gap within the bone cuts. So I am shifting the tibia proximally and distally. So it's 8 mm, 8.5, and you can see the changes occurring there. So if there are too much of osteophytes, you need to keep MCL tight by about 3 to 4 millimeters. But here the osteophytes were not too much, so I'll keep it somewhere around 2 to 2.5 mm tight. Now I'll go here on the rotational side. As you see, my laxity on lateral side is too high, but medial side is not. So I start rotating the femur externally. So 4 to 5 degree of 5 to 6 degree of external rotation. This red mark indicates that you are notching the femur in the planning. So I rotate it, I reduce the flexion gap, it was notching, so I have increased the flexion component of the femur by half or 1 degree. So you can have all permutations and combinations here. So this is 5 degree of 3 or 5 degree or 3 degree here, 2 degree of tibial slope. So now you see you have balanced the lateral side very well. Now again it is notching, so I'll just increase the flexion by a half degree. So one click is half degree. So I have increased the femoral flexion for 4 degree, the femur and tibia and 2 degree varus. So this is what I have achieved on planning. So I believe in functional alignment of the knee. The coronal alignment should not go beyond 6 degree of varus, combined femur and tibia. The flexion or rotational should not go beyond 10 degree. If you keep 4 degree on femur, tibia might be 4 or 5 degree. And in sagittal plane, it should not be beyond 10 degree combined femur flexion as well as tibial slope. So this is what I have planned finally. I will keep it like this: 1 mm lax, 0.6 mm lax laterally, and little tight both medial in flexion and extension, because I know after I do my cuts there will be a bit amount of capsular release, and this 2 mm automatically opens without any releases. So the release will go down. And this is of another patient. So why I am stressing? Because planning is the most important part of any robotic TKR. This is another patient who was very lax completely. See, the MCL is completely lax from 0 to 120, as well as the LCL was totally lax. Everything above the line. So this is a very lax knee. Very lax knee to start with, without any releases, just exposure. So here you need to see everything above. So you need to minimize your cuts. So you start planning again. First, balance the extension gap. As I know, it was a hyperextension knee, so we need to take less distal femur cuts. So see that you plan at least 2 mm tightly on your robotics, because once you start cutting, the 2 mm open. So if you plan complete 0, 0, your 9 poly will suddenly become 13 or 15 poly. Though you will say ki I have planned well, but that was a lax plan. So here I planned everything very tight in the sense 2 mm to 2.5 mm. Avoid notching, and you can see the whole 3-dimensional how the femur is sitting and how the tibia is sitting before you plan. So planning is very important, and we have an option of narrow and standard in Smith Nephew. They don't provide any tibial rotation because their tibia is anatomical. Their medial is wider than the lateral side, so they don't have that facility here. And then you start executing. So this is how you hold the burr in your hand, just like a pencil and pen, and you can just pick the errors, or the trackers are so movable that even if you change the position, you can just rotate the trackers here and there. And then you start burring. So how it bursts? First I burr the anterior aspect of the femur, just hold it. So here you see there comes in various color. So once this white is the original bone, as soon as it reaches the white part, the burr goes inside the socket. It doesn't cut anything extra than whatever we have planned. So this red one is, if I have planned 9 mm, the pink indicates 9. The blue indicates 3 mm bone is still left, and the green indicates that 1 mm bone is still left. So you just keep to rotate the burr, it moves in and out. As soon as it reaches the white aspect, that means it won't cut more, it just goes back into the socket. So you just have to hold it like a pen, keep rotating it. You get the tactile feedbacks, haptic feedbacks, and you don't have to totally depend on the machine, though it's very accurate machine also. Same for tibia also, and this is what the accuracy is seen after cutting. You have a digital angel, so 0.1 degree to 0.2 mm variation of whatever we have planned. So you can cross check, and if you feel that the machine has done something wrong, you can go back to planning and come back and burr it again, but that rarely is required. Same way, see the way the femur sits, it's completely flushed with the bone. You just have to use 1 or 2 knocks and it's flushed with the bone. Believe me, I have used saw also with this system and burr also. The kind of fixation the components get with the burr can't match with the saw. The burring is so accurate and precise. And that's the way you do same for tibia also. Tibial burring, you just hold it. You can come from the top of the tibia, or you can do the tunneling technique the way the QS guys have shown. You can go from below. So tunneling technique usually I do whenever I feel I have to do some bone grafting. So I use tunneling technique. If I feel I don't have to use any bone graft, I just start burring it from the top, and you can see how it starts cutting. Once you are done this, you can go through full range of movement after you place your trial components and see whatever you have planned. Now that's the first case where it was complete tight medially. Now you see the hole even under stress, it's opening hardly a half a millimeter MCL and about a 1 millimeter of LCL. So that's the kind of balance even under stress you can get with Cori Robotics or any other. Then you do cementing. After cementing, some variation do occurs in the balancing. Believe me, some variation do occur because cement, if you don't press it properly, the tibia may go into maybe a not visible to a naked eye, but may go. So see that you properly cement your component and then again cross check it. I don't remove the machine only on the trial component. I cross check it, though I can't do anything after I cement, but just to have my knowledge so that I can't make the same mistake in the next patient. And that's the final thing. So see, it's hardly 1 millimeter lax on medially as well as laterally, even under stress ROM. So that's what we want. We don't want 0 at all, because the knee will become too tight. And that's the stability you can see on table. That's the anterior-posterior stability, and that's the ROM you achieve. That's the patella tracking you get without any thumb. So rotation-wise, so what I mean to say, it's individualized TKR, not fixed TKR for everyone. So that's the patient pre-op gait, that's the post-op with Cori Robotics. You can see the stability. To answer Sir's question about whether the satisfaction rate has improved, in my 4 years of practice, around 1000 knees, I'll say more than 90% of patients don't come beyond 3 months. So the dissatisfaction rate has gone down drastically. Though I have only 4 years of results so far, but I can say this, and you can even use this CRNE in this complex system. So this is the final chart what you get after you finish your surgery. You know what was the component placement, you see the pre-op tightness, you can see the post-op, what you have achieved, what you have planned, what you have achieved, everything, the flexion of femur, the tibial slope. Everything for your data is there. So you can play for functional alignment and you can get good results with CRNE even in such kind of bad knees with the implant already in. And this is what the patient 3 to 4 weeks after bilateral, my own dad. So robotics works and is going to stay. Thank you. Fixed deformities, yes, that's pre-op. So you will have very tight MCL. So you can play only up to certain range. As I told you, you can put 3 degree and 2 degree. After that, you have to do releases. Don't take home that the releases are gone. No, releases depend on pre-op how stiff knee it is and how flexible the knee is. So any stiff knee, you still need to release and balance it. Robotic won't take care of all releases.
What is the acceptable limit you will accept? 1 or 2 millimeters max?
1 millimeter on the medial side and up to 2 to 3 millimeter on lateral side, because what I believe, on one side we are dealing with the ligament which is on femur and tibia, and other side is on fibula and femur, so they can't be equal. So if my MCL is 1 mm lax, even if the LCL is 2 to 3 mm, I'll accept. Yes. Yeah, it gives the red dot, but that means in osteoporotic bone, either you are pushing your burr too much. So you don't have to push, you just have to hold it. It does its own job.
I think the burr automatically withdraws.
Automatically goes in, as I was showing you, it goes in the socket.
It will not allow you in the red zone.
No.
In the last slide that you showed, there was a lot of tightness and firmness in the anterior dorsal after you implanted in the last slide.
Yes.
So do you always keep it, your knees, even under anesthesia patients that tight, or you would like to have 1 mm step of anterior?
That patient might be, but if you see under, I can show you that this one. So if you see the graph of this patient, sorry, it was not that tight on the graph.
Basically, I'm just asking that what is your
1
idea
mm,
after so many
not much either. See, it's very difficult to see 1 mm, but if after flexing and giving, if my graph is showing it's 1 to 2 mm and this is also showing 1 to 2 mm, I'll leave it. If graph is showing I am tight and this is also tight, then I'll do some posterior relief.
any case you feel that you need to intentionally keep it too tight or relax slowly?
So in that one, when you have a chronic PCL knees, where you have some lax initially to start with. So when I start my knee, I just check anteroposterior laxity before even taking the incision. So if I feel it's lax, I'll posteriorize the femur, make the flexion gap tight, not too notch, I'll flex the femoral component. So in that case, I'll prefer to keep it little tight.
The last one thing, have you ever had your patients who you kept little lax come and complain to you that when they get down from the staircase, they feel this little bit weak of you?
Not that, but if you see in Korea or I don't know any other, post-op graph, when it comes, it should always show 5 degree of flexion. Why? Because it's calculating from the femoral head. So femoral head is anterior. So on graph, final graph, if you are seeing it's a 0 degree, that means you will go into hyperextension post-op. So you should be at least 5 degree flexion at the last, because you are coming from the center of femoral head. So 5 degree flexion in that last, if it's not wrong, yeah, here, if you see the range, sorry, it should be 5 degree flexion. Okay, it might have gone from here. So finally, okay, is it playing? Yeah. So when I extend it, it should be at least 5 to 6 degree. You can see that 5 degree of flexion, I'll accept it. If you go up to 0, your knee will be in hyperextension and then the patients will have complaint. So you need to understand right from the basic, because you are calculating the hip center. That is.
Any special tricks of you do CR?
Yes, I started doing so far.
So any special tricks to prevent damage to the PCL while burying?
There is a two-prong, yeah, and but I have put the burr even on the soft tissue just to see it doesn't cut.
It will stop.
It will stop.
So there is a protective.
Yes, it doesn't do anything to soft tissue. Means while doing my femur cut, invariably 2-3 times I just do. Let's go to the surrounding muscle. What it does, it doesn't do anything.
And you put a deep dish here.
No, normal one. If it's too lax anterior-posterior, then use deep dish. I think deep dish is because we have asked the company to make something for our failures, and that's why we believe this will work. But definitely that is giving more stress on the poly. So if you have not balanced it well, then deep dish is there. Right, sir. Thank you.
Thank you so much, Dr. Mukesh. Now we will proceed for the lunch at the basement.
We all orthopedicians are, none of us are like bookworms, and we don't want to keep things as complex as this gentleman Chatur said. And let all of us stay with this idiot and makes life simpler and learn something from the machine, so that we can make even our convention much better than before. So this is the different kind of knees that we encounter in our population. So none of the knees are similar. And the problem is we are trying to give the same traditional TKR to every kind of knee, and we are putting the similar type. So this is a problem that we normally have, that there is an intra or extra medullary rod. You are taking a standard femur cut with a 5-degree valgus or 6-degree valgus fixed. You all know that every alignment is different, and you are having a large margin of error with this. And you are doing a ligament balancing after the bony cuts are made, and many of the times you are in trouble. You will not be able to balance it because your cuts are already been made. You don't know anything prior in advance how this knee is going to behave. And this is what we normally hear from a traditional OT when we do a TKR. The alignment looks good to me. So who measured? And what alignment you are talking about? In a 3D plane, is it well aligned? And you don't have any of these, and we say alignment looks good to me. And the second thing is, knee, everyone says, yeah, knee is very well balanced. So have you measured it? And what's the limit of that almost well balanced? And with what precision you say that? In which range? You really don't know. So this is what a normal traditional TKR normally happens. Many of the time it's good, more than 80% of the time it's good, but the problem is it is less accurate and less precise. So many of the inventions came in, many of the technologies came in, and you gained little bit of precision, but again it is not accurate. And all of us wanted our surgeries to be as accurate and precise as it could be. So this is what the target of every single surgeon is. So how to achieve it? So shall we go with an a la carte approach? A constitutional varus is so common in our population, and this is how a mechanical axis looks like of patients, those who have a constitutional varus. And you know that the Oxford people have come up with their study of survivorship of almost 30 years in more than 90% with no alignment correction. In unicondylar, they just look for whether the medial side can be opened or not. That means the MCL is not contracted, your ACL is functional. With those two criteria, accepting whatever the alignment the patient is originally having, they publish their survivorship of more than 30 years in more than 90% cases. So alignment can be accepted in that way. With this principle, Stephen Howell came and started accepting extremes of alignment. 10-year survivorship of Stephen Howell studies was good, but again there are plenty of studies which says some of the problems with accepting extremes of alignment. So that's your unicondylar alignment in unicondylar, and that's the kinematic alignment. Now coming to the hybrid concept, this is what I told. In restricted kinematic alignment or adjusted mechanical alignment, you accept a reasonable pre-arthritic level of laxity in the knee. That means you never aim for a Fujisawa point, or you never aim for a middle of the interspinous sulcus. But accepting some amount of, and accepting a reasonable good alignment within 5 to 6 degrees of varus or within 3 degrees of valgus is a acceptable thing. And the systematic concept, of course, that is what we follow in conventional things. It can be applied in the other hybrid concepts can also be done with these two concepts in place. So this is the latest one, the 2023 Bone and Joint Journal, and they publish the language of knee alignment has been changed. And this is a recent update of definitions and considerations for reporting outcomes in total knee arthroplasty based on that. So they have considered this functional alignment, mechanical alignment, unrestricted kinematic alignment, and adjusted mechanical alignment, and how well you can utilize your machine to achieve these kind of newer alignment philosophies. So this is what many of we orthopedic surgeons get to have these kind of cases. Advanced OA, there is significant medial tibial defect. Lateral condyle apparently looks fine. Significant lateral or varus thrust with lateral side laxity. You do a thorough medial release. All the contracted medial structures have been released. You do a reduction osteotomy as well, and then you end up in having a very good, well-aligned X-ray. But we should accept that many of the time they do well. But the problem is you are actually changing the kinematics of that knee. The biomechanics changes, and we really don't know how that knee is going to behave if the biomechanics is changed. So the million-dollar question comes, whether the improved radiographic alignment will improve functional score and survival. Of course, it is not directly or related. Improved radiographic alignment will not correlate directly with an improved functional score and survival. So that has been predicted in this study with more than 1200 patients, predicting dissatisfaction following total knee replacement. How much ever good X-rays you produce, how much ever technology helps you out, the problem is up to 20% of patients are not satisfied. Alignment matters, of course, but I should say that alignment is only one equation in getting a good total knee replacement. Mechanical aspects of malalignment really into implant failure, all of us are aware of. So the problem is how well we can improve this concept of alignment. You place the component in a different way in coronal plane, sagittal plane and rotational plane. So if you get all these plane correct with respect to your knee, you're going to create a better TKR for your patient. This is what has been published based on the total knee arthroplasty on a studied on a three-dimensional morphology. So what are the challenges? Accurate component positioning, perfect, I should rather say optimal alignment and proper soft tissue balancing is what we need. And so if you're going to do it, let's do it right. So what are our concerns? The number of TKRs performed are increasing exponentially. Revision rates are increasing in conjunction. Patients' age is decreasing, but the demand and expectations are increasing. And failure mode is changing. Early revisions are increasing. So these are all, being arthroplasty surgeons, these are our concerns. So to address these concerns, these much technologies have come up, like patient-specific instrumentation, custom-made implants, accelerometer and navigation, then robotics, and what should be the future. That's the next one. So just brushing through this patient PSIs. This is a preoperative 3D imaging used to model the knee anatomy, and they're designed personalized surgical plan with respect to bone resection, component position and alignment. The thing is, these many publications have given that alignment outlays have significantly reduced. Femoral component rotational accuracy was not great even with PSIs. No difference in clinical or functional outcome with PSI versus normal traditional TKR, and no significant reduction in surgical time. So that didn't get the popularity that it was expecting. Now coming to the individual knee arthroplasty implant, the custom-made implants. Matched with pre-arthritic knee anatomy, they used it. Ligament balancing seems to be simpler when you use customized implant. Satisfactory achievement of planned femoral mechanical axis, tibial mechanical axis and HKA. And there was less outliers, but there were multiple studies which says improved functional scores were not that great. Then came this sensors in the knee system. That was originally intended to improve the ligament balancing. Sensors were placed inside the soft tissues and the tibial base plate. The feeling was totally different with respect to obesity, gender, generalized laxity, degree of joint contracture, surgical experience, etc. And even the surgeon's daily condition was also affecting this. So the sensors were adding and giving some data on soft tissue balancing, and they concluded that when this was applied, 74% of the knee needed additional balancing or rebalancing procedures with the sensor after conventional balancing. That means there is something more to add on from your conventional method of balancing the knee. Now came the accelerometer. It's a early navigation tool developed to improve the alignment of coronal alignment of femoral and tibial components. It's a portable surgical navigation system that didn't use or console of TKA. resulted in good coronal alignment, but no advantage for sagittal alignment and no difference in functional scores. Then came the one which stood in time for almost 20 years. They came the computer navigation. It's one step ahead of the accelerometer. Along with alignment, they considered the real-time gap check. So it's like this. You have a car. Inside the car, you use navigation system or a Google map or maps, and the satellite connects these two, and you get the desired target of having a good navigation with you, right? So the car is replaced by the sensors that you are going to place on the femur and tibia. This is the console which we uses to get the sensors done, and the sensor detects all these things. So these connections will make how accurately you can place your component, at the same time giving a real-time gap check. So in my practice, I follow a neutral mechanical axis. I'm not against that, but I'll personalize with a hybrid alignment concept, which will result in my functional alignment, and I'll try to stay within the soft tissues always. So just an example, this is a case with a 23-degree net femoral tibial mechanical axis varus. So when I measure the MPTA, it is 83-degree MPTA and a 91-degree LDFA with around 4.3 degrees of posterior slope. So I have, if I take it as 87, I have 4 degrees of tibial varus, around 4 degrees of femoral varus, that means 8 degrees of bony varus, and around 13-degree intra-articular varus. So how well you are going to correct this and place your knee? So we'll take a spectrum rather than sticking to 87. MPTA 85 to 90 can be considered as normal. LDFA 85 to 90 is normal. That spectrum is always acceptable in any case, right? So less than 85 tibia MPTA is considered as varus. More than 90-degree LDFA is considered as varus, right? So I'll measure the MPTA as X. Then if you are handling a varus knee, then 85 minus X is the tibial side varus. Am I right? So to be on a relaxed spectrum, I don't take 87. So anything less than 85 is considered as varus. So here we have 83. So 85 minus 83 is the net tibial varus. Similarly with LDFA, I'll measure LDFA as Y. If my LDFA is more than 90, then Y minus 90 is my femur side varus. And I'll accept only 3 degree on either side. Right. So 91 minus 90 is again 1. So that is my femoral varus. So it's not the 8 degree there. And I'll accept only a combined varus of 5 or less than 5. So if I need to get this, if I need to get this formula done to achieve my functional alignment principle, I need something extra compared to navigation. Most of the things can be achieved, but a real-time feel of how to achieve this is lacking in the normal navigation system. This is what I wanted to accept. Like you all know, anything which comes new will have some protest against, no, because even the whole invention of wheel was protested. So there comes the role of collaborative intelligence, where humans and artificial intelligence are joining forces. Humans and machines can enhance each other's strength. So navigation with more accurate surgical execution, that was the whole principle behind introduction of robotics. As you all know, technology adoption is on the rise. 21% of American Association of Hip and Knee Surgeons group has been shifted to robotics. Even the Australian registry is marking a significant steep rise in the adoption of technology. So these are the systems: passive system, semi-autonomous system, autonomous system. We had a good discussion about all these things in the morning. I'm not going into the future. Just wanted to highlight this. Semi-autonomous, robots are controlled and manipulated by the surgeon. So that's an advantage as well as a disadvantage. But the surgeon's control is modulated by the robo to limit the bone preparation to the surgical plan. The advantage being surgeon's accuracy is increased, at the same time decreases the risk of errors. But if you can trust on your machine, autonomous robo stands superior because it takes the full cuts as per your plan with utmost precision. So that was the beginning of the new era, the static plans, computer navigation and the robotic assisted surgery. Now, what are the dissatisfaction elements here? It's one is infection, overhang and oversize, internal scar formation, persistent synovitis, component micromotion, neuroma, malalignment and patellar problem. These are the commonest reasons for dissatisfaction following TKRs. So can robotics help bridge this gap? Of course, robotics is not going to address each and every point that we have mentioned here. So what are all they? Infection, robo has nothing to add, nothing to less or nothing to add or nothing to deduct. It's equal. Overhang and oversizing with the robo, it's almost impossible that you oversize or undersize. You can have the best fit, best precision model. Internal scar formation, of course, with the active robo in place, with a 6.2 mm precise milling tool, it's quite unlikely that you will end up in having some scar formation, some micromotion at the component interface, which is quite uncommon. When the surgery is executed in a precise disciplined manner, probability that you end up in some instability is very, very less. Metallurgy or hypersensitivity, nothing to do with robo or conventional. Component micromotion I have mentioned, of course expected to be very less in a well done robotic knee. Neuroma formation again related to the way you dissect it out. In a robotic knee, since the releases are less, dissection is going to be meticulous. We don't have to do anything in more than 90% of the cases. Chances that these things will develop is very less. You follow functional alignment principle or whichever alignment your philosophy allows you is fine. You definitely are not going to end up in malalignment. Patellar problems is of course expected to be less with when you are done with your alignment as well as rotation, both in component placement in coronal, sagittal and rotational plane. If you are right, you won't end up in that. So with the machine allows you to be very like simplicity, flexibility, safety and accuracy. You are all aware of these points with respect to the robotic. So what are the clinical evidences in this regard? The patient reported outcome PROMs are excellent in the short-term studies. All the reported 2-year short-term studies, PROM was significantly superior in robotic knees. This was from the great Parvisi and Shark et al. Robotics in hip and arth. He actually was checking in his study whether it's a marketing ruse or a real innovation, and that he concluded that all the points that we are mentioning, if we could prove it, then becomes a cost effective in future. The rewards to the industry and the patient would be substantial. With respect to the component placement accuracy, they compared the tibial alignment, tibial slope, femoral component alignment and femoral rotation was much better versus manual. These were the studies undertaken in this regard. Restoration of joint line and mechanical axis, Journal of Arthroplasty 2014. They given like improved restoration of joint line and greater accuracy and precision to plan compared with manual techniques. This was the postoperative pain and opioid use. The VAS scale at 2 weeks and 6 weeks post-op was significantly better on robotic assisted total knee arthroplasties. And then soft tissue protection. None of the studies have shown that this soft tissues are at risk when in a robotic assisted knee. Regarding stiffness, robotic assisted total knee patients had a 4.5-fold decrease in the MUA rate, manipulation under anesthesia rate. This is improved early function and earlier hospital discharge. Opiate consumption was much less in robotic assisted knee. There was short-term improved range of motion in robotic assisted knee, earlier hospital discharge. So this is just wanted to conclude. This was from the Atul Gawande's textbook, or not textbook, is book of complications, that a surgeon's note on imperfect science. To fail to adopt new technologies would mean denying patients meaningful technical advances. So once a new technology rolls over you, and if you are not part of the steamroller, then you are likely to become part of the road. In conclusion, the philosophy has changed. Planning is substantially more accurate and personalized. There is less dissection, less exposure and less trauma to soft tissues.
It consistently reproducible accuracy and precision and soft tissue balancing, decreases recovery time, thereby improving outcome and longevity. And since we have mentioned all these things, what is going to be the future in arthroplasty? This is the hopeful and probable one. A dynamic MRI can be done at the age of 20 to 30, wherein we capture the real-time data till lifelong. So it's a dynamic MRI. So your soft tissue behavior pattern is well understood. And then an MRI and CT is taken when that individual is ready for a TKR, and then the data of their soft tissue and bony behavior has been done, and robotic TKR should be done based on that. And there are studies going on in customized smart implant with chips and sensors placed inside the base plates, tibial base plate, and once the behavioral pattern is done and the soft tissue biomechanics is understood, the robotic execution of arthroplasty is going to be there. So now it's for us to decide whether you want to use the map which is given on the left hand side, or you want to use the map as given on the right hand side. Thank you so much.
Excellent talk.
Excellent. The second talk. You have another talk with you, I suppose. Soft tissue balancing with robot.
I think I'll do it after the complex piece.
Okay.
Thank you. Now, okay. So till now we have discussed cases and we have seen the relative benefit of the robotics over conventional. Okay. But then there are few cases where the robotics gives you definite advantages over the conventional techniques. So we'll be discussing few cases where the robotics have got clear-cut advantages over the conventional techniques. So she's a 57-year-old lady, difficulty in walking for a couple of years, has got deformity in both the knees which is gradually increasing, and no significant comorbidities. So if you see this X-ray, this patient was actually having valgus knee on both the side. On the right side, varus correction osteotomy was done, but it was overcorrected. So it's a iatrogenic varus on the right side and a valgus knee on the left side. These are the lateral X-rays, and that is the clinical picture of the patient. So the right side is in severe valgus, the left side is in varus because of the surgical. So if you see the X-ray on the right side, basically the whole condyle has shifted medially. So this is a scenario where if you want to do a conventional surgery and if you want to put your jig inside, it won't go into the center. It will go somewhere like this. So this is a condition where doing a conventional TKR will be a challenge. Now cases like this can be managed quite easily on robotics because you can plan your surgery much better. You can plan your cuts accordingly. So that was the planning on the left side for the valgus knee. So we thought of giving a mechanical alignment of 0 degree, no valgus, though now the studies have shown that you can keep them in up to 3 degree of valgus which will require less release on the lateral aspect, but we decided to give a mechanical alignment. Now that was the cut which was coming on the lateral aspect. We all know that in a valgus knee the lateral femoral condyle is hypoplastic. So this was the cut which was on the lateral aspect, and similarly on the tibial side there were no cuts on the lateral side. So after the planning, the plan was fed into the robo and these were the cuts. So you can see that the lateral condyle was not touched at all. That is the trial implant, and this was the balance which we achieved after the implantation. And these are the x-rays. So the thing is that we could achieve the same balance with the minimum amount of spacer. Now this is, so even with conventional you can do that, but usually you will require a bigger spacer. So if you plan properly on robotics, you can easily do that. Similarly on the right side, which was more challenging because there was shift of the whole condyle, we planned our femoral component in such a way that we could achieve our mechanical balance. So that was our planning, and that was the post-op X-ray. So these are few of the situations where the robotics have got real benefit over the conventional technology. This is the same patient. Now another case, he is a 68-year-old male, got osteoarthritis of both the knees. Now he had subtrochanteric fracture fixed by DCS 10 years back, and on the left side also he was having a supracondylar fracture. So you can see that the patient was having osteoarthritis on both the knees, and these are the x-rays. So here you can see that the plate is extending right up to the distal part of the femur, and if you see the left side, the lateral x-ray, so it was very difficult to, it will be very difficult to pass your jig here. So again, these are the conditions where if you utilize the robotics, you can easily circumvent these problems and achieve a good balance and good implant positioning. So it was planned accordingly on the software, and these are the post-op x-rays of the patient. So that's another case with severe valgus deformity where the femoral condyle has gone deeply into the tibial condyle. And these are the final results. So these are the few situations where the robotics have got definite advantages over the conventional thing, especially in cases where there are severe deformities or where there are implants which will interfere with the jig positioning. So in these cases, I think and especially also in obese patients, like today you saw that while doing tibia, you don't have to bring the tibia out to take the tibial cut. So you take all the cuts beforehand, and once the cuts have been taken, the bone has been removed, then automatically the joint is decompressed and you can easily take out the tibia. So these are few situations where the robotics offers definite advantage over the conventional techniques. Thank you.
Excellent talk, sir, and very valid indications for robotics. Any questions?
Can I ask you a question in the last X-rays? Right side. I think you have a bigger poly is used. This is the same, you could have used this semi-constrained implant, I think 23 mm poly is there.
Not 23, it was 14 only,
14
but it was constrained.
Constrained poly, yes. It was a constrained poly.
done excellent
Okay.
cases. Thank you.
Excellent,
very much.
excellent.
Excellent cases.
I invite Dr. Nikhil Verma to present his talk on tips and tricks for registration.
All the best.
बात कर लेंगे क्यों से कि देखना है तेरे को बात कर लेना तो
And
चलो उससे बात करना हरी को बोलना हरी का
very good evening to all the delegates and the faculties. A very hectic day with the artificial intelligence. So my presentation is not a literature based. It is just we have evolved with the technology. So we'll be discussing on some tip and tricks for the registration for QVIS based system. So as we know, registration is a very important part in the robotic assisted knee replacement surgery, and the accuracy and the precision of the robotic arm surgery depends on the how accurate we are with the registration. So what is registration in the robotic surgery? It is the mapping of the femur and the tibia bones of the patient using the probe with the virtual 3D reconstruction model that already been created by the robotic software during the pre-operative planning. So total points that we need to collect in the QV system is the 40, combining both femur and the tibia, and how much accurate we are in the registration will be told us by the RMSE score. Initial points collection, RMSE, initial RMSE should be less than 10, and for final RMSE it should be less than 1.5. However, the company people says that it should be less than 2. So how to be accurate in registration? Sometimes it is the quality of the CT scan also matters a lot. Poor quality of the CT scan may change your RMSE. Pre-operative points collection during the intraoperative pre-operative planning with the CT scan should be more accessible and should be reproducible during the intraoperative period as well. And correct sites should be marked with the correct points, like medial points should be marked on the medial surface of the bones, and the lateral points should be marked on the lateral side of the bones. Any discrepancy will lead to change in the RMS in your intraoperative period. During the intraoperative period, we need to see that our tip of the probe is touching the bone. It should not be on the superficial soft tissue, and if possible within the cartilage deep up to the subchondral bone. Then you will get the exact RMSE and the accuracy with the registration. And we can also always counter check our final RMSE by touching the distal surface of the femur and the proximal surface of the tibia with the probe, and if it coming to be less than 1.5, it is acceptable. So these are the points that I was talking about during the pre-operative period. While collecting the points, marking the points with the CT scan of the patient over the laptop, these are the points should be in a more accessible position so that we can reproduce them intraoperatively. So, and these should be marked on the correct side. Sometimes medial points if marked on the lateral side, then total RMSE will change during intraoperative period. So always do vigilance in during the preoperative planning. And how to be fast during registration? So we usually start with putting the pins 4 fingers width away from the superior pole of the patella for the femoral pins, and 4 finger width below the tibial tuberosity for the tibial pins. This will give enough space for the robotic arm to come and take the cuts. Adequate exposure of the joint with minimal medial soft tissue release is necessary to give space to the robotic arm, and synovial tissue from the anterior surface of the femur should be removed so that we can touch the bone area with the probe. Also notch clearance also need to be done in the femoral side. We need to collect the points in the notch area as well, and the lateral and medial meniscus can be taken out from the tibia so that we can achieve the bony surface for touching the probe, and hold the probe steady with the both the hands. So like this, how to be fast during registration, we are putting the pins 4 finger widths above and down on the femoral side and the tibial side, and touching the probe with the bony area. And it is showing that synovium has been removed enough for the probe to touch the bony surface during the mapping of the bone during registration, and the notch clearance also needed to collect the points. So this is a video which is showing how we do registration intraoperatively. So we are collecting the points on the femoral side and try to collect in a single shot so that we can save the time, and holding the probe with the 2 hands is very necessary, making it more steady and touching every time over the bone, not on the superficial tissue. So then only you will achieve a good RMSC, which is in this it is less than 1. It is 0.74 for the femur side, and this is for tibial side. We're taking initial points, so initial RMSC should be less than 10. So in this, if you see, the initial RMSC comes to be 3.95, and this is after collecting the final points on the tibia, holding the probe again with the 2 hands, making it more stable and touching the bone every time. So this is how we'll get the good RMSC score, less than 0.56, less than 1. So this is how we can ensure also that we are accurate during the registration. This will influence your final accuracy and the precision with the robotic arm surgery. So conclusion, RMSC inversely proportional to the accuracy and the precision. Preoperative planning points should be more accessible and should be reproducible. Probe to be held with both the hands, make it more stable, and probe should always touch the bone surface. Thank you so much.
Nice talk, Dr. Nikhil. I invite Dr. Hassel to give his talk on soft tissue balancing with robotics. Any questions?
Approaching towards the end of the session, so don't worry, no more slides here. Okay, no more slides, absolutely no slides at all. Let's make it very interactive. So Nikhil has taught us how to do the registration part very well. Once the registration part is done, we are going to do the gap check, and what we are going to discuss here in this talk is the gap balancing. So absolutely, I'm not going to detail anything about what we do for a varus knee, what release you are going to do for a valgus knee. You're all thorough with that. How Robo is going to help in this soft tissue balance. That's the only discussion that we are going to do right now. Let's finish it in 5 minutes. So let's make it very simple. You have the femoral component, you have the distal femur, right? So let's talk about the degree of freedom that the component can be placed. Right? So you can distalize the femoral component, you can proximalize the femoral component. So you know that what change you are going to bring in the gap, right? You are distalizing, tightening the extension space. You are proximalizing, you are loosening the extension space. Similarly, you can anteriorize the femoral component, you can posteriorize the femoral component, right? When you anteriorize, you increase your flexion space. When you posteriorize, you are tightening the flexion space. This you can do in any method of TKR. You don't need robotics to do that. Robotics helps you to guide it with a millimeter precision. That's only advantage that Robo offers in this degree of freedom. Very simple. So now coming to the rotational profile. So you can, so this is your distal femur, this is your femoral component. Now you can flex the femoral component or you can extend the femoral component. So when you flex the femoral component, you tighten the flexion space, as well as that is the primary advantage that you get when you flex the femoral component, you tighten the flexion space. When you do that, you also get a increased extension space. So whenever you come across a knee where you wanted to tighten the flexion space and to get some freedom of extension, you can simply flex the component. You get both. So vice versa. When you extend the femoral component, you get the reverse. That means you get extra freedom on your flexion space and you can tighten the extension space. So that degree of freedom is also done. So that was my second. So distalizing, proximalizing, anteriorizing, posteriorizing is done. Flexing the component, extending the component is also done. Now the next level of freedom is you can valgize it, you can varize it. Right. So when you give a femoral varus, you accept a functional alignment principle there. Similarly on a valgus knee, again you apply the functional alignment principle on the valgus knee. And the beauty of the machine is, it gives you freedom with respect to the rotating origin as well. So if you have some concepts about that MPTA or LDFA, that means you can use this principle of rotating origin, hinging at what point you should valgize, hinging at what point you should rotate. Means you can do a femoral component valgus by positioning the hinge at the center or positioning the hinge medially or positioning the hinge laterally. Each of these 3 degrees of freedom will give you advantages with respect to the gap. So by producing valgus or varus, depending on the each case scenario, hinging on where you should do that. So this hinging principle will always also give you an added advantage on your bone preservation as well. Because if you don't want to take an extra medial cut, when you do a varus knee, you can hinge that point medially and do varus or valgus, whatever you want, so that you don't take any extra bone there. So this advantage of gap balancing in robotics gives you a definite grip over your gap bone preservation principle as well. Now the next level of freedom is your rotation. You can externally rotate the component, you can internally rotate the component, thereby tightening your flexion medial or flexion lateral as the value that the robo gives you after your thorough registration. So when if you are taking a varus knee, you have a lax lateral space. You want to close down the lateral space by increasing your rotation. If you want to be bone preservation, you can hinge medially and tighten the flexion medial space. If you have enough bone to spare, you can hinge laterally and then rotate. So you take extra bone from the posterior medial condyle and correct it. So that's all about the degrees of freedom with respect to each movement that you can play with your component positioning, thereby tweaking your gaps. Similarly on the tibial side, you can proximalize, you can distalize, because it affects equally on both flexion and extension. You can play following the functional alignment principle, accept up to 3 or 4 degrees of varus on tibia, maximum 3 degrees ideal. So accepting 3 degrees of error, 95% of the cases you can get away without any further release. I'm not telling that you should not do release, you can do release, but you can always minimize and create the native soft tissue tension ideally. So I'll just show you one case which I did yesterday, that's all. This is a video. That was a simple varus. Nikhil has taught you the registration part. Coming to gap check. When I did the gap check, it was 8 mm space on the lateral side. No, this was a bone on bone, no medial space at all. There was no flexion or hyperextension deformity. 7 degrees fine, matching to the anteversion at the hip. There was 11 degree varus initially. That was the space. That was by itself correctable with a simple valgus stress. That was correctable up to 3 degrees of varus. And then the spacing was 6 and 5. Okay, I'm done with that. Okay, so when I went into flexion, there was 12 mm space laterally, 6 mm space medially. Right. So that was even with the maximum draw that anterior force I given on the femur. So that was stretchable up to 11-12. So now I realize that I have a tight extension space. I have a lax flexion space. So with the permutation and combination that the robo offers you, you can play now. So straight away, I know that from the preoperative plan, I know that I have a reasonable freedom on my anterior side without notching. So I have shifted my component 1 mm posteriorly. So I have tightened on the flexion space. Now the red point shows the rotating origin 1. So I play with that red dot. I know where to hinge, and then based on that hinge, I'll play with my gap balancing. So I flex the component now to 2 degree. You can see still I'm not cutting excess from the posterior medial condyle. Right. So and I'm slowly opening my flexion medial space, trying to close down my flexion lateral space. Right. Now given a hinging at the medial distal femur, I have given 1 degree valgus on the distal femur, which I love to do because you know that 90% of the normal and distal femoral anatomy is in 1 or 2 degrees of valgus. Valgus related to the mechanical axis. So now you are tightening the flexion space again by externally rotating the femoral component, given 2 degree flexion, hinged laterally and given so I'm controlling my LDFA to less than 85. So that is closing down again 9. So now I went to tibia. I given hinging at the lateral point. Tibia hinging at the lateral point. I gave 2 degrees of varus. So my neutral mechanical axis is going to be in 1 degree varus now because I've given valgus on femur, 2 degree varus on the tibia, and now that is given because flexion space was still more. So I've given extension also. I've reduced the slope to 2 degree now. I do mostly PS knees. So anything between 0 or 2 to 3 degrees of slope is good enough for me. So now I'm checking the balance now. So that's it. See in extension, holding it in around 10 degree this thing. I got an 8 medially, and on my flexion space stretchable. You can see my picture in picture there. I given that force. So it's 8 8 8 8 now. Is that done? So sorry? No, that is when there is a inherent varus thrust is seen. Yeah. So when you position the knee on the table, depending upon the position you keep it, it is stretchable up to 9. But when you yeah, stretchable up to 9. But when I open the medial space to 8, it is equally balanced. Right. So that's all. Thank you. Sorry? It was, I put a 9 poly, 9 9 9 9. That was a balance. After implantation, you mean? No? No, this is my pre-op, this is the gap planning. This is only planning. Yeah, no further release because I've balanced everything before resection. I will check it. Definitely I'll check it because if once the tethering effect on the medial side on a varus knee, once you make the cuts, all the meniscus is out and all the soft tissue, once the soft tissue sleeve is released, you may have little bit of opening. Of course, you have kept something on the some stretchability on the lateral side. You may go from 9 poly to 11 poly. That's all. But in this case, I've managed everything in a 9 poly.
So this 9/6 is on stress. You have applied varus stress.
Yeah, it's going up to 9.
Okay.
going up to 9, I'm happy to accept 2 mm laxity on the lateral side. So with a 9 poly, I could not stretch it further. So this was like within a millimeter balanced.
You have taken flexion 4.5 as a chance of.
No, Chief. No, Chief. Flexion 4.5 helps to avoid no, Chief. Flexion of, up to 6 degrees of flexion is accepted. Component flexion is accepted. It won't affect you in any way.
Fantastic presentation. Any questions? Okay, good. So just to add to that, just to simplify, maybe very nicely told by Dr. Hassel, but if we are dealing with a varus knee, let's just to simplify it, we should just forget the medial side. We should try to balance the lateral side in flexion and extension. And because later on, while releasing the soft tissues and doing the osteotomy, we anyway will have balanced gaps in the medial as well. So we have to first look at the lateral side and try to balance the lateral side on flexion and extension. Next talk by Dr. Sujoy on CR knee with robotics.
Yeah, how many of you are doing CR over here?
That's the first question always asked, and nobody raises hands usually.
Yeah. Good. At least one guy is there to
with
understand me. Perfect. Everywhere the same. Same story is same. Because it's a good, I think.
Yes.
With robo also CR is possible. I think right now the age is coming, the age of CR knees. Although we want to increase our populations, we have very less populations as the minorities. So most of the conferences, we are very minority guys. Hope our population will increase. So good afternoon. So we'll start with this, the possibility of the CR knee with the robotics. And I'm telling you, it is very much possible, and you are doing regularly with the CR knees. And since the beginning of this robot, for the last more than a year, I've been using CR, and we have done more than 1,000 knees with this CR. So these are the all advantages of this CR knee. Something is coming here. These are the advantages of the CR knees. We have done more than 1,000 CR TKR with a cubis, all with 9 mm poly. It is not, I'm very selective surgeon. I do all type of deformities and deform. But issue the message is that is possible. Forget about 11 mm poly, that might need some of your expertise, because I've been doing CR around more than a decade. I've been using CR, only CR. So I might be little bit of experience to use 9 mm poly for that, because I have a very good idea, sense of how to balance with these soft tissues. But other than this 9 mm poly, all deformities of the TK you can come across with this CR knees. So no to cubis, whether sagittal coronal plane deformity is more than 30. You know what happens, more than 30 also you can do. In that case, you have to take the multiple cuts. If the sagittal plane deformity is more than 30, in that case, you might have to take first distal cut, then proximal tibia, then check the gap. If the gap is less, again you have to go for this distal femur. Or you can do it, you take all the cuts, where you go for this TK, then you don't remove the pins, keep the pins in situ. You go for the trial implant. You see the trial is tight and there is a still fraction gap is there. Again you connect the robo and you take the more distal cut. So that is possible, but it takes time. It takes a little bit of time. So more than 30, we just say this is the message to the house. So more than 30, better to avoid cubis. Now these are the things when I use. Whether BMI is more than 35, height, small height, osteoporosis is one go. Single patient, female patient is very common. Small height, small size. Height, BMI is very fatty patients. Small height, osteoporotic patients. Because osteoporosis patients or the issue is the pins. We are looking after some options of the femoral array because we had two disasters. So we might be a little bit of worried about this. Two femoral fractures in the beginning of my careers with the robo. we had 2 fractures with the femoral pins. Right now we modify the size of the pins, 4.5 to 2.5, but still we are little worried because another thing is that very osteoporotic patients, we are not using both the cortices in the femoral area, and I'm using the soft versus approach. When the soft versus approach muscles is very bulky, and you are using only the one cortex of this femur, so when you take the gap checking, it moves. It moves with a little bit of movement. It gives the wrong gap measurement and the wrong assess of your joints. So we have decided. Right now we are still experimenting because anything we can find out to get rid of this fixations of this femoral area is very important. Another thing is that more you go proximal, more there is a chance of proximal femoral might be come across the stress fracture because there is stress riser. Short height is difficult. So that's why you are using, avoiding in such cases doing the robo. So see, from the since morning we are talking about a lot of alignment and this, but these are the conventional alignment. I think most of us accept with this because I'm a gap balancing technique. I'm not using other than I balanced the knees only the acceptable range. What I've been doing it for the last couple of decades. So these are the acceptable range of movements. We will modify, we will rotate whatsoever we play with the both femur and tibia implants. Only this range of movements. No, don't go beyond that in generally. So this is already told, we get the lateral gap first, then we balance the knees on the medial sides and we get the trial implant. So HK axis of the, or we just follow the hip knee ankle axis. The goal is to correct the mechanical axis 3 degree. The tibiofemoral less than 2.5 degree, varus or more than 7.5 degree valgus have increased failure rates. Post-operative varus fail due to medial collapse. So we don't keep the knee lot of varus because there is a chance of medial collapse. Coronal alignment also, we 2 to 7 degree, the valgus, we just respect to the femoral mechanical alignment. And tibial malalignment only 3 degree varus we accept. The component should be placed in the neutral alignment, tibial. This is depends on what type of alignment you are looking for. I am looking for the gap balancing technique, so using that. But the guy who is doing the kinematic alignment or semi-kinetic alignment or mechanical alignment, in that case, you might have to go for this more than that. The slope 6 to 7 degree because I am using CRNE. So in that case, I have to keep the natural slope or at least for 6 to 7 degree slope. So this is the rotational alignment as already discussed. The combined axial rotation, it should be 0 to 10 degree. Is already discussed. It is beyond that. There is some malrotations of this maltracking of the patella. So, end of the day, this has already been discussed. We get this, we can have everything with this. We planned it as per that because we take the minimal cut because sometimes the medial lateral mismatch, sometimes big difference. So, as per that, we go for this one size above because we can come down one size below for that. Go for this. The surgical exposure, you can go for this very much. We can do it the sub-versus approach. It gives the extra edge, and you can go ahead with the cubis with the sub-versus approach. The advantage is that the CRN is the range of movements is very good. Patient can have the normal alignment, normal walk. They can go for the steers up and down. You can early recovery, early discharge. Everything is possible with this. You can go with the CRNE, is a bone preserving, and I think it's good. So, I'll go show you a couple of cases. This is the preoperative patients. This is the sagittal plane deformity, the coronal plane deformities. This is the planning, preoperative planning. So, when it starts with this, after the planning, this is the gap. So, we plan to have this, basically the lateral side, you want to balance it. So, we balance the lateral up. We are not balancing the medial as the Dr. Mohammed Sahil showed. He balanced the medial side also. I'm not balancing the medial side because I will just go for this release of the medial release, and I hope that I can balance the medial half. So this is the when adjustment of the down. In that case, we have sloped the 7 degree slope and we have taken the size 3 tibia. This is the keep the femur rotation 3 degree. Varus valgus 0, flexions, keep the femoral flexions 2 degree. And After the robotic resections, this is the final cut. This is the final 11-11 gate. So even in the 8 and 8, the soft tissue, because we are not considering in the robo the soft tissues, so that you have to taken care of. So is absolutely acceptable the valgus varus 3 degree and the limb around 2 degree flexions is acceptable because you are comparing with the head of the femur, and this is even in the 11 also you can have a very good come across with this 9 mm poly, because it is your clinical science, because it is not only this number, even in the 2 mm up and 1 mm down, even the 11 and sometimes 12 also, you go for this clinically how patient there is any opening medial side, lateral side, and how it is well aligned with the poly, we go ahead this. Even in the 9 mm, 11 mm poly, 11 mm size, we can come across with this 9 mm poly. So this is the post-op X-rays. I am telling you the post-op recovery is very good. Even after 2 months, patient can walk like this. They don't come for the second visit in my hospitals, because we don't put tunica also. We are not operating with tunica, we are not using the soft busters approach and shear knees, and we are not using stitches also, stitchless, no drain. So once I get operated and get goodbye, and they come after maybe a couple of years. If you have problems, sometimes they can talk, otherwise they need to come. So this is another patient's gross varus deformity, both sides. The patient walk like this. The video, I think. It's a pre-op video. This is the deformity. Deformity is the coronal plane 6 degree and the sagittal plane 5 degree, right side. I'm giving you showing you the right side operations. This is the planning. When you put the planning, this is the initial phase. Now we have this, everything is 3 degree, we keep the 3 degree rotations, accelerations. All are 0, only the slope is 7 degree. Now you have to balance it. When you balanced, it is come like that. We balance the lateral half. In that case, we have taken the rotation 3 degree, and this is the valgus varus 0, no flexions, keeping the tibia to. So this is the taken in the limited range. This is the distal cut on the lateral side and the distal cut on the femoral side. It is rate because it is less, but we could have to balance the lateral half, and this medial half is 4 and 4. We hope that we can manage with this release. So this is after the cut. This is 10-10, it comes, it goes well. So we come across with this 9 mm poly. This is the post-op X-rays. This is after 2 months, same patients. Same varus deformities. The 10 degree sagittal plane, 10 degree varus. This is the same, now with the initial stage when you, after balancing. This is the while you start doing the preoperative CT scan planning. So everything is 0, 0. We balanced. Here also the flexion 0 degree, you can see everything is, you can come across with that. And we balanced 8 and 8 and 6 and 5 on the medial side. And this is after taking the cuts by the robo. This is 11, 11 at 10, 10. This is extension is 11 to 10, but we can very much come across with this 9 mm poly. This is the post-op X-rays. Result is very good. Patient have a full range of movement, no need of physical therapy also. I can show you a small clip how we'll do it. This is 11, 11, but we can balance. So message is that even you cannot get the 9 mm gap, if it is the 11 mm gap or 8 mm, 2 mm up, 1 mm down, you can come across with the 9 mm poly. But clinical is very important. It is not exactly the what robo shows. It should clinically, it should be absolutely tight on the extension. There should not be any opening either sides. Because I am doing the CRNE, I used to keep a tight knees. I don't want to put my patients in the absolutely, I prefer to put 2 or 3 degree FFD flexions. I don't want to exactly straight because there is a natural stabilizer there, the PCL is there, it takes its own course, it balances well. And another thing is that in my CRNE, I keep the flexion tight. I don't keep the flexion loose. And if at all flexion I want to little bit of opening on the lateral side because while we flex the knees, it always rotates in the, because the lateral pivot is there. This is natural mechanisms of the knee movements. So the little bit of laxity in the lateral compartment is acceptable, but medial side is not acceptable. Thank you. So robotic assisted allows is a shorter hospital stay and is a good benefits of this Shrivastav approach. Thank you.
So just one question. Any tips and tricks about the tibial slope, especially when you are retaining the PCL? Normally we recommend 5 to 7 degree slope. Are there any incidences where you have reduced the slope while designing with robotics? Implant planning?
Operating the CRNA, you have to keep the
slope more slope.
More slope. Good, less slope, it will avulse the PCL. Because natural slope or 7 degree, but only one thing is there. One is a recurvatum. One is the recurvatum is there. In that case, you can keep the slope less. In that case, you have to take the less distal cut because while using the slope, more slope, you are opening the flexion gap. You are not utilizing the extension is remains and you are opening only the flexion gap.
Correct.
Otherwise, you take the normal tibia cut, it affects both flexion and extension. But increasing the slope, you are increasing the flexion
gap.
Oh. No, if I feel that the PCL is because sometimes osteoporosis is there, sometimes use this only the poly, this, there's a UC poly, ultra congruent poly like this. See, issue is that only both the column should be tight, medial and lateral column. So if it is tight and even little bit of laxity is there, because recently we get the UC poly, previously which I was using, they don't have the UC poly. So I was using only the flat poly. So in the initial stage, couple of years back, when the little bit avulsed, most of the time it is avulsed. So I was little worried. So I took the risk because I don't want to, because once you started doing SEER, it hurts to go for this, convert it to this PS. So, but it works well. Only issue is that both the columns should be intact. See, I'm telling you, you have to choose either both the columns or the PCL. If the PCL is lax, both the columns are intact, you will get rid of this. Otherwise, if the PCL is not there, but their columns is intact, no problem, you can carry on with that. But it is only your skill. It is a little bit of steep learning curve. But issue is that when you start using the CRNE, previously start doing the normal knees, basically don't go for this very deformed because most of the knees are deformed. Once you started using it, then you have the idea how to go ahead with this. Because in the CRNE, you start with the femur first. We take the all cut femur flexion, then you, as per that, we'll go for this tibia cut. But normal standard for TKA, we go for this tibia cut first in that. That is basically John Insall told, why he advocated. They go for the gap balancing. You go for the flexion first, and compared to that, you go for the extensions. So in that case, we go the reverse way. We go for the femur cut first, get the flexion. With that, we get the tibia cut. But it is very safe. I'm telling you, even this surgery is also, none of the cases it damages the PCL. Even the very small tibia, number size 1 tibia, very small tibia. Even I would have been operated manually, I could have damaged little bit of PCL, but tibia is not. Always left a little bit of what Dr. Shekhar shown. Every step, bone island before that part. They're gone beyond that, the soft tissues. Even the lateral part of this tibia, we are little scared of that because the bar is going into, sometimes it very fast, we see that it will damage the patella, never touches, never. So, previously we were scared, we put some, because while you put some sort of retractions, little bit of movement, the robo stops working. So there should not be any movement. So the guy who is holding it, little bit of movement, robo stops. So previously you used to do it, then gradually you will stop using it. It never touches any of the soft tissues in the patellar tendon.
Okay. So if there are no more questions, then we can break for the demo session.
Thank you, Dr.
So,
Shekhar, for this excellent content.